Well, good morning. My name is Dr. Alan Lumsden. I'm the Medical Director for the Methodist DeBakey Heart and Vascular Center. And on behalf of everyone in that center, we want to welcome you to this second annual Vascular Ultrasound Masterclass. The real power behind that is I'm joined at this table by Dr. Zsolt Garami, who heads up our ultrasound lab. And so Zsolt, thank you for putting this together, and I'm going to hand it over to you.
Thank you, sir. Well, welcome everybody. I think we have nearly 300 people registered for this course, and this is why we are here, because you want to continue to learn together with us. And again, what I would like to share with you is that until today, we're still running on-demand slideshows for the last year videos. You have one more day. Please review our protocol and lectures from last year on demand. I would like to have a big thank for our team. Again, without my twins, Christine and Tanya, this conference wouldn't come together. They are the brain behind our schedule and make sure every month we had a planned meeting, and thank you so much for planning. Cicely, thank you for the CMEs. Leanne, thank you for the CNEs. And our interns. And behind the camera, we have our AV crew. Thank you so much, guys. We have a special big thank for our sponsor for Boston Scientific Corporation and Siemens Medical Solutions USA. And we have 4 other companies contributed and sponsoring us. By scanning the QR code between lectures during the break session, you're able to visit a virtual booths, and you're able to see videos and training from each of these companies. Thank you for Digisonics, Fujifilm, Sonosite, Mindray North America, and NovaSignal. Well, this month is really special. This is the Ultrasound Awareness Month. So definitely this is the big anniversary, it's the 58th Medical Ultrasound Awareness Month. So thank you so much for everybody for your hard work. I'm sure that with few slides from the history, I also would like to thank, because our ultrasound lab was really founded by Dr. George Noon and Dr. Charles McCollum, and we would like to thank them for the special contribution for our education. They recently awarded us with some grant to continue our education. And how the lab started, you see Esther and Dan. We would like to wish happy retirement for Dan, but you're going to see Esther on our faculty, and she's going to teach us some very important lessons on carotid scanning. And this is our team when we celebrate the 30th anniversary, and this is our team now. Again, I would like to thank everybody for their hard work, especially they are really working on the front line. Everybody thinks the low extremity venous duplex is a screening study for COVID, so we are doing all our best to really do that. And I would like to introduce my faculty for today. First, again, Dr. Lumsden, thank you so much for your motivation and taking the education to the next level. So I think this studio is your vision, and I think we would like to keep up with your speed, and we would like to keep up with your vision. And our love is definitely shared with ultrasound. I think being a vascular surgeon, you love ultrasound, and maybe you use ultrasound more than your scalpel time to time. And with our ultrasound service, we definitely a perfect match for your operating room. In this picture, you will count at least 5 different robots. So again, a robot not going to replace our sonographers, but definitely the technology is here to challenge us. So our skills definitely in operating room, behind the scene, trying to support with ultrasound monitoring anything what we see on our operating room. And this is where, again, the latest technology, you can see a 3D acquisition that with recording the ultrasound signals, the blood pressure, and also the same time you see the imaging created and linked with a video setting. This is how we can show you what we really do in OR. It's just impossible to invite you everybody in operating room. But by these videos, I think we can really share what is the cutting edge technology capable to do with the proper diagnosis. And these are the images. These are the images what you see on your ultrasound. These are the images what Dr. Lumsden going to create. And for example, here's the carotid body tumor. The day before the surgery, we're going to create a cast and embolization. And during the surgery, we are planning how to really do the incision. And this is again the CT really helping us. In the left bottom corner, you see the CT scan, how it's planning and matching the surgical view in the operating room. Why we like to use TCD, just you can see a little tiny pool on the carotid going to result in waveform changes. Those waveform changes, what we are watching. On the top of counting emboli, this is one of our favorite things to do. And here's you will see the stent deployed, and you see embolization on your TCD. Again, the TCD in real time, linking these two images together, able to tell you how much embolization you really have on the table. And I think what our source is that this is a primary stroke prevention to see that make sure those vessels remain open despite this microembolization. And the technology is here that you can deploy a stent without any embolization. And this is during the TCAR procedure. You can deploy the stent and you do not see a single embolus. So I think emboli is never good, and this is why we monitor. We do not want to see our signal disappearing in front of our eye, and this is maybe a macroemboli, and that macroemboli, what is really taking out this signal, and loss of signal. That is the stroke. There's no tissue can survive behind that occluded vessel. And again, we are really successful to show you how to do a proper CPR. Here you see the hand, and the hand is trying to, again, compress the heart, and with the compression, you don't see too much TCD signal. So that is, for example, what we want to see is like what's the perfusion to the brain really recorded on this TCD. Well, my next speaker will be Esther, and Esther is really my most experienced sonographer. She's only 40 years old, but she has 35 years experience already. And Esther is our technical director of our outpatient ultrasound lab, and she has a special magnet for interesting cases. So when someone doesn't want to take on, this is what we see, and I think on this image what you see, and this is why the ultrasound is really interesting. On the image A, you see an occluded carotid. On image B, you see an open carotid. And you know the difference is that we slightly turn ahead to the left. And this is what I think is stunning in an ultrasound, that you really need to be strong and protecting your ultrasound and believe that what your ultrasound really shows you is correct. Because while the patient was laying down flat and not moving, on the CT and an MRI really showed an occluded carotid. Angio did confirm our ultrasound finding. So be proud and be strong. The ultrasound is here to stay, and definitely one of those modalities that I think with our education we can really teach you all these different waveforms. We're going to talk about waveforms a lot. This is one of Esther walking through a subclavian stenosis, and you see the first signal here. This is the velocity up to 600. And this is where you see the flow is coming through, and she's walking through that color signal, and you see tremendous changes of this waveform, but the end result is what you see in a vertebral artery, and this is what the brain is going to get. So SVU did a very important paper for us to try to really learn more about these waveforms, and this is again, hopefully you're not colorblind. Blue or red, that means that is reversed. Blue, blue, blue going towards the brain. This is how you see a suboccipital vertebral view, and this is where there's no doubt that how you can see intracranially. That's the best way to really image both vertebral arteries, so you are avoiding cross-insonation, and you can really see the end result of that perfusion. And here's one more beauty. When you really see the stenosis picked up on the ultrasound, confirmed on the MRA, and this is again a proposition in the suboccipital area, still a result of the increased velocity, but again pinpointing exactly where your stenosis is very important. And is my favorite case with Esther. Do you feel anything?
Yes.
What do you feel? Patient immediately reporting.
Getting lighter and lighter and lighter. Yeah.
Put your arm down. And in the background, I want you to see the recording, which is the PCA. The label is correct. And when he puts his arm up, his PCA signal goes out. So definitely not just the middle cerebral artery, but the posterior cerebral artery can be monitored. And again, be proud that the MRI, in this case, the angiogram was negative, the CT was negative. And this is one of our special. We have Ponraj from Siemens working us, and this is a colored angio. You can see the arm down, in this case, the subclavian pointing down, arm up, subclavian pointing up. And you see the color differences. This is how the contrast arriving and timed, and about half a second delay arriving to the vertebral artery. You can see the origin stenosis. And I just want to point out one more time, that's the origin stenosis. And again, the positioning on the arm, which is causing the patient's symptoms. Well, I have a special night hawk. I just run into her, 7 o'clock. She was leaving after working all night. Hard day's night is Jay's talk. Jay joined us from GE, and she is doing a tremendous job, not just covering our night calls, but also she is training our satellite offices and hospitals and sonographers. And she is going to take you to the ICU. What are the most difficult waveforms? What are the intra-aortic balloon pump? What are the LVAD waveforms? And here's my example for you. The LVAD is running, and why the LVAD is running, so you see multiple embolization and you see a non-positive waveform. We stop the LVAD, suddenly no more embolization, and the waveform is positive. That is the indirect and direct way to really see that the embolization definitely coming from the LVAD. So turning the LVAD back on, you're going to see the emboli returning. Here you go. Non-positive waveform, and here comes the embolus. And again, we are in Texas. When we see dolphin, that's an artifact. This is how easy to see that if something sitting on a zero line is not moving, the embolus needs to be in the waveform. Hopefully you learned that. And we do use some good bubbles. In Champagne, for example, PFO testing, but definitely the bubbles and emboli is never good. Sheldon is a great dancer, which is talk of dirty dancing. He is going to show you the best leg work, and again, how you really can pick up that stenosis, how you can really show a popliteal artery stenosis, and with the waveform changes showing your post-stenotic waveform, I think you need to learn. And again, what you see on the leg, sometimes in low resistance, is not just a coincidence. Definitely MRI shows you an AVM malformation, and with a low resistance waveform kind of confirms that this is where not just atherosclerotic disease or narrowing can give you this low resistance pattern. So get ready for some fistulas between artery and veins and kind of solve which pulsatile, the artery or the vein. I cannot introduce this speaker, but you're going to have fun because we're going to do Kahoot. My talk is basically lunchtime. We're going to play, and we have an award. We haven't figured out what's the award, but I think we can pitch in definitely some gift and free registration for our next conference. My next speaker is my other lead tech. Sheldon and Stephen is running my inpatient services, and Stephen is truly a magician. I'm so sorry, but he's really my work wife. He is my first backup when I'm doing intraoperative monitoring, and I think we just messaging by telepathy. We don't need to say a word. We really understand each other. And Stephen gonna show you when you see an embolus on a carotid ultrasound, not all the time is coming from that plaque. Certain machines can produce those, and what you see here, that you can monitor with the TCD with different settings, and you can see that how much balloon pump is assisting with your embolization. With a different setting, you will definitely see way much more embolization. Our next speaker will be Joe, our faculty who rejoined us. He was our fellow with Dr. Lumsden, and he loves waveforms. So the waveform never lies, and the waveforms never lie. And this is where we're going to learn a lot, that not the increased velocity, but the shape of the waveform is going to teach us a lot. Here's again, you have a normal waveform become abnormal. Between those two waveforms, you need to find an occlusion. That occlusion is again with the color and with the spectrum needs to be confirmed. So the waveforms is going to be our story. And this is how you see. Don't try this at home, but we are going to occlude the carotid. And you see, this is how the MCA waveform changes. That is a carotid occlusion. And here's your release. And this is the waveform. And please visit the hemodynamic.com for this game. And this is how you see it in real time. This is a carotid occlusion. You see there's no flow here. Here's your blunted signal. Here's your open. And here's your open carotid. I'm going to skip these slides because I'm running out of my introductory time, but I would like to introduce the next speaker. Karen Broadbent worked with us. Now she is coming from MD Anderson, is going to teach us a very important lesson that we are not seeing every day. We asked her to give us the vascular ultrasound talk in oncology. And again, Karen is a queen of our lower extremity venous studies. We can learn a lot from how to properly diagnose this DVT, how you can tell the aging of the DVTs, and what's the best protocol. Definitely, this is your acute one when it's so dark that it's as dark as your lumen. And the compression is a must. And we'll have our top gun. Eric Peden is chief of our vascular surgery, I think a master of our AVF protocol. And I think I'm blocking his number now because when he calls me, that it's always trouble. He called me on this one. There's an increased velocity, and assume that this is an increased velocity coming up from the anastomosis. The lesson, he told me, that after the anastomosis of 200, your velocity is still going up, that's the bad sign. After the anastomosis, you see a second stenosis, and that second flow disturbance this is what he sees, and he calls me, that on angio confirmed it. And if you pay special attention, you see the same narrowing on your ultrasound, and you just need to believe that those numbers are real. And sometimes we say, yes, 3 times is the velocity, give you a 50% stenosis, but unusual location, go with your guts. And again, I think he's not drinking Pepsi Cola these days, but this is the best advertisement I ever seen for Pepsi. I think these are just gorgeous pictures. You can see on the B-flow, this is stunning. But again, this is our Pepsi Cola. I'm so sorry Pepsi did not sponsor our conference. And our final talk going to be a carotid dissection. Christopher was my roommate. Now he's the chief of vascular surgery of next door. And I think the carotid dissection is something that we do not want to see every day, but you need to be ready because not every carotid dissection is as simple as this is, for example, a pseudoaneurysm. And sometimes when you see that looks like a dissection, it's maybe not. Maybe this is just a normal, like a double lumen even on an angio. You can see a double lumen here. It's maybe just an ascending pharyngeal which is running behind your internal carotid, and during the CEA, maybe it was behind the ICA, and as a clamp injury can result of the stenosis and increased velocity in the ascending pharyngeal. But again, this is, again, about 8% of the time can originate from the internal carotid. Well, thank you again for joining us. This was my introduction. I'm so sorry I'm running over time, but I'm ready to introduce my first speaker, Dr. Lumsden, our chairman and the medical director for our Heart and Vascular Center. Please give us a talk.
Well, thank you, Zsolt. I think you've already heard my titles. I do want to make a plug for the International Society of Endovascular Specialists. I'm currently the president of that, and for all particularly the interventionalists who may be participating in this, it's open to all different subspecialties, and it's an exciting group to be part of. So I think what my job this morning is, because I really don't consider myself an expert in ultrasound. I consider myself a collator of different types of imaging. I don't really know how ultrasound works. It's the physics of that. It's a little bit beyond me. But what I really want to particularly focus on is how I take imaging and I integrate it into what I'm doing on a daily basis. Hence the title, Imaging, Imaging, Imaging. There are a number of groups we're one of the biggest Siemens installed in the United States, actually, in fact in the world. And so a lot of research has been done here basically with Siemens, Corindus, I'm just going to show briefly, and Storz. A lot of this audiovisual integration, which we've seen a lot of the recordings from the operating room, is all done really with Storz. So let me move forward. You've already seen this picture. One of the slight challenges when we have a small group is we all share slides together and our pictures kind of pop up all over the place. But this is our operating room. And I used this when I gave a talk in London at the Hamlin Institute for medical robotics. And the question was, how many robots do you see in there? And there's actually really 5 different robots. 3 of them pertain to imaging. And so if I show you the arrow, you're going to hear a little bit about robotic transcranial Doppler. This C-arm here is called a pheno. It is a robotic arm which came off car assembly lines, which allows us really to rapidly move the image intensifier from position to position. In the background is the typical surgical robot, not particularly germane to you, and at the bottom of the table is a remote viewing robot. So when Dr. Garami here is traveling the world, the one big advantage we've had with COVID recently is he's been here, hasn't been able to travel internationally. And so the frequent flyer miles are dropping like flies at the moment, but this was designed particularly so that Zsolt from Hungary, if he happened to be over there, he's never off, we can actually plug in the transcranial Doppler machine or the ultrasound machine into this and transmit that signal to him on his laptop. And we'll show you a little bit about how that actually works. So lots of robots, 5 robots. So I thought I'd walk you through how our workflow happens on a daily basis. We never puncture an artery or a vein on the floors, in the ICUs, or in our operating room without using ultrasound. So the first imaging that's up is usually ultrasound. And for those of you who don't do this, let's introduce you to our world and how we do this.
Typically, we start off by the usual way of localizing the medial side of the femoral head using fluoroscopy. Here we can see a needle or a hemostat can be utilized. And then we switch over to using ultrasound. The ultrasound should be set up in a way that's convenient for you, looking straight at it. Typically, we'll start off by scanning the femoral artery so we get an idea of the lay of the anatomy and see whether there's atheroma. Here you can see calcification in the posterior wall. We can see the bifurcation. And so we know exactly what the common femoral artery is. I mean, we still use a combination of fluoro and ultrasound to make this decision. Here you can see we're scanning and identifying the soft anterior portion of the femoral artery. And typically, we always use micropuncture as a way of access. The micropuncture needle is being brought in with the right hand, and you can see that we're walking it into the anterior aspect of the femoral artery. You can feel this, and you often can see it pop inside the femoral artery. Sometimes you actually really got to pop it in order to get blood return. Here we're getting good blood return, and you can see when I let it go, blood return stops. So we're actually changing the angle a little bit to make sure that we're not impinging on the posterior wall. Once we've got good blood return occurring, and then we take the wire. The wire is then going to be inserted up the hub, and the wire should pass easily and without resistance. If at any time there's resistance, you need to bring in the fluoro and actually look to see what it is. It may be subintimal, it could be going up a side branch. And again, here we can see we've switched over, and you can see that the wire is in the right trajectory. At that point in time, we insert this introducer sheath. We're going to move the inner cannula from this, and this allows us to actually insert an 035 wire, and the wire can then be it can be used to deliver a standard, in this case, 6 French sheath.
So first up, every day is ultrasound on the field to allow us to get access. Transfemoral access, of course, has been done for a long time. What's really new in our field is alternate access. And the entire ability to do that has been predicated based upon the use of ultrasound. And so, for example, if we're going to treat a DVT, patient is placed on their face, and we access the popliteal vein directly. Occasionally we go transpedal, where we can actually stick the dorsalis pedis artery. Very similar to what I'm going to show you here, because increasingly we're using transradial access. And we'll just show you an example of how we do this.
In this video, we're going to talk about a technique probably could be more widely used in vascular surgery world. It's about transradial access. These basically are the learning points for this video, which we'll go through. Indications, some hard indications, softer indications. They're hard indications where you can't get in through the femoral artery for the reasons which are outlined here. But increasingly this has been used for some elective cases, particularly access to the mesenterics, the renals, the supra-aortic trunks. It's not any good for going down below the knee because the catheters and wires are currently not long enough. And you can see what some of the limitations are here.
Radial artery is not an end artery, but you do have to do an Allen test before you start this to make sure that there's communication before you make a decision to puncture the radial artery. It's nice and superficial, so it's relatively easy to compress compared with the femoral artery. Technique involves localizing the artery. We do all of these under ultrasound guidance. We'll demonstrate this. Use a little lidocaine. You don't want to put a lot of lidocaine in to compress the underlying artery. Once you get access with a 21 gauge needle and an 014 wire, it's kind of business as usual. With the exception of you're going to track up through the small artery, and so tortuosity, calcification, spasm are some of the issues we'll talk about. So it starts off really with initial ultrasound survey, just looking for tortuosity, making sure that the artery is patent and there's nothing unexpected in this. It doesn't really matter whether you access this in a transverse or a long axis. We'll run this forward just a little bit. And you can see here's an example, a beautiful example of how this can be done in the long axis view. Here you're actually looking at the long axis of the radial artery. Use a slightly higher frequency transducer. It's one of these hockey-shaped transducers. You can see the needle actually coming in the back wall more than you would want to. You back the needle out, and then you can actually follow the wire. We'll wind it forward here, and you can see the wire actually entering and passing beautifully, coming in and passing down inside the artery, just right there. So the ultrasound is extraordinarly useful for being able to do this. Once you get the wire in, essentially use the skinny sheath. The skinny sheath just means that the ID is great.
So let's just go on from that. So again, first up every day is some sort of access. Access in our hands is always done using ultrasound guidance. Not just the access, also the delivery of the local anesthetic. What used to be done in the past was you'd feel the femoral artery, you stick a needle around it, and you'd inject some lidocaine. Now we can actually use ultrasound to direct where that lidocaine is going. So we make sure that we bathe the entire front of the artery and all the way up to the skin access site. So I want to go on and talk about one of the first people who was hired into our department many years ago happened to be Dr. Garami. Now, why on earth would we hire an ultrasound expert and transcranial Doppler expert into a department of cardiovascular surgery? Because a lot of the work that we do is up in this area, up inside the chest. The heart surgeons, are always working up here. TAVR is delivered up here. We work on carotids, we work on supraortic trunks, and the feared complication is stroke. And so when you go to a morbidity and mortality conference after an open heart case, here's how this conversation will go. Well, the operation went great. Oh, operation always goes great. But the patient woke up and had a stroke. Okay, so that's not good. No, that's not good. So what do you think happened? And then you will be given a list. Well, it might have been when we clamped the aorta, maybe when we punctured the aorta, it might have been there was air in the cardiopulmonary bypass circuit. And the reality is we have no idea when that event actually occurred. And it's almost impossible to troubleshoot what happened unless you know what's going on inside the head. And that's the value of transcranial Doppler. And the value you have with ultrasound, it's dynamic and it's real time. And so we use transcranial Doppler when we're doing anything that puts the patient at risk of stroke. So that, number one, we can get feedback. Hey, there's a big shower went up there. Or hopefully not, we've lost the entire right MCA signal like Dr. Garami just showed you. But it lets us troubleshoot what are the embologenic phases in that operation. And we think it allows us to start refining that operation. Sometimes it doesn't help patient who's on the table, but it certainly helps us troubleshoot what is going on down the line. And the criticisms of transcranial Doppler, because I've talked about this all over the world, and they'll go, okay, that's great. You work in a big rich hospital and you got Dr. Garami. We don't have any of this stuff. And so when it comes down to TCD, the questions are, number one, who's going to interpret it? And number two, who's going to put the head frame on? Very legitimate criticisms. So at least in address, we're going to show you solutions to both of these potential issues. And first one is, who's going to put the head frame on? I'm sure you're going to hear more about that basically later in the day. But this is kind of a new concept of a robotic transcranial Doppler system. That's one of the robots that you see in that operating room, that you put a patient in the head frame and this will autonomously acquire the signal. And I know Zsolt's going to talk a lot more about that. It has search functions with algorithms which are continuously refined to try and find that MCA signal. Why the MCA? Because I want to know when we do X, put a clamp on, deploy a stent here, we want to know what's going on in the head, not what's going on down at that point. In these recording setups that Dr. Garami showed you, we can record what the interventionalist is doing. I deployed the TAVR, and there was a massive shower that took place up both MCAs. So we know that these are temporally related. Right now, one of the studies that is ongoing with Boston Scientific is that they've developed embolization protection devices. Now remember, all the TAVR interventionalists have told you embolization is not a problem, but it is a problem. And if you image somebody's head after TAVR, about 70 to 80% of these patients are going to have DWMRI positive lesions inside your head, little holes in your head. Now, many of you may have enough brain power that you can afford to throw away 5 cubic millimeters of your brain every time you have an intervention. Personally, I'm at a stage in my life where I can't afford any of this stuff. And so what is now happening is a whole gamut of embolization protection devices have been invented. Remember, they've invented them to solve a problem that everybody denied actually exists, but it is a problem, and we are in this world of embolization protection, and the way that you're going to be able to evaluate the efficacy of that is with transcranial Doppler. So I'm going to go forward a little bit, and this is kind of what it looks like in action right here. So the robot can move. Our anesthesiologists, not particularly big fans of this robot because it makes it a little bit challenging for them to work, but nevertheless, this is incredibly valuable information. So solution number one then is, can there be a robotic solution that will allow people who don't have Dr. Garami to actually acquire these signals? Second question is, who's going to interpret these? Okay, so we have the luxury of having many people in our team who can tell us about the TCD signal. Well, and what TCD tells you about, I'm going to make it very simple, he'll make it very complex. It tells you about flow. So the question is flow better than no flow? Pretty easy. Flow is better than no flow. Is emboli better than no emboli? And no emboli is a lot better than emboli. Is more flow better than less flow? Pretty simple. Those are the 3 simple things that transcranial Doppler can tell us. And all of these things can be adjusted to some extent. And so here's an example of Dr. Garami. And we always play this game, where in the world is Dr. Garami monitoring this signal from? These are cameras which are looking down at the carotid endarterectomy that we're doing. We're sending him a signal, and he's talking to us back and forward. And so this ability, and one of the things that's happened with COVID is, again, the criticism was always, you guys have got more money than sense. We can bring in a remote viewing robot, and Dr. Garami can monitor this. But what you've seen in COVID is increasing acceptance of this guy of remote delivery of therapy or remote delivery of monitoring. And it doesn't have to be this sophisticated, but all of these things can be monitored. You don't have to have somebody sitting in an operating room who's telling us what's going on. But it's truly remarkable when you've got somebody who's 3,000 miles away talking to me and saying, "Oh, you better shunt that patient." I go, "Oh." You put the shunt in, he goes, "Yeah, shunt's good, shunt's working fine." It's highly comforting when you're doing something like that. And this is kind of how it works. He's seeing the TCD signal, we're seeing the TCD signal, but really we're focused, on the operation itself at that point in time. And we use it, in this case, we're actually doing a branched thoracic aortic stent graft, highly embologenic. The biggest limitation of thoracic aortic stent grafting as we move around the arch is stroke, stroke, and stroke. And so this is why we're so hot, basically, on the value of TCD monitoring. Okay. So let's kind of move on. Other situation. This is one of my partners. You're going to hear about from him this afternoon, so I'll show this briefly. Is we are a end-stage renal disease center. We have an enormous dialysis access program, largely thanks to Dr. Peden. And ultrasound is used in the office. It's used in the operating room. It's used for monitoring percutaneous interventions. But it all starts actually with the ability to do vascular ultrasound and vessel mapping.
Controlled like a volume button, depth for up and down, generally 2.5 to 3 centimeters, and that we're able to use caliper to measure vessels. Some machines require you to freeze. This machine, just using the caliper button alone, makes it freeze. To go back to a live image, we can hit the freeze button or 2D.
So this was an instructional video that we made because we want all our residents to be able to do that. I'm sure you're going to hear a little bit more about this from Eric this afternoon. So let me now give the philosophical part of this. I really don't care how x-rays are made or how ultrasound is made. What I care about is understanding enough to figure out how I take this and apply it inside our operating room. I did not train in any endovascular procedures. The most complex endovascular procedure we did was take a Fogarty catheter, which got a little balloon on the end of a catheter, stuff it up inside the artery, blindly I would add, blow up the balloon, pull it out, and hope a bunch of clot came out and flow was restored. That was how sophisticated this was. To get a completion arteriogram, we'd bring in a flat plate, stick it underneath the patient, inject dye, say shoot, they take basically a chest x-ray of the leg, they'd run off down to the x-ray department for 20 minutes while you kind of twiddle your thumbs. They came back and they go, missed. We didn't get the timing of the dye with the time we do at the x-ray. We had to do it all over again. And so we've gone from that to be able to create CAT scans basically in the operating room. And if you look at the top right, these new imaging systems that we've got allow us to create what are called cone beam CTs. And if you compare side by side, on the left is a multi-slice CT scan done in the radiology department. On the right is a cone beam CT done in our operating room, and the resolution is almost identical. And so it's the digitalization of imaging which has allowed us to import all of the stuff and to be able to do needle localized guidance. So the reason for doing this in the operating room is so we can stick a needle in it, and so that the surgeon, you would think you'd be able to open the chest and palpate these nodules, but sometimes you open the chest, you can't feel anything. Well, you can't take a whole lung out. So localization techniques basically have become very important in being able to use this. And so I think of this as another visualization tool. Think about it as a surgeon uses their eyes to see what they're doing. Then we got really fancy, we wear a pair of glasses. Unfortunately, I'm now into the glasses mode with age. Then we got really fancy, we put magnifying loops basically onto the glasses. Then we got scopes that we could actually deliver pictures from inside, outside. And then we got microscopes that allowed us even more magnification from both internally and externally. But what we really need in our world is be Superman. We kind of argue whether we're Superman every now and again, but we want to be able to have X-ray vision. And the way that X-ray vision has moved is from those flat plate images to the digital image, which allows us to move these pictures around. We get real-time fluoro images from a CAT scan. We'll show you how we actually use this. Excuse me. And this was my operating room in Emory before I moved down here. And this was highly advanced at that point in time. We had a spinal table we stole from the orthopedic surgeons because it was supported top end and back end. We brought in a C-arm for the first time ever. We could put a foot in the fluoro pedal. We could actually see from top to bottom of the patients. Wasn't great. And we had windows in the operating room. Now we have no windows, so we can see the imaging a little bit better. And we've moved from that to something like this. And it's the digitalization of this, the portability of imaging, which has allowed people like us to actually focus this on in an operation, to maintain the core therapeutic efficacy of the operating room, but trying to minimize the magnitude of the intervention, the physiological insult. And we're very fortunate in our new tower. We own the imaging in the Heart and Vascular Center. That really is very empowering because it means that colleagues like Zsolt, those who run the MR scans, the CT scans, are clinicians who we talk to, tell them what the problem is, and we try to solve problems. And the portability of this data set is very important. This is an example, I've been showing this for years actually, is a dynamic MRI, and it shows you a dissection in the lower abdominal aorta. A huge picture, an anatomical image that we can relate to. It is completely quantitative in terms basically of the flow fields, and it shows you not just one static image. You've known this in the ultrasound world for a long time, but we could get a CT scan or an MR, and that septum in the infrarenal aorta is up against the wall, may not even look dissected, but being able to have dynamic imaging. And so we work, I think, in the most dynamic organ system that exists, the cardiovascular imaging system. In angiography, we've always said one view, no view. You need multiple views to be able to know what's going on. You get a stenosis in one view, it may look normal. In another view, it may look 90% occluded. The same thing is true of static images. We now believe in the cardiovascular space, static imaging is one view, and we got to get beyond that. You've known that for a long time. And imaging and navigation is the bread and butter basically of what we do. I'm going to press the ultrasonographers a little bit to make it anatomical, because I'm a big believer in anatomical imaging. You all have seen these cadaver dissections. Well, this is not a cadaver dissection. This is a CAT scan. And the CAT scans, and I think the imaging has been created to keep radiologists employed. I need, if you make all imaging look like anatomy, then you need an anatomist to actually interpret. I'm an anatomist. And so this is kind of what's called cinematic rendering of a CT image to make things look like they're anatomical. And this is actually a little bit of Hollywood in there, using these post-processing algorithms to make it look like that. Here is an example basically of dynamic CAT scans, now starting to look at the heart beating, the ascending aorta basically pulsating. And recently what we've started focusing on, now you've known this, and this is lessons we've learned from ultrasound. The problem with the ultrasound is you can give me the diagnosis, but my ability to translate your pictures into what I need to do is fairly challenging. So what we need is, this is a type 2 endoleak. So we knew it was a type 2 endoleak. What I need to know is what the inflow-outflow patterns are. And you'll never see this anywhere else. This is something that's really been highly developed here. And if you watch, I'm going to point this out, you're going to see this is a stent graft inside the aorta. Here's calcification in the wall of the aorta. Here's the L5 lumbar artery, and here's an L4 lumbar artery. Well, what am I supposed to do? It's hard to actually get both of these. Which one is the most important one that you're going to deal with? Okay, so which one are we going to deal with? The top one or the bottom one?
Both.
Yeah, ideally you want to take both. That's the answer. But we know what this flow pattern is, and we can actually go ahead basically
Show me an ultrasound and I will tell you which
and
one.
target. So this is, we're running out of time here. So I'm going to close, and this is a situation where, again, all endoleaks are very complicated, and our ability to approach endoleaks, we have to have multiple ways of doing this. This is a nice thin patient. He's got a big aneurysm. The aneurysm up against his anterior abdominal wall. Hopefully his transverse colon is not flattened between the anterior aspect of the aneurysm and where we're looking at with the ultrasound probe, because this is going to be a direct puncture of an aneurysm sac under ultrasound guidance, targeting basically where those endoleaks are actually coming from. Because once I get inside the aneurysm sac, it's not any different from working through the femoral artery. Needle in, blood return, wire in, sheath in, and then off we go. We use catheters and we can wires and all sorts of things. So,
Can you show that on ultrasound at 9 o'clock and 8 o'clock you have the endoleak?
yeah, here and here.
Yeah.
Right there and there. And this is the flashing of the flow coming down through the endograft. So, it's 9 o'clock. I got slides that I could occupy the entire morning. But I think my job is to kind of tease you about the importance basically of what you're doing. I think there are so many things that we learn from ultrasound that change the way we do these procedures, and our ability to incorporate ultrasound into access so that we can do the procedure, evaluation of whether we've done a good job with the procedure is another part I haven't even talked about. And what I wanted to focus on are these pretty complex things where we're using ultrasound to allow us to do procedures that we otherwise could not do.
And I think we did not leave the room until we also confirmed with another imaging modality that ultrasound did not show more endoleak after the managed coiling those branches. So I think that's the strong point, that we are not discussing what is the two imaging modality tells you, but we are in the same room. We are not leaving until the two modality agree. So our accuracy is 100% all the time.
Yeah,
but the ultrasound is always right.
So imaging and applying the imaging has been a big focus for our group. And so we have the luxury of having experts like Dr. Garami, Ponraj Janudrai works for Siemens, the research scientist. This allows us to push the boundaries of this to some extent because we have so much expertise and people that we can tap in and say, you think this is a good idea? No, not such a good idea. Okay, we won't do that. But thank you for the invitation. And
thank you so much. I think we always hand over the best talk and the best videos. And we would like to emphasize, and can you give us a pitch on the videos? Because those videos you showed us, it's also available online.
Yeah, sure. So we have, this is the banner that you see in these slides, the introductory slides is DeBakey Cardiovascular Education. We actually got a big grant about 6 years ago from the DeBakey Foundation actually to build the most advanced cardiovascular training center. We've done that, we have a hands-on training center that's second to none, but what we've also done is built into our daily workflow the ability to record what we're doing. And that is backed up with this audiovisual team and the studio that we're broadcasting out of. All of these videos are posted on the DeBakey Cardiovascular, DeBakey CV YouTube channel. That is free. We probably upload 5 to 10 new videos a week. There's over 3,000 videos on there. You can actually search inside that site for individual topics. And there's about 34,000 subscribers to that. So my message, join the International Society of Endovascular Surgery and subscribe to our YouTube channel. It gets rave reviews and we're very, very proud of it.
Thank you so much, sir.
My pleasure.
And
Thank you.
please send us questions. So we do have a screen, and you probably saw that if you go to the pollev.com and you type in DeBakey, you can ask your questions, or on your phone, if you text DeBakey to the number 37607. And if we cannot get to your question, we definitely will make a written answer to you. Please, at the moment, I do not see any questions. If you guys are awake and you're ready to ask questions, please just text us. I would like to go ahead and introduce the next speaker. Esther Collado is a technical director for our outpatient vascular lab, and she loves cats, and she definitely has a magnet for interesting cases. Esther, please teach us some more tricks.
Thank you, Dr. Garami, and good morning, everyone. So I know what you're thinking, cats. I know nothing about cat vasculature. I know nothing about cat blood flow. So I picked up the phone and said, I'm presenting cats? And Dr. Garami said, no, you're presenting cats. Carotid arterial and transcranial signals. So with a little communication and clarification, let's go ahead and start. So we have a 42-year-old female who presented to the emergency room complaining of chest pain. Her only past medical history was for hypertension and never any type of surgical intervention. She had a CTA in the emergency room, and it demonstrated an incidental finding of a focal saccular aneurysm measuring approximately 3.5 by 2.6 centimeters and descending thoracic aortic aneurysm that filled completely. It arose at the level of the left subclavian origin, but it was separate from the origin and was at the site of coarctation. So here's a beautiful image, and this is our aneurysm, and here's the coarctation. So the patient was admitted 9 days post her ER visit for a thoracic endovascular aortic repair, or better known as TVAR. And they repaired the descending thoracic aorta with a 28 by 120 centimeter covered stent and the innominate artery with an uncovered stent. They dilated the coarctation, and they performed a right carotid to left carotid artery bypass and a left carotid to subclavian artery bypass. And this is the artist's surgical rendition. So just to give you a better visual, which is usually a little bit easier if you can see it, here's the covered stent in the aorta. This is the uncovered stent in the innominate. And from there, you're excluding your great vessels from the trunk. So a right carotid to left carotid artery bypass was performed, and then a left carotid to left subclavian bypass was performed. And again, this is the stent graft in the aorta. This is our innominate stent. So we did a post-op carotid duplex on 11/26/13, which was 19 days post-op, and it was for the indication of a bulging mass at the left proximal neck area. So we did a routine duplex protocol that included the vertebral subclavians and her bypasses. And this is an image of the right side. So this is our anastomosis of the bypass. You'll see in just a moment coming up to the carotid, and then we just followed through to the bifurcation. Just wanted to show the Doppler signals. The one on the left is the right mid-common and internal. And this is our left CCA to CCA bypass, the anastomosis on the left, and then our subclavian to carotid bypass, and Doppler signals from our left internal, which looks slightly delayed. And remember, the right is feeding everything on the left. And then this is an image of that area that the patient was complaining about. You can see this large hypoechoic with a little bit of echoes within it. A beautiful picture of the graft. So it's surrounding the graft and just above the common carotid. And this is a side-by-side dual screen where measurements were performed, and this is our panoramic that was done. And one more image. So we did a vertebral artery Doppler signal, so the right looks normal. The left has this pre-steel appearance, which is likened to a bunny rabbit, right? The ears and then the body. So pre-steel waveform in the left vertebral. So our carotid report was basically she has no disease in her carotid arteries. All of her bypasses are patent, but she has this non-vascular hypoechoic mass measuring 8 by 4.5 centimeters superficial to the left proximal common carotid graft anastomosis. So an IND of this left neck lymphocele was done on 12/17, and a CTA of the neck on 8/13 of 14 demonstrated occlusion of her proximal left CCA and left subclavian artery with patent bypass grafts from the right to left common and left common to subclavian bypass. So the patient complained of syncope and shortness of breath, 11/17 of 14. A CTA of the chest basically said that everything looked exactly the way it was supposed to. There were no endoleaks. And then she came back to 18 of 15 for a 1-year follow-up. And this just demonstrates her grafts that they're all patent again. And signals in her bilateral commons and internals, which all look fine. And again, her vertebral on the left shows pre-steel waveform. She comes back in 2015 for another follow-up. We basically do these follow-ups yearly. And again, everything is looking fine, still with the pre-steel on the left. She comes back in 2016 for her yearly follow-up. And this is color flow at the anastomosis of her bypass graft. You saw at the beginning. We'll let it rewind. Here's the bypass, the anastomosis. This is on the right side, so patent, bypass. And this is her left anastomosis to the carotid, and then her carotid to subclavian, so everything again is patent. And again, just showing you signals in the common internal and external, which never really change. And her vertebrals, again, unchanged. So patent bypasses, vertebral, we have a notch on the left side, pre-steel waveform. We did a TCD also on 5/4 of 16. So TCD, we're going to do the ophthalmic artery first at a depth of 50, and normal flow would be red towards the probe. So we have red on both sides, and then from the same window, we'll obtain the siphon. On this side, we're getting the blue portion of the siphon, which is normal. A siphon can be red or blue. And on the left side, we're getting the red portion of it. And you see there's a little bit of a bruit here, which is just a normal. The velocities are not elevated. And then our MCAs, again, really unchanged. A little bit delayed on the left side, perhaps, in that middle image. And the bilateral ACAs, this one looks a little bit delayed compared to this side, but still values are well within normal. And then our PCAs and across the top here, right and left, and our basilar proximal mid-distal. And our vertebral, the right was easier to get than the left, and the left has lower mean flow velocities and PIs than on the right. So we said low resistant Doppler signals in the bilateral ophthalmic, mild delay in systolic upstroke of the left middle cerebral and anterior cerebral arteries with low resistance, and the left vertebral was poorly seen. 2017, she comes up for another yearly follow-up. Once again, her grafts are patent. And the report is, again, the same, patent bypasses, normal carotids, and the left vertebral was not assessed on this exam. Comes back a year later, 2018, for her yearly visit. All her bypasses are patent again. Same thing with the vertebral. This time we see the innominate stent in the upper left-hand corner, the arrow pointing to the tines of the stent. She has a little bit of a dilatation at the anastomosis on the right side of her bypass to the common carotid, and she has some elevated velocities of 406 in her right subclavian, and you can see the color flow disturbance here also. So this time the report states that there are elevated velocities with disturbed color flow and Doppler signals that might suggest subclavian innominate artery stenosis, and remember there's a stent in that innominate, and also that there's a bit of a dilatation in her right common carotid artery where that graft is sewn onto. CT of the chest was done. It shows patent stent grafts in the transverse arch and in the innominate artery, and patent carotid and carotid subclavian artery bypass. And again, another image of our covered stent and our innominate stent. And she had an in-office visit, 8/28 of 18, and she's doing well. All her bypasses are patent and no complaints. 2019, she comes back for another yearly follow-up. This time she has elevated velocities of 233 at the anastomosis on the right common carotid to left common carotid artery bypass. And this is on the left side of that bypass, and the bottom image is the carotid to subclavian bypass. So the report, again, is basically unchanged other than she has some of those elevated velocities we saw. CT angiograms, again, everything is patent. She comes back in 7/8 of 2020 for a yearly follow-up. And as I'm talking to her and asking her if she has any symptoms, she denies them. No dizziness, no syncope, absolutely no problems, no change. But if you watch this, you see the graft come up and there's no color flow. Here's her native carotid, following it up to the bifurcation. And this is her 7th carotid duplex. So here's her innominate artery stent, and there is color flow in the stent. There are elevated velocities of 250, and this is the bypass at the base of the neck on the right, the common carotid, and it's absent of color flow and Doppler signals. And this is her common carotid demonstrating Doppler signals. I'm sorry, that's her internal carotid proximal, and this is her left proximal internal. So now this is reversed. And her subclavian on the right, velocities of 74.5. Vertebral arteries now going from a pre-steal to a total steal on the left. Reversed. And this is our carotid subclavian bypass distal to where the bypass is, and we pick up low velocities of 25 centimeters per second. Left common carotid is atretic with absence of color flow. There's the bypass on the left side. Again, no color flow. And you can see how small that common carotid has become. Here's the bulb, reversed, color flow. And this is the external on the right side, demonstrating low resistance. It does not come below the baseline like a normal external would. We did a temporal tap just to confirm that we truly were in the external. And then this is our left external, which maintains its antegrade flow, but very, very low velocities. And here's the vertebral on the left side showing the motion clip where you have the vein and the artery both blue going in the artery going in the retrograde direction. So our duplex basically reports that her bypasses are all occluded. She has a patent innominate stent and retrograde flow in the vertebral artery. There's a 26 millimeter difference in the blood pressures. And again, upon re-questioning her, she has absolutely no symptoms. CTA of the chest was done, and it demonstrates her patent arch graft, but we do not see the other grafts. So she had a follow-up, She's doing well. She continues to take her aspirin. She noticed high blood pressure and dizziness for the past few months, and for this reason she came into the clinic. By now she's had a CTA, and it also confirms that all her bypasses are occluded. And at the current moment, there's no indication for surgical intervention because she's asymptomatic. She will return in 1 year for a CTA and carotid duplex and TCD. And on 9/9/20, she came in for low blood pressure of 51/38. Her left arm is aching, and she has dizzy spells now, which are sudden, and they vary in severity, lasting 3 to 5 seconds before she's able to resume her daily activity. And she's not sure if there are any particular movements that exacerbate her dizziness. Her BP fluctuates but remains very low, and she's going to consult, or there's going to be a consult with the CV surgeon and see what the plan is. So that is the end of the first case. And the second case is a man that we first saw in 2009. Actually, he went to the hospital. He's 66-year-old male, and he had cardiac issues with a low EF. And a carotid duplex was done as an inpatient at that time that showed no evidence of carotid artery disease or right carotid artery disease, and less than 50 in the left bulb and internal. If you notice, the velocities are very low on the right, 36/16, and the left 42/20. 3 years later, he's an inpatient for syncopal episode of unknown duration, and now he's progressed to 80 to 99% stenosis of the bulb and internal carotid artery bilaterally. A TCD was performed, and we see siphon signals. On the ACA, it looks like here there may be some cross-filling because we're seeing red all the way across the screen. MCA, he has an irregular heartbeat, obviously, and not looking too terribly bad here on the MCAs. So we said right to left cross-filling of the ACA. The right ophthalmic is not seen, and there's delayed siphon. There's blunted low-resistant left ophthalmic and siphon signals, and abnormal MCA bilaterally with delayed systolic upstroke. He has an irregular heartbeat. So he had a left carotid endarterectomy on 5/15/13, and a right carotid endarterectomy followed 5 days later. And he was he had a carotid duplex on 5/21/13 for a palpable mass with goiter-like appearance of the neck. So here are the images of the area. This is the left. You can see the measurements here. And it was reported as a hematoma. He also has one on the right. So a hematoma on the right and the left with the measurements surrounding the carotid artery. 2 weeks later, he had another carotid duplex for new onset of syncope. And basically, if you look at the endarterectomy sites here, there's satisfactory appearance. Both are patent. And 11 months after the last images I just showed you, he again had a syncopal episode. And this time, the endarterectomies have an abnormal appearance. So here on the right, you can see the superficial wall. It looks almost fluted. And also on the left, color flow is present, and just very abnormal appearing superficial wall here on these patches.
How often have you seen that?
I've never seen this. This is the first time I've ever seen this. And at the time I remember thinking, are they using a new material? If they are, it doesn't look like it's working very well. Just was not sure at all what this was.
You're looking at your image, you're able to see the images 11 months ago, and definitely you see a change
Absolutely.
of the wall and the material. So I think that is, very important point of why you want to look up your previous images. What's your guidance to realize what really happened between this picture and that picture? Thank you. Yeah.
So a soft tissue of the neck was performed on 11/16/14 for a suspected neck mass, and this was 6 months post the carotid duplex. So basically they say minimal fluid is noted at the carotid bifurcation with a measurement, and a second smaller fluid collection is noted, and it was questionable for hematoma or seroma. And the statement, superimposed infection of these fluid collections cannot be excluded, but there is no air or significant fat straining around the fluid collection to suggest it's an infection by CT. And if we look on this side, we see that it comes out to the skull.
Skin.
So it
Skin.
I'm sorry, so it looks a little bit more pronounced on that side. So another carotid duplex was ordered 11/18 of 14, which was 6 months later, and it showed, or he was complaining of a recurrent lump to the left lower neck area, and the swelling had started around August of 2014. It's intermittent, it comes and goes. And here we are again showing this patch on the right, very abnormal looking, with all these ups and downs, bumps, and then also on the left side. And here you can see this area sort of superficial to the carotid artery, abnormal tissue. And in this particular scan, the veins seem to be affected or being compressed. You can see this color flow disturbance, and it narrows down. So this is just the internal jugular vein with very disturbed flow, and then as I move through and distally, it becomes pulsatile as it becomes compressed. So we said no evidence of plaque or stenosis, but the edges of the patches are wrinkled, was the description of the final read. And we described the hypoechoic area superficial to the endarterectomy sites. And at this time, it was questioned whether it was a small AVF creating that disturbed flow within the vein. So he returns 4 months later for a large non-pulsatile lump on the bilateral neck, but it's greater on the left than the right, and now there's a draining nodule on the left. So again, this is our right with our Doppler signal slightly raised. And here again, if you look superficially, you'll see some irregular tissue. Superficial again to the bifurcation. Here it's measured, it's irregular. And again, tissue. And our very irregular patch. This is our vein. And we said on this exam, 4 months later, it was 50 to 79% stenosis in the right bulb. Ratio suggests the lower limit, and a small non-vascular abnormal tissue region noted superficial to the bifurcation. So again, in 4/17/15, he's admitted for difficulty swallowing and a neck mass. And he goes to the ER. He's already been seen 3 different occasions for these neck issues. It's bleeding, quote unquote, per the patient's description, over the left surgical scar now. And there's some purulent drainage as they palpate and press on this area. They think it's a lymph node, a submandibular lymph node. He's got elevated white blood cell count, and they think he's got this mass. So they were concerned for malignancy on the CT scan, but at that time they thought it sounded infectious. They started him on combination antibiotic therapy. ENT was consulted, and the patient was significantly better after antibiotics and steroids. So the plan was for a long-term antibiotic suppressive dose for 1 year, and they did not want to have to re-intervene surgically because of the patient's age. So soft neck soft tissue films were done, and basically just said that there was some folds in the epiglottic region, and CT was recommended. So a CT was done, and on the CT again, you can see now on this side that the irregular mass is coming out towards the skin. So it's bilateral now at this point. So the carotid duplex is done again 1 month later, 4/18/15, and he has elevated velocities at the right distal endarterectomy site, 50 to 59% stenosis on the left, and this time his endarterectomy sites are looking better. And again, a non-vascularized structure, left carotid. So the patch, again, looks irregular. Irregular. And here we measure this area superficial. Again, there's collection. Very abnormal looking patch. So otolaryngology has a consult for persistent cough a month later, and they put him on antibiotics still and feel like hydration, rest, and antibiotics are the answer, and keeping the area clean with soap. So on 1/19/16, 9 months after the last duplex, he comes back with a lump to the right side of his neck that's been there for 3 days. It's been 9 months since we did his last duplex. And again, this irregular patch, this fluid collection, this is on the right, all of this on the right. He has a second area that looks more perhaps fluid filled. No echoes. Here's a posterior approach, and again you see this tissue irregularity, superficial to, and there's the second area superficial to the patch. And again, very, very abnormal looking patches on the left. So duplex again. Again, we measured these areas and reported them. And he gets another soft tissue neck with contrast. So he's got new subcutaneous cystic mass on the right mid-neck laterally. And then 9/25/16, now he's 87 years old. He's going for a wound check to the emergency room. He was watching television and his left carotid artery popped open, is his description, and it started to ooze blood. So he also had difficulty with his right carotid. Sometimes it oozes. He has pain at the site and no fever, chills, redness, or swelling. There has been some bloody discharge from the wound. And he was started on antibiotics again. He visits the ER 9/25/16. He's a poor surgical candidate. He has this chronic infection. It will improve with antibiotics and dressing to the wound, and he's to follow up with his MD. Now he has cough and bronchitis 2 days late, or 2 years since his last ER visit in 2018 now. He's given antibiotics again, and there's been no mention of neck drainage or pain. And the last documented visit was an emergency room visit, 10/1/2000. He's now 90 years old, and he's falling because he has neuropathy, but there is no mention of these draining wounds. So hopefully this is all taken care of with antibiotic therapy. And that's it. Thank you.
Where's my cat? Yes!
Thank you, and stay
I was
safe.
missing mine. Well, thank you so much. I think these were really stunning images, and this is why we wanted to show that something that you don't see every day, but I think the sequence of your studies and gorgeous pictures kind of telling us why you really need those follow-up. I still would like to encourage people to ask questions. If you have anything on the waveforms, if you have any stories to tell, we can open your mic, or you can text the message to 37607 DeBakey, or on the internet pollev.com. Just type in DeBakey. Thank you so much, Esther.
Thank you. Thank you for inviting me.
Well, let's rock and roll and do the hard day's night. I hope, Jay, are you ready? After working hard last night, I hope you're still awake just for another 30 minutes for us, and after you can let to go to sleep. The next speaker is Jay Chang, and the talk is Hard Day's Night.
Are you able to see my screen?
Yes.
Awesome, fantastic. So my name is Jay, and today I'm going to be going over peripheral arterial duplex findings in the presence of cardiac support devices and some duplex findings of related complications. But before we jump right in, I see that we have over a little over 140 attendees right now. So for those of you who are unfamiliar with us, I wanted to give you a little bit of a background of where I work. I work at Houston Methodist Hospital in the Texas Medical Center, which is the flagship hospital of Houston Methodist. And our hospital consists of over 950 beds with 5 intensive care units with over 140 ICU beds distributed between the cardiovascular ICU, the cardiac ICU, neuro ICU, medical ICU, and surgical ICU. So needless to say, we certainly don't have a shortage of patients to scan at any given time of day. And if you missed Dr. Garami's introduction, I work the overnight shift here at DeBakey Heart and Vascular. So most of my patient volume comes from the ICUs and emergency rooms. So I thought it would be nice to give some basic overviews of cardiac support devices and related duplex findings for our newer sonographers who aren't used to scanning them. So since I find myself scanning a lot of patients in critical care units, I've seen a lot of patients on several different types of cardiac support devices to support a wide range of clinical conditions, from heart failure to managing cardiogenic shock or cardiopulmonary arrest, ranging from long-term devices to short-term devices. And these devices include devices such as the left ventricular assist device, the tandem heart, the Impella ventricular assist device, the intra-aortic balloon pump, and ECMO or extracorporeal membrane oxygenation. So today, we're going to be going over arterial duplex findings, specifically in the presence of ECMO, LVAD, and intra-aortic balloon pumps. And as you can see, when we're scanning in the presence of these devices, waveforms are altered from the normal triphasic pattern here that you see on the left to these very atypical waveforms you see on the right, which can make examinations more challenging to perform and to interpret. So we're going to start with our first section with a brief overview of ECMO and some related duplex findings. So ECMO stands for extracorporeal or outside the body membrane oxygenation, and it consists of a combination of a blood pump and oxygenator that provides support of a heart and lung with patients with either severe pulmonary failure or cardiopulmonary failure. So you can see here in this figure, the venous blood in blue being drained by a cannula positioned at the IVC to the right atrial junction, and it passes through the extracorporeal membrane where oxygenation and carbon dioxide removal occurs. And then the oxygenated blood is returned by a return cannula that's positioned in the common iliac artery or the descending aorta. So there's different types of configurations of ECMO depending on whether the patient is on pulmonary support or for cardiopulmonary support. ECMO support is either veno-venous in nature for those who are needing pulmonary support. So that means that venous blood is drained from a vein and then it's returned back to the venous system. Or it can be veno-arterial for those needing both pulmonary and cardiac support, requiring arterial cannulation as well as venous cannulation. And the reason why I'm going over all of this is because before we go scan a patient on ECMO support, it's really helpful to know and understand the type of configurations or the type of ECMO circuit so that we can anticipate where we're going to visualize cannulas in our peripheral duplex evaluations. So both of these configurations can be placed by central or peripheral cannulation. So for centrally cannulated veno-venous ECMO support, blood is drained by the femoral vein drainage cannula, passes through the oxygenator, and is returned to the venous system at the right atrial return cannula. And for peripherally cannulated veno-venous ECMO, the return and drainage cannula are placed in bilateral femoral veins. So drain from a femoral vein, oxygenator, and then return back to a femoral vein. And then, of course, there's another one for veno-venous ECMO where there's a dual lumen single cannula device that's placed in the internal jugular vein or femoral vein with a tip in the IVC or SVC. And then for veno-arterial cannulation, for central cannulation, blood is drained by the right atrium and then returned back to the left atrium or proximal aorta. Whereas for a peripheral cannulation, blood is drained by the femoral vein or jugular vein, and then it's returned by the femoral artery, carotid artery, axillary artery, or subclavian artery. And today we're mostly going to be going over images from the peripheral veno-arterial cannulation ECMO, because it's in these situations where, in the presence of an arterial cannula, our vascular lab gets asked to rule out arterial occlusions for a cold extremity. And out of all the cardiac support devices we listed in the first slide, I find scanning patients on ECMO support the most challenging. This picture here is just a picture I found on the internet. It's not our actual patient from the hospital, but it's a really good portrayal of what a typical room looks like for patients on ECMO support. It's very crowded with a lot of equipment surrounding the critically ill patient, which can present an issue also during our scan because it creates electrical and mechanical signal interference. As you can see here, there are several invasive lines and tubings and dressings obscuring the area where we need to insonate with our transducers. And because of the tubings, we are unable to reposition limbs for optimal visualization. So, and finally, of course, duplex waveforms are changed in response to systemic hemodynamic changes for patients on ECMO support. So it's important for us to stay focused, to identify what information is already known, and understand why we're doing the study. So what is the primary concern and what are we trying to rule out? So now we'll go over some duplex findings, some expected duplex findings in the setting of veno-arterial ECMO, particularly with patients with a peripheral femoral to femoral veno-arterial cannulation. Since, as I mentioned before, we tend to scan more peripheral cannulation patients due to the increased risk of limb ischemia. So you should be able to see the large echogenic cannula within the vessel lumen. And I like to start out with the transverse sweep so that I can quickly orient myself to the vessel location, and also to kind of quickly make sure I don't see any pseudoaneurysms or hematoma formations near insertion sites. It's very easy to miss when you go straight into the long view. And then once we've quickly ruled that out, we continue on to check for patency of these vessels. So here you see the large echogenic indwelling cannula in the left common femoral artery. And you see here the waveform shows a non-pulsatile, near continuous waveform. And when we see this waveform, we want to know if this waveform morphology is due to a cardiac etiology where the patient has poor cardiac contractility, or if it's because we're distal to an obstruction by the indwelling cannula. So it's very helpful to always try and evaluate the contralateral limb that's not cannulated so that we can obtain a baseline, so that we can differentiate whether the cause of the altered vascular waveform is due to cardiac function or due to ipsilateral disease in the cannulated artery. And then due to the large size of the arterial cannula that you saw in the slide before, there's a higher risk of ipsilateral ischemia. So frequently a distal perfusion catheter will be inserted distal to the main arterial cannula in the common femoral artery. So you see here what it looks like outside the body, where you see the main arterial cannula for ECMO at the common femoral artery, and then there's a side branch providing flow into the side port of the vascular introducer down the SFA. And that's what here this duplex finding will look like when you see the perfusion catheter in the proximal SFA. And when you see this, you should expect to see color within the vessel like we see here. And of course, we see, again, that high flow waveforms with no systolic pulsatility. And we see that patency is noted throughout the SFA and throughout the popliteal artery. Also note here, before we move on, how low the velocities are. So make sure you optimize your color and pulse wave Doppler scales for low flow settings, where our velocities here are under 15. Here we see a different patient on veno-arterial ECMO with another left CFA arterial cannula. And we see in this patient that we start out with low resistant waveforms, but here we see systolic pulsatility, which is indicative of the patient's myocardial reserve or cardiac contractility. And of course, we can always compare with the contralateral non-cannulated limb. And we see that here the waveforms are compatible. And then as we continue distally down the leg, we see the perfusion catheter here in the superficial femoral artery, but we don't see any color flow despite optimizing our settings for low flow. And we mostly see noise above and below the baseline and see absent waveforms. We don't see any significant waveforms. And as we go more distal to the tip of the distal perfusion catheter, we start seeing flow being reconstituted. And just remember what this waveform looks like in the left common femoral artery. We're going to move over to the Doppler waveforms obtained distal to the perfusion catheter. So you see there is a notable change in the waveform where both pulsatility is reduced and the resistance is reduced compared to the proximal segment where we saw in the common femoral artery. But remember, we need to prioritize our findings and make sure we're ruling out ischemia. We see that flow is present throughout the remaining visualized vessels. We have a 3-vessel runoff. The tibioperineal trunk is patent. The anterior tibial artery is patent. We have patency noted throughout the tibial vessels. So no intervention was actually taken on this patient until this patient was weaned off to veno-venous ECMO. And then once the cannula was removed, they extracted a large amount of clot per the operative notes. So understanding what waveforms look like when they're distal to an obstruction and comparing to a contralateral side can be very helpful in differentiating why we're seeing the waveforms that we're seeing. So our key takeaway is that in the presence of ECMO, it's very helpful to read through the history and physical and read through the operative notes to understand what kind of configuration the patient has. So we anticipate what vessels have been cannulated, and also, of course, to anticipate altered waveforms that exhibit high flow, low resistance waveforms that may or may not demonstrate systolic pulsatility, and that the presence of pulsatility can depend on the patient's cardiac function, but it can also be due to an obstruction. So make sure you get that contralateral comparison in the non-cannulated limb, and also to optimize for low flow settings since velocities can be very diminished. Then now we're going to be talking about left ventricular assist devices and what our duplex findings look like. So a quick overview for left ventricular assist device. It is used to manage patients with advanced heart failure with the reduced ejection fraction. And the components of an LVAD system can be seen in this figure here on the left, where blood flow enters from the left ventricle through a pump, through an inflow cannula that's surgically implanted at the apex of the left ventricle. And the pump contains a rotor or an impeller which propels blood through the outflow graft into the aorta, into the ascending aorta. So as that impeller rotates at a high speed, blood is continuously moving from the left ventricle to the aorta. And since the LVAD is continuously removing blood from the left ventricle, the difference between the end diastolic and end systolic volumes become minimal. And that's going to be key in understanding why our waveforms look the way they do in the presence of LVAD. So in the presence of LVADs, we can expect altered Doppler waveforms, and they are very dependent on a number of things, including the type of device that's present, on the type of pump that's present in the LVAD, as well as device settings such as pump speed, and of course, the patient's myocardial reserve. So here, we see varying appearances of waveforms, peripheral arterial waveforms in the presence of an LVAD. And depending on the type of pump, the pump speeds, and the myocardial reserve, you can see varying degrees of acceleration times and how the upstrokes look in these peripheral arterial waveforms. So notice how in the first column, we see very monophasic waveforms with almost a tardus parvus appearance. The word tardus refers to a slow systolic upstroke or increased acceleration time. And acceleration time is calculated using the slope from the start of systole to the early systolic peak. So you're going to see this big delay in a long slope. And the word parvus in tardus parvus refers to a decreased systolic velocity. LVADs are also known to increase end diastolic velocities as well. So when we're doing these Doppler acquisitions, we actually just keep the peak systolic velocity measurements on for the calipers and get rid of the end diastolic velocities. So we don't take that into consideration as a criteria. And then here in the second column, we see a greater upstroke or decreased acceleration time compared to the first column. And again, this can be dependent on the type of pump that's present or the pump speed settings or the patient's myocardial reserve. And then lastly here, we see a waveform that is continuous without any, we can call this aphasic with no systolic peaks. And this can be seen in patients with no myocardial reserve, where that left ventricle is simply serving as a canal and all the blood is being pumped by the device. So you don't see very much pulsatility in this waveform at all. So these are all expected waveforms in the presence of LVAD. So you can expect varying degrees of delayed acceleration time, decreased peak systolic velocities, increased end diastolic velocities, which all give that appearance of a low resistance waveform. And we may, or again, may not demonstrate systolic pulsatility. And then this is the last device we're going to cover, which is the intra-aortic balloon pump. And an IABP is a temporary support device that's used to augment coronary artery perfusion and reduce myocardial oxygen demand. So it's used for acute myocardial infarction, cardiogenic shock, and different forms of cardiomyopathy. And it is typically inserted by the femoral artery and advanced to near the origin of the left subclavian artery here. And the balloon is mounted on a catheter and it is connected by an external drive line to a control unit that you see here. This is a system for helium transfer and computer control of the inflation and deflation cycle. So the balloon inflates with helium during diastole and displaces blood and increases arterial pressure in the ascending aorta to yield increased coronary artery perfusion. And during systole, the balloon is deflated, creating a suction at the aortic root, pulling blood from the ventricle into the aorta. So with arterial waveforms in the presence of an intra-aortic balloon pump, they have a very unique waveform morphology where you'll see two antegrade systolic peaks for each pulse. The first systolic peak here that you see with the blue arrow represents intrinsic left ventricular contraction or unassisted systole. And the second peak here that you see in the red arrow reflects early diastolic augmentation due to balloon inflation or forward flow from the balloon inflation. And you will commonly see this reversal after the second augmented peak, which reflects balloon deflation, seen here by that yellow arrow. And since we're seldom able to turn off the IABP while intunating vessels, velocity should be obtained from that first non-augmented peak, from that unassisted systole. And we have to make sure we keep our measurements consistent throughout our exam, in any given exam. There's additional things that we can go over when it comes to IABPs, including frequency and sequencing of the inflation and deflation and associated waveform changes with that. But I want to make sure today that we have enough time also to go over duplex findings of other complications. So we're going to move over to the next slide for the sake of time. So mechanical circulatory support devices like ECMO, the ventricular assist device like the IABP, or even like the Impella ventricular assist device, they can all be inserted percutaneously. So there can be access-related complications like pseudoaneurysm and hematoma formation, dissection, iatrogenic AV fistula formation, and of course, thrombosis or ischemia. Since ultrasound is such a portable, readily available modality, we are frequently called into the critical care units to evaluate for vascular injury. So I have a slew of images that I wanted to go over with you for complications. So here we have a patient status post impella insertion by the axillary artery. The impella is a percutaneously inserted ventricular assist device. And our care team ordered an upper extremity arterial duplex to rule out hematoma or pseudoaneurysm formation as the patient's hemoglobin levels were dropping and it continued to trend down. So here we see an echogenic catheter within the lumen of the distal subclavian or axillary artery. And color flow interrogation shows no significant flow. We just see a lot of artifactual signals, but no flow within the lumen of the artery. We also see a presence of an hypoechoic structure surrounding the catheter, and color flow interrogation shows no flow or no vascularity within this hypoechoic area, which is indicative of a hematoma rather than a pseudoaneurysm. Doppler investigation at the proximal subclavian artery shows very high resistive waveforms that can be described as a pre-occlusive thump or staccato or knocking waveforms. They're all words to describe high resistance with little diastolic flow. And this is typically seen immediately proximal to an occlusion. And then continued investigation of the right subclavian artery, we see a lot of mechanical noise, but no significant Doppler signals. And contralateral comparison shows mostly normal triphasic looking patterns, consistent with an occlusion at the segment where that impella device is, the catheter. And then we continue down the arm, and further investigation shows that flow is reconstituted at the brachial, radial, and ulnar arteries with monophasic waveforms consistent with waveforms that you see distal to an obstruction. And then here we see a different patient, status post axillary IABP removal. We were called to rule out a pseudoaneurysm. The patient had increased bruising and a grossly visible expanding hematoma in the axillary fossa. So an arterial duplex was ordered, and here we start with a transverse sweep down to the axillary fossa, and we see a hypoechoic structure pop out anterior to the axillary artery. And color flow shows vasculature within this hypoechoic area. And turning long on it shows a to and fro color flow, showing a vascular structure arising from the axillary artery in both transverse and long views. Pulse wave Doppler shows to and fro waveforms consistent with the pseudoaneurysm neck. And we see also in B-flow, which is a non-Doppler technology, we're able to see we're able to evaluate vasculature in the entirety of the image without a color box. And we see that we are taking measurements here because it's a grayscale evaluation. We have better spatial resolution rather than being limited to overestimating the size of the neck from color bleeding. And because we're not limited to a region of interest box, we are able to see how far this pseudoaneurysm expands. And we see that it's poorly defined as we move down the arm. Here we see two different patients with two different types of femoral pseudoaneurysm, status post femoral artery axis. So on the bottom here, we see a more complex appearing pseudoaneurysm with transverse sweeps. We show areas showing intraluminal echoes and hypoechoic areas with vasculature. We see that it's a very large structure originating from the common femoral artery, which is posterior. And then up top, we see a very simple pseudoaneurysm arising from the common femoral artery. So they can have different appearances. It's also helpful to use, when you have these complex, large pseudoaneurysms, it's very helpful to use a curvilinear transducer because it has a wider field of view than a linear transducer. And then, of course, color flow and Doppler interrogation shows that to and fro waveform consistent with the pseudoaneurysm neck. And color flow and B flow demonstrates a pseudoaneurysm with multiple interconnected sacs. And then, of course, anytime there is access, percutaneous access, we are always at risk of creating iatrogenic AV fistulas. They can result from the puncture of an artery and vein with a direct communication between the injured vessels. So you'll see a significant pressure gradient resulting in a focal area of significantly increased velocity at the site of the AVF. So here, we start with the evaluation of the left axillary artery, and we start seeing lower resistance waveforms than expected. A quick contralateral evaluation of the right axillary artery shows much higher resistance waveforms. And then we continue down the arm, and we see this color bruit when we sweep in the transverse plane. And this is a very good clue that we can see in the presence of AV fistulas. That color bruit is actually resultant from tissue vibration or perivascular tissue vibration that creates a detectable Doppler shift. So I always like to do a transverse sweep whenever we're looking for arterial injury. Here we see that perivascular tissue vibration again, or that color bruit. And then interrogation of the vein shows disturbed pulsatile arterialized waveforms. That's adjacent. And we're actually able to demonstrate that jet coming from the artery into the vein. And that jet demonstrates even lower resistance waveforms at that site. And color direction shows flow going from the artery into the vein. So I hope that was helpful. Here are my references. And as Dr. Garami said, I was at the hospital all night scanning. So you see it is well past my bedtime. But thank you for paying attention.
Jay, thank you, thank you. Please type in any questions, even in the chat room on the Zoom meeting. And if we can get to your question, we'll answer it in the chat room or by sending you an email. My next speaker is Sheldon. Sheldon is my lead tech in our inpatient service in the vascular ultrasound lab. And he's a great dancer. He's going to show you his best dancing moves and the lower extremity arterial protocol. Sheldon.
Thank you, Dr. Garami. My name is Sheldon Boston. I'm a registered cardiac and vascular sonographer. My topic today is dirty dancing, my best leg work. I have no idea why that's my topic, but we'll try to make it work. I have no disclosures. We are a 24-hour vascular ultrasound lab. We are accredited, at least 18 full-time vascular sonographers. In 2019, we performed at least 18,000 vascular ultrasound exams. Perform a variety of modalities that include arterial duplexes, venous duplex, as well as carotids and TCDs. Today, I'm going to discuss evaluation of the arterial duplex system, system of the lower extremities. Evaluation of the lower extremity arterial system it includes duplex imaging as well as non-imaging vascular testing. Duplex imaging is actually what we consider to be ultrasound. It is basically imaging of the lower extremity arterial system, whereas physiologic or non-imaging arterial testing involves continuous wave Doppler signals to assess lower extremity arterial blood flow. Indications for these exams include claudication, gangrene, lower extremity ulcers, limb pain, critical limb ischemia, and also cold sensitivity. Mechanism for diseases includes emboli, pseudoaneurysm, arterial dissection, entrapment syndrome, extrinsic compression, as well as vasospasm. Location of disease, it can be in a variety of areas. Location could be focal or diffuse. Focal area meaning a small area, or diffuse meaning long segment disease. It can affect multiple levels. Distal superficial femoral artery being one of the most common areas for obstruction, And common location also include arterial bifurcation. Plaque and lesion characteristics. Diffuse plaque, again, being long segment of the artery lined with plaque. Also, less than 50% diameter reduction at any point. Calcific plaque being highly reflective with acoustic shadowing. Occluded being complete blockage of the arterial system, as well as mobile thrombus being debris within the lumen, which is poorly adhered to the vessel walls. There are several contraindications for the arterial duplex arterial exam. There are also limitations as well. One being patient with extensive bandages or cast, poor visualization of the artery due to depth, secondary to obesity or edema, patients who cannot be adequately positioned, as well as diffuse wall calcification, which causes acoustic shadowing in the artery, makes it difficult to visualize the artery. So the tools that we use to evaluate the arterial system in the lower extremity, again, it can be digital or analog. Digital being the probes that we use for duplex machines. It includes 8 to 15 megahertz linear probe used to perform various ultrasound exams. The other being analog, this is continuous wave bidirectional probes to obtain analog signals for segmentals and ABIs. So the arterial physiological study, non-imaging, indicates approximate location of significant obstruction. You cannot visualize the arteries with this test, so this is just non-imaging. It provides an objective baseline to follow progression of disease. There's the ABI exam for this that we're going to cover today. The ABI only evaluates the presence and severity of arterial obstructive disease. ABI should be combined with segmental pressures, volume pulse recording, Doppler waveforms, and duplex imaging to determine the location of disease. Indication for these exams are follow-up on abnormal ABI, limb pain at rest, claudication, preoperative cardiovascular evaluation, follow-up after revascularization procedure, as well as non-healing foot ulcer. And here are some of the equipment we use to evaluate the lower extremity with non-imaging. This is the Pax Flow Lab, as well as the probes that we use with blood pressure cuffs, digit sensors, and toe cuffs. The ankle brachial index exam that we combine with the duplex exam is performed with every arterial duplex per protocol, unless contraindication exists. For the technique for this exam includes, begin with patient being rested for at least 5 minutes. Appropriate blood pressure cuffs are placed on patient ankles and arms, being 10 to 12 centimeter bladder above the medial malleolus. Locate posterior tibial artery, obtain waveforms using continuous wave Doppler signals, and record multiple waveforms representative of the posterior tibial artery. Then we inflate air into the pressure cuffs, at least 20 to 30 millimeters of mercury greater than the last audible sound. Cuffs are then deflated slowly until the first audible signal returns. Then we move on to the dorsalis pedis artery and repeat this procedure using continuous wave Doppler signals for the dorsum of the foot. Record multiple representative Doppler waveforms for the DPA as well, and obtain bilateral brachial artery pressures. The ankle brachial index is calculated by dividing the ankle pressure by the higher of the two brachial arteries. Here's an illustration of the ABI. As you can see, cuffs are placed on both ankles. obtain waveforms using non-imaging continuous wave probes, 4 megahertz or 8 megahertz, 4 megahertz for obese or deep vessels, 8 megahertz for normal patients. We also obtain PPG waveforms for the digits, that being the toes, as well as perform the TBI. Here's an illustration of PPG sensors as well as digit cuffs to obtain brachial index. So what's the reason for digit pressures? Pressures reflect overall obstruction in the arterial tree proximal to the digits. Does not appear to be affected by incompressibility. Also, toe pressures exceeds 30 millimeters of mercury spontaneous. Whenever it exceeds 30 millimeters of mercury, healing occurs in most cases. If it's less than 30 millimeters of mercury, chances of healing decreases with pressure value. Here is an illustration of the complete segmental pressure exam where four cuffs are used on the lower extremities as well as the brachial artery. So one of the main things we evaluate whenever performing these exams are the waveforms. Waveforms can either be triphasic, that being normal, biphasic, or monophasic. Normal waveforms are demonstrated by strong forward flow with a sharp upstroke in systole followed by flow reversal in early diastole and additional short pause of forward flow. Biphasic demonstrates forward flow in systole as well as reverse flow in diastole, whereas monophasic, that being abnormal, demonstrates complete loss of waveforms and reverse component. For the duplex exam, we use a ultrasound system. There are various manufacturers. We are multi-manufacturer facility. Exam may require use of high frequency probes at 8 to 15 megahertz, ultrasound gel, towels for cleanup, as well as a Pax flow lab for ABI testing. Components of duplex. Basically, it's an ABCD. A being anatomy, B being beam mode, C for color flow, and D for Doppler. And what are these? Basically, grayscale imaging is what we consider to be ultrasound. It is what you see whenever there is a baby or whenever there is a fetus. Color flow is actually blood flow color flow is superimposed over blood vessels moving throughout the arteries, and spectral Doppler waveform demonstrates the flow characteristics in the lower extremity. For interpretation of the lower extremity arterial duplex, we assess plaque location and plaque characteristics, peak systolic velocities, and flow direction. Increased velocities with reduced luminal reduction is followed by waveform changes. We also use indirect signs to evaluate hemodynamically significant lesion in the region where proximal velocities are technically difficult to obtain. Changes include spectral Doppler waveforms from one segment to the next, triphasic to monophasic in most cases. Comparison of the arterial waveforms in the contralateral extremity also as well. And here are some of the waveforms that we evaluate. The first one being triphasic, second being biphasic, and the third being monophasic. Again, triphasic and biphasic can be considered normal, however, monophasic is abnormal. Triphasic again, bi, and mono. Poor blunted waveforms showing the loss of sharpness in the systolic and lack of reverse diastolic element. For the lower extremity arterial duplex, the patient is placed in a supine position with the legs externally rotated. We begin the exam at the common femoral artery, moving distally in a sagittal plane. We record and obtain grayscale and color flow Doppler images while moving distally down the leg. Images are recorded from the common femoral artery, superficial femoral, profunda femoris, popliteal, peroneal, and tibial arteries. Again, we measure peak systolic velocities, and Doppler waveforms are obtained using a 60 degree or less angle parallel to the vessel wall. So here is an illustration of, this is a model basically having an arterial duplex exam being performed. As you can see, you begin from the common femoral artery, move into the profunda femoris, superficial femoral artery, sorry. Then we move to the popliteal artery, posterior tibial, peroneal arteries, and anterior tibial artery. Towards the end of the exam, this is what the lower extremity arterial tree should demonstrate during a complete arterial duplex exam. For normal findings, we expect it to have smooth intimal lining. The artery should be free of intraluminal echoes. Doppler velocity recordings should be within normal range. Triphasic Doppler waveform should be expected. Color flow Doppler should fill the entire lumen. Peak systolic velocity should be within normal limits as well. As you can see, the normal limits for the external iliac artery, common femoral artery, femoral, and popliteal artery. Here's the interpretive criteria we use for evaluating disease in the lower extremities or in the arterial system. We use the ratio to stenosis criteria. These are published criteria that we use in our department. However, the criteria may vary according to the vascular ultrasound laboratories. For abnormal findings, we evaluate the presence of plaque, what type of plaque it is, focal or diffused. Velocity acceleration over a stenotic lesion, 2-to-1 ratio followed by post-stenotic turbulence demonstrates a 50% or greater stenosis. Waveforms should be evaluated as well. Monophasic Doppler signals demonstrate reduced pulsatility and blunted upstroke. Total occlusion of the arterial system should demonstrate absence of color flow and Doppler signals. Collaterals may be visualized proximal to the occlusion as well. Here is the disease to diagnostic criteria correlation. You can see that there is a calcified vessel. The ABIs on this vessel should be greater than 1.3. Doppler waveforms sometimes may be unaffected. For normal vessels, ABI should be within 0.95 to 1.3, as well as toe brachial index should be greater than 0.60. Mild PAD, 0.80 to 0.94. Moderate, severe, and as well as ischemic PAD being less than 0.30. For color flow imaging, for stenotic lesion, color flow imaging should demonstrate disturbed flow proximal to the stenotic lesion. As you can see over here on this image, flow could be laminar prior to the lesion. However, within the lesion, color flow becomes disturbed with increased velocities as you walk the sample volume throughout the vessel. This is duplex imaging of the arterial stenosis in the distal SFA. Velocities are well over normal limits, exceeding 364 centimeters per second. For arterial occlusion of the artery should be represented when there is no flow detected by color or spectral Doppler. Staccato waveforms often suggest downstream occlusion. These are blunted Doppler waveforms that are not reflective of monophasic or triphasic waveforms. We recommend using flow in the adjacent vein as a guide to identify an occluded artery, always confirmed by placing Doppler samples within the vessel of the lumen. Large collaterals can also be identified near proximal occlusion or the distant end of occlusion. Mechanism of disease. Disease can be, there could be a number of diseases in the lower extremity artery. Plaque being one of the most common, calcified plaque as demonstrated here. This is the common femoral artery extending to the profunda femoris, and as you can see, there's calcified plaque noted throughout the artery. Also, collaterals may be seen exiting the posterior tibial artery near 90-degree angle. We also evaluate stents and graft. Interpretation of this stent, of the surveillance include disease location, extent, severity, and if possible, etiology should be described as well. Graft velocities may vary with diameter of the conduit. Velocities should be greater than 40 centimeters per second. Greater than 50% stenosis is signified by a focal color flow disturbance. A ratio of 3.0 to 4.0 suggests 50 to 75% stenosis. Ratio of 4.0 could suggest stenosis greater than 75%, absence of color flow, and Doppler signals. Occlusion should never be based on color flow alone. Always confirm with pulse wave Doppler. Types of graft material. Graft material could be synthetic or autogenous, that being vein grafts, modified biologic grafts, which include bovine, cryopreserved, staphylococcus vein. Evaluation of the bypass graft or stents. Evaluate stents or grafts for structural abnormalities. Always walk or scroll Doppler sample through the stents on a graft to evaluate for changes in velocities. Record and measure peak velocity in longitudinal plane using pulse wave Doppler. Doppler angle should be less than 60 degrees. Also determine classification of stenosis according to laboratory diagnostic criteria. Grafts can be located between any two vessels and are named from the two arteries they connect. Examples of grafts surveillance include aortoiliac, aortobifem, femoral to femoral, fem-pop, or fem-tib. Locations, again, aortobifem, as you can see on this image to the far left. Aortoaxillary is the middle image, and femoral to popliteal bypass graft. Arterial bypass graft surveillance protocol. Always scan in sagittal view with grayscale, color flow, and pulse wave. Evaluate from the inflow artery, proximal native artery, proximal anastomosis, proximal graft, mid-graft, distal graft, distal stenosis, as well as outflow vein. Interpretive criteria for the grafts are slightly different from the interpretive criteria of the native vessel. Velocity should be less than 40 velocities less than 40 centimeters per second suggests impending failure of the graft. Stenosis in the femoral popliteal segment of a graft. 80% instant stenosis is signified by peak systolic velocity greater than 275 per centimeters. For arterial stent protocol, which is similar to graft evaluation, again, evaluate inflow arteries proximal to the stent, proximal stent, mid-stent, distal to stent, as well as outflow native artery. And here's an illustration of flow of integration of a stent. As you can see, grayscale, color flow, and Doppler signals. This is an illustration of an occluded stent. This is the superficial femoral artery. Color flow demonstrates absence of flow throughout the artery, whereas there's venous flow beneath the artery in the femoral vein. Surveillance of an aortobifem graft. This is the distal limb. This is grayscale imaging to the left and color flow, as well as Doppler signals beneath. Color flow of within, there's also an aortoaxillofemoral bypass graft, which extends from the axillary artery to the femoral artery. Again, grayscale, color flow, and Doppler signals. Graft failure. Occlusion should never be based on color flow alone. Always evaluate grafts using pulse wave Doppler. Vein graft less than 40 centimeters per second suggests impending graft failure. Also, there is we evaluate for mobile thrombus. It's the most commonly reported source of low extremity emboli is from the heart, accounting for 55 to 87% of events. Diseased aortic walls with complex plaque can be a source of emboli as well. In this case, this demonstrates mobile thrombus throughout the popliteal artery. Grayscale demonstrates intraluminal thrombus through the artery. Color flow is absent. Again, distal popliteal artery, intraluminal debris throughout the popliteal artery. Here is a case of a pseudoaneurysm. Pseudoaneurysms are false aneurysm, which forms due to trauma to the arterial, to all three layers of the arterial wall. Pseudoaneurysm usually develop with it. In most cases, they develop near the common femoral artery after percutaneous intervention. Here's an example of a pseudoaneurysm with B-flow imaging. This is the femoral artery. And there's usually a characteristic to and through Doppler waveform pattern that's apparent from the neck of the pseudoaneurysm. Again, color flow. This is the femoral artery being the source of the pseudoaneurysm, and an active neck with to and fro waveforms. This is a partially thrombosed pseudoaneurysm from the right groin, common femoral artery. In this case, this is a traumatic atriovenous fistula with pseudoaneurysm from the common femoral artery. Here is traumatic. This is traumatic AV fistula is an abnormal connection between the artery and the vein. Here you have the common femoral artery and the common femoral vein with a communication channel in between. Low resistance flow is usually seen supplying in the supplying artery or the inflow artery. There's also a high velocity arterialized waveform in the draining vein, which is the common femoral vein. Again, color flow disturbance and the communication from the common femoral artery to the common femoral vein. Most frequent iatrogenic lesions are caused by percutaneous interventions such as renal biopsies, cardiac catheterization, and orthopedic procedures. There's also popliteal aneurysm. This is also one of the cases that are usually found on arterial duplex imaging. Popliteal aneurysm are associated with abdominal aortic aneurysms with an incidence of 40 to 50% of the time. Also, popliteal aneurysms, they account for at least 85% of all peripheral aneurysms. So, grayscale imaging, the dimensions are actually much greater than the normal dimensions for the popliteal artery in this case. And color flow and Doppler signals are present throughout. However, there's also intraluminal debris noted within the vessel walls. B-flow imaging does demonstrate color flow disturbance within the artery. This is specific to certain equipment. Color flow also demonstrates flow disturbance within the artery as well. And sagittal view of the vessel does demonstrate it's actually fusiformed. Also, again, there's popliteal aneurysm. In this case, it's obstructed. Approximately 30% of untreated cases experience acute thrombosis and distal embolization with the risk of possible limb loss. Here's a popliteal artery with heterogeneous echogenic material filling the artery. Absence of color flow and Doppler signals within. and Doppler waveforms are absent throughout. In conclusion, the arterial system of the extremities can be evaluated using several different testing modalities. Several factors may determine the appropriate method of evaluation as patient history, patient conditions, symptoms, surgical history, as well as previous findings. Indications for various arterial testing modalities may include PAD, claudication, acute limb ischemia, and traumatone artery. Here are my references. This is the end of my presentation.
Thank you, sir. Thank you, and your talks already triggered more questions than we had before. So I would like to have some few questions for you. We have a political attendee called Anonymous. He's afraid to show his name, but willing to take his questions no matter what.
Okay.
His first question, let's go backwards. Would an ABI still needed after an arterial duplex on a patient with a heart assistant device such as LVAD and ECMO?
For ECMO cases, I don't think that ABI would be possible. The velocities, the waveforms are just way too low for ABIs. The Doppler, continuous wave Doppler signals almost sounds monophasic, somewhat venous flow-like on ECMO patients.
Mm-hmm.
For LVAD, there are different types of LVAD. LVAD, it all depends on the settings. Various settings it is possible to obtain ABIs and complete physiologic exams with certain LVAD cases.
Yes, I would like to confirm that because I'm reading them. So this is actually in the heart transplant protocol that you need to provide a carotid and PAD screening.
Yes.
And we are doing all those studies. The second question from the same person is otherwise normal study, but monophasic flow in a distal leg vessel. In what scenarios would you consider that normal?
This would not be considered normal if it's monophasic flow in the lower extremity.
Yes, I would like to have one funny answer for the nameless guy though. So think about you're in Alaska, North Pole, wearing a warm boots.
Okay.
If you remove those warm boots and you have a nice distal dilated vessel, you will have monophasic flow. So those are the things that we can have in normal scenarios. We can definitely say waveform never lies.
That is true.
The question is that he's really twisting us, making it otherwise normal study.
I do.
But you have a monophasic waveform. So this is where the twist needs to be a physiological answer for him. But I agree that in a moment you have a monophasic thing and your systolic upstroke disappeared. That telling us that you need to search for more proximal signal. You need to find and identify that spot where the disease is really taking away your systolic upstroke. And I think that's the message. But when the question is if we have a normal study.
Normal study. In a setting of hyperemia, it may be normal if it's hyperemic. But
yes, and also I would say that we have certain bypass cases, normal blunted signal or non-pulsatile signal. We see it with the LVAD. So I think certain non-pulsatile, yes, would be a normal study, but it's a monophasic signal because you have a LVAD or heart assistant device. Next question, why the patient needs to be arrested for 5-10 minutes before the test?
Patient should be arrested because patient just came to the lab. You do not know if they ran to the lab. You do not know what conditions they came to the lab in. So you want to get the best resting values. You allow them to sit and rest for at least 5 minutes in order to get the resting values.
Yes, and then we do have a certain study when we have this is your resting physiological studies, and then how you perform the exercise one.
Exercise patient should be walked on a treadmill for at least 5 minutes at an incline of about, what's the incline again? 2% incline? 3% incline? Okay, yeah.
And then after 5 minutes, you still want to see them going back to the resting normal.
Yes, you want to gradually obtain values until it goes back to the baseline levels.
Thank you, thank you. Contraindication for your physiological studies.
Contraindication, bypass grafts, DVT, thrombus in the arterial system, pain, open wounds, ulcers. Yes, those are all contraindications.
Do the graft or stent in a leg pose contraindication for doing segmental pressure?
Yes, grafts and stents do pose contraindications.
The graft, but not the stent. Stent too?
Yes, stent as well. We do not do physiologic and stent with patients with stents.
Okay. Regarding AV femoral fistula, what's information that the vascular surgeon can demand from a sonographer in order to surgical treatment?
Most likely volume flows. This is a patient with that went into acute respiratory failure following intravenous surgical procedure, which created this traumatic AV fistula.
Yeah,
so
I think it needs to be specified as traumatic versus we do have when you run out of upper extremity access.
Yes.
You do have femoral AVF we have to create. But flow volume is our number one.
Yes.
For the traumatic, I think it's really important to really confirm the venous flow pattern. I think that's the venous flow pattern and the exact site of the location where almost we can mark it. So this is one of the Dr. Lumsden asking and protocol to have a picture where did you capture that on the skin, because that will make it so much easier. You don't have to fillet the entire leg, but you're able to pinpoint in that area where you really saw the fistula. I think that's a very big help.
Also the flow patterns. The flows are usually low resistant through the feeding artery, and the venous flow should be arterialized and high velocity as well.
This is very funny. I think this nameless guy, I'm gonna ignore the questions. Can this technology view renal artery and vein abnormalities? I think this is more provocative than any other political debates. But thank you for your laugh. I just can't do the same. Please answer the question politely.
What was the question again?
Can this technology view renal artery and vein abnormalities?
Yes, this technology can view abnormalities, renal vein abnormalities as well.
Very good. I have a very beautiful actually value that we started to use in a protocol that in our renal stenosis. I think the protocol is over 60% based on the systolic upstroke. If the systolic upstroke is more than 110 milliseconds delay, this is how we can use not just the value of the velocity, but about the waveform. And I believe that we need to do something that not just using the peak and diastolic velocity values, but to really come up with objective. And I think the renal stenosis was the first, as I know of, that made the systolic upstroke delay really measure delta V and a delta T, give you a nice number that 110 milliseconds or more delay will be a significant stenosis. And I think I have one more question from my favorite nameless person is, what is an entrapment syndrome? I would like to answer that this is a popliteal artery entrapment, and we have a really fancy way of testing it. You just put a PPG on the toe. This is, can you zoom on my finger? So this is your knee. This is your knee, PPG is on your toe, and basically you are not in a straight leg, but you a little bit bending, and you are testing how the signal disappears when you are moving the knee. And this is where we are testing the popliteal artery entrapment, that just with the PPG on the toe, and you're moving the leg, and this is again one of those fancy physical studies we can add. One more question before we take a break. Are you able to perform an arterial exam with a chronic deep venous thrombosis, or at least an ABI and TBI?
Chronic deep vein thrombosis, you perform the arterial duplex exam. You can also obtain ABI and TBI if the chronic DVT is in the upper like the upper leg. We won't do ABI on patient with acute DVT. However, chronic in the upper leg, then yes.
Okay, I think that's all. If I see more questions, I will continue to answer them.
Okay.
Right now, we would like to do a 10 minutes break. We are coming back with just images, and that will be our Kahoot presentation. what we would like you to do is please download the Kahoot to your phone. So basically how it's going to work is that continuously you're going to see slideshows and questions on your laptop, on your computer. And when you see the images, underneath there will be 4 different colors. So we are testing again if you're colorblind, if you can see red or blue, and also yellow and green. And that will be just those 4 colors on your phone after we give you the PIN number. And basically you have to answer it. First prize, free registration, and some goodies from us come in the mail. So please put your name on it. It can be a nickname. So you don't need to say that I'm so and so, but you cannot be nameless on this game because otherwise we won't be able to give you the award. So the challenge is, I think we have at least like 30 questions. What we have after each question, you have 20 seconds to look at the image, give your best answer. Don't be afraid, don't be shy. Definitely I put in at least 1 or 2 questions that I would be surprised if anybody will get it right. This is why we're here, and this is why we would like to teach you. And thank you again for joining us. Sheldon, thank you so much for your talk.
Thank you.
See you guys back in 10 minutes, or maybe only 5 now. So 10:45 we'll be back. Thank you. Hello everybody, welcome back, welcome back. Let's play Kahoot. Just images, this is my talk, and I would like to share my screen. This is the PIN number you need to enter to play with me. 7691845. Steven, thank you. You're already in.
Oh, wow. Yeah.
That was fast, man. So I'm just going to wait a few minutes for more players. Just initials, nicknames. I recognize Carolina. Mate, hello from Budapest. Marton, hello. I hope you are from Budapest too. So here's a shout out for my Hungarian friends joining us from Europe. Thank you for making our conference international. Vascular dude, welcome. Vince, szia. Vicky, we have 37 players. I want to go up at least 100 before we start. Let's repeat the PIN number. This is the PIN number you need to punch in. 7691845. Oh, Bushra, hello, hello. Chris G, here's my other hard days night. Hello, Karen Broadbent. I recognize your B. Cat lady, cannot be anybody else, just Esther. Hello, Tamra. Hello, Dr. Day. Thank you so much for joining us today. Oh, Yesenia, thank you for joining our team. She's one of our new recruits in our lab.
Fantastic, by the way.
And this is how we... Oh, Yuko, hello, hello. Howdy, that's my name. 52. I'm just gonna give an extra 30 seconds and we'll get started. So again, we're gonna have few slides. Just please, based on your slide, give us the best answer. First prize is definitely free registration for next year, but I think we'll mail you some goodies from our hospital. We'll figure out something for our Hey guys, hello Sheldon. And I know from a Zoom meeting you need to come over to the Kahoot app. So on the Zoom you still can usually able to see the screen. Won't be able to answer the question by just clicking on a screen. This is why you need to download on your phone and put this pin in. Let's get started, guys. This is my talk. I just thought that it would be really simple if I just give you some PowerPoint, and I hope that you can hear some music. First image. Very good. I think we need more training for sure. I think I'm hearing myself somehow. Okay, this is better. So I want to show you the picture, and I think what you need to see is this is a high resistance, no diastolic flow ICA. In this case, doesn't matter what is your velocity, you do not see any diastolic velocity. So going back to the answer, congratulations for those 5 people. Definitely, this is why we have a vascular ultrasound masterclass. The vascular dude, Victoria, Bushra. Congratulations, you all got the score. And I don't know why you only got 588, damn it. I'm very sorry.
Well, it's based on time. The faster you answer the question, the more points you get.
Oh my God. Then the time challenge is on. Wow. Awesome. Thank you. Definitely the significant ICA disease would be my clue. That again, the extremely high resistance, and I think what I have actually a better explanation by the next image. So this is no answer needed. This is just teaching purposes. I wanted to show you one of our common carotid occlusion. And here's a clot. This is your flow front of occlusion. We're going to be high resistance. So when you do have downstream your disease, this is how it's going to shut it down for you. Okay. The numbers are 377 and 181. Wow. That the interpretation is even. Oh my God. Yeah, yes, I'm really like it. So the image, what I wanted to show you that this doesn't matter what is your ratio. When your end-diastolic velocity is 180, you don't have to even think what is the grade of the stenosis.
Yeah, it's already pushed into the 80 to 99%.
Thank you. Cool, cool. Let's see. Victoria. Steve, congratulations. Victoria, how fast can you answer that? Like you probably in 1 second. Look at that. Wow. Awesome. Vascular dude, you still there?
What are the numbers?
The number is 143.46. Very good. Congratulations. I think this is just way easy. The whole idea, what we wanted to show here, that this is by the consensus criteria. If it's over 40, that's your second number on the top of the 125. It's need to make it more than 50% stenosis. Thank you, thank you. Victoria, how did you do that? My God. So this is the consensus criteria, and it's beautifully, actually, it's on our report. So this is the Digisonic report format. Sometimes we have issues that everybody would love to edit them, so we cannot lock them down. But actually, this is what we agreed on, that if your velocity is more than 125 and your end diastole is more than 40, 2 out of these 3 needs to put you in this category. Not all the 3 criteria needs to be there. Over the 70% stenosis, you need to have 230, and diastole needs to be over 100 and a ratio of 40. And this was one of our first questions, that if your end diastole is over 140, that is the 80 to 99. It was really specifically picked for lots of asymptomatic patients may ended up with intervention, and this is where we put that specific criteria for that. And we need to talk about the Spencer-Reed curve. So the Spencer-Reed curve, this is where in the 70s, 2 gentlemen showed you, and this time actually was a CW probe, that with no stenosis to the total occlusion, your velocity is going up, and exactly around 70% diameter stenosis, your flow volume gonna start dropping. You won't be able to deliver the same volume flow throughout, and this is why this is hemodynamically significant. But look at the area, cross area reduction. That is almost like a 90% on the 70% diameter. The big trick all the time when we have a 300 centimeter per second, which side are you on? Are you on this side or the other side of the Spencer curve? I think is helping when you see the velocity drop after the high velocity. If your velocity is more significant, let's say 10 times more, then this is where you are on this side. If your drops is only like half, then you're on this side. And this is a gorgeous report. I really wanted to share that if you see our PDF format, we have an image, we have a beautiful drawing, we have the table that is representing, and these are the numbers which are coming across and able to display the numbers for this table. So I think this is I'm really proud to say, and this is for next year. This is how the drawing could be really complex, and this is where you can really go to the edge.
Looks really familiar.
So here's the next one. One answer is already there. That must be Victoria.
Must be.
Oh yes, thank you guys. Thank you guys. That was, I would say, very simple. What I wanted to show is that you can be saying that maybe this is a calcification and this is why you don't see anything, but you definitely want to maybe open up your sample a little bit, sample front and back, but this is again the stent and the stent occlusion. Thank you. I want to see who was the first one. Victoria, my God. How fast? Did you guys see that? It was like 1 second and she had the answer punched in.
She's the trivia queen.
And I trust me, nobody's seen these questions. Oh, here comes an easy one. I'm so happy. I'm so happy. I just thought that if you guys like would be 100% on each image, I would say there's nothing to teach. Yeah. Here comes a teaching point. So you see the color outside the stent, and there's no color inside the stent, but outside. So basically, there's a thrombus start to fill up the stent itself, and I have an angiogram on the next image. Victoria. No. Wow. Victoria. Steve, Congratulations.
I'll be
yeah,
back.
yeah,
It's
yeah,
okay.
yeah.
I'm at
So
disadvantage.
here's a beautiful explanation, guys. So what you see here, that there's a occluded stent here, not meaning that you maybe stented the vasa vasorum, but the fluid is coming outside, and this is where, again, it's really interesting how easy to really see that on the cross section, and cross section still is my favorite, and with explanation with our the radiologist drawing. Get ready. Do you guys hear the sound? Because I don't hear the sound. Wow, congratulations. That was too easy. The idea, what I was really scared of, that again, you're not going to call it stenosis because of a losses, not increase. Sometimes we just say, I give an extra 50. That will give you the stenosis criteria. For instance, stenosis, you can really see the color part. So definitely delayed upstroke, giving me a chance that maybe thinking about maybe proximal, there's more disease, but that's high velocity. They give me the instant stenosis. Wow. Okay, Steve.
Yep.
You are number 3.
Oh, awesome.
Music. Wow, you guys really paid attention to Esther talk. This was Esther infected graft. I'm just extremely proud. Sharina, Stephen number 2. Oh, Victoria,
Yo.
yeah.
Coming for you, vascular dude. So wait, he's not
Here you go, sir. Music.
Oh. Duh.
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 That was funny. Yeah, I think it's hard to miss that one. Definitely, I want to see who is the fastest. That was one of the cases we showed with Dr. Lumsden, and I wanted to do this. Steve, 2. Awesome. So what we wanted to show, and actually Karen, I'm going to show you this slides, the classification. I am letting her do the explanation. This is the time when Steve will take over.
I'm like smashing the button so hard. That's the femoral artery, guys.
Awesome.
No femoral? Okay.
Oh my God, everybody's a TCD expert
Look
here.
at that.
Jesus. So definitely left middle cerebral artery and diastolic velocity is extremely high. Again, mean flow velocity is 190, gives you a proximal middle MCA stenosis.
So let's, I guess at this time, let's dispel like why some of the answers probably seem good, but probably aren't. So ICA seems like it's an okay answer. Why wouldn't it be, right? So if you're looking at ICA, you're typically looking submandibular. So those signals are going to be moving away from the probe, right? Because you're pointing up towards the head. In those cases, the signal should be blue instead, right?
Yeah, but I think the next picture will tell you why the right ICA disease was there. And I think these are the answers, because I wanted you to think about the ACA stenosis. Make sure you exclude ACA stenosis, and also not thinking about the cross feeling yet.
Okay.
So watch. Music. I don't know who picked this music, but I like it. I think your heartbeat is.
5 seconds, guys.
Wow.
Ooh.
See the beauty?
Oh no.
That's 17 people. I'm so proud of those 17 people. So just to show the media, I think this is really nasty because I'm showing you a left MCA and the ACA is higher, telling you that this is going across feeling with that flow gap. So the left ACA cross section indicating that this is an ACOM cross feeling, and this is why this is beautiful. 24 on the ACA stenosis, very, very good point. You would have multiple or just do another ACA measurement and your ACA high throughout. So that's why it's not a stenosis, because not one focal velocity increase. And I think the other two is out for this time.
That was definitely next level. I would say I'm one of the. Oh, that hurts so bad.
Dude!
I'm one of the ones that picked ACA. And the reason why is because you're limited on your clues here. Come on, you threw a curveball there. You can't say that's not possible. It's plausible, right? I mean, if you have decreased MCA, ACA
I'm surprised for those 17 guys. They got it right. So, yeah, I think it's
Good job,
curveball for
guys.
sure.
Good job.
So this is the explanation. Again, one more time, when your AC is higher than your MCA, the AC is going to carry over the flow to the right side. But I think it's another clue for, I thought that I have one more picture. Maybe the next picture is going for the explanation for this one. Music. It's not a curveball, guys. This is objective as it is. Sharina must be attending my TCD boot camp. Oh, see, this is so easy. Come on.
How am I not seeing this?
It's so easy.
To be fair, it's pretty far.
It's the whole thing is red, and what I hope I'm going to show on the next slide, an explanation. I wanted to show you how the ACA, when it becomes reversed, you need to also pay attention to the waveform. When it's coming across and you have a reversed ACA, will be a totally different waveform than your MCA. So that tells you that it's coming from a different vessel bed. So when you see the reversed ACA and you are not colorblind again, not blue, but red, needs to be an increased velocity coming across with low resistance, but going to feed. And the MC is really dilated because, hey, send me some flow because my carotid is down. I need more flow in my middle cerebral artery. Very cool.
What vessel?
Left siphon. I really love my answer as a verse stenosis. I think I really made that. Oh, come on, guys.
You want more?
So
Hang on.
that is too funny.
That is funny.
That is funny. So I hope I have some explanation for that one.
Oh, I think I'm off the chart.
So finally you see my eye. So through the eye you see the ophthalmic. So if your carotid is down, occluded, that you may have this reverse ophthalmic. This is why it's blue. Normally your ophthalmic is nice and red and high resistance. So this is your normal ophthalmic. Hint 10% decreased power. And then when you look at your reverse ophthalmic, it's continuous. So low resistance ophthalmic versus high resistance. And again, blue versus red, blue, red. So I think those colors kind of telling us the screen today. Music.
All right. Using context here.
Please do not read the labels. The labels are incorrect. Too late. If you punch the answer, you cannot change it. Steven, if you don't beat this one.
I can't see it.
What?
I can't see it. I'll be guessing. I'm like using the pictures of context.
First joke, I only had color blind, but if you're total blind, and then we have
I'm total blind.
I'm so sorry. That was a terrible joke. I really feel sorry for your eyes.
It's all good.
I'm sorry.
I thought it was funny.
I thought so too. But bilateral vertebral, that's awesome too. So my label is MCA. when you look at the red signal at 50, you have a red signal. That is cannot be anything else. Cool? Some loud laughing is in our waiting room. I'm really enjoying this game, guys. No score for our leaders? Come on. Stephen. Oh, Stephen, please.
I can't see.
Just hit something
no,
like green.
No, I know what it is
or-
now, but I already answered it.
And you cannot change
Yeah, I
it.
can change it. Oh, that
I
was
really
a
like this
3.5
game.
points. Yeah, of course.
PCA, not good. Someone really likes this vertebral stuff. And a basilar, no. So this is middle cerebral artery. And again, when you see a red, this is only MCA.
Yes.
There's no PCA when you see MCA, no basilar when you see MCA, no vertebral when you see. So MCA and AC is always kind of coupled together, like me and Stephen. So here's MCA embolus going towards your probe. This is why your slope is from a deep coming toward your surface. You have this one. When the ACA is coming from going away, this is why the slope is just getting away. And my recording is in the ACA, so I only see the ACA signal here. So if I need to move my depth to 60, then I will be able to see an MC and ACA together. And I think that's just one more thing how the embolus really looks like. Don't tell me you missed this one too.
I plead the fifth. Can I get the pin real quick? Can I get the pin? I can't see. Oh, okay. I think I know what this one is. Let's see that one a lot.
It's definitely not the basilar artery. If someone hits green on this one, no.
It's like it's less than 50% of the folks that answered it correct.
Basilar.
Basilar's gonna be blue, guys.
I would say that's not a good answer. The good answer is in MCA, and I think it's important that you see them. This is what we are talking about. That it's in the waveform. You see, it's not sitting on a zero line, but in the waveform, you see this beautiful signal. Amanda.
Yep.
Oh, Steve.
Look at that.
We have
power
a hope.
play.
We have a hope. A few more questions, and you can give us a talk. This is not blue. Oh, I mean, I see blue.
It's a jackal. That was mean. That was really mean.
I know. So I really feel sorry for those yellows because the yellows really thought that they see an embolus. But where is this stupid thing? It's on a zero line. It's not moving. So if it's an embolus, it needs to be in the waveform. This is present multiple depth at the same time, so it's not moving. It's a tap. So it's a sound effect that it takes, as again, multiple depth. You see it. And this is where it's not moving. So the first thing for an embolus, you really need to see it in the waveform.
And there's a couple other clues on the picture as well. The fact that it's a black line across the
Yeah,
MO
and
as
the
well.
delay. I think that's.
Yeah.
I think in the Spencer, you had that artifact rejection
Right.
really nicely done. Otherwise, you will see the white line on
Yeah.
that one. I hope you got it right, man.
Well, we'll
Because-
see. Oh, man,
Dude.
apparently everybody else did too.
Amanda. Fabienne.
Oh, I can't see. I'm about to run up to your side.
Come.
I mean, it's true. That is true. What is it, 44?
I'm so sorry.
I was
Come on,
close.
cubic cube. That's
was
my
close.
Hungarian cubic cube.
Yeah.
Come on, guys, don't tell me
really
you don't like
cool.
my answer. So we really had to come up with something.
This is definitely
You see this beautiful 3D beautiful thingy bingy here. So it will be definitely 4D in the moment you see it's moving. Do you see it's moving?
Yes.
It's not.
No.
Oh, well, I moved the
in
screen.
a context of moving.
Oh, I'm so sorry. We are enjoying too much. I was told that we are 3 minutes overtime, and because we started 5 minutes later, it's my fault. But we keep rolling, quickly.
Oh, so it's not the first one. This could be two things.
What would be other thing?
Maybe IVP?
What?
You don't think so?
There's no flow
With
here.
high filter?
Ch-ch, ch-ch,
All right.
ch-ch, ch-ch. Too far. Du-du-du.
Oh.
Come watch my screen, man. If you don't see it
No,
on
I saw that. See that one.
Hurry.
Okay, yeah, I gotta look up here. Let's see it. Oh, oops.
Ooh. What? You cannot have less than 50% stenosis when you have a shape waveform change in a vertebral. That's another class. Sharina. I'm so mean. Look at the color. Look at the diastole. Very good. Someone really saw my lectures before. I bet it was Esther. Victoria, Stevie. Almost done. I'm so sorry for the delay, but we're just having too much fun. Okay, at least the green people paid attention to Jay's talk. Very good, congratulations. Victoria.
It might be too late.
Few more, 3 to go. Wow, I'm so proud of you guys.
Good job.
Double waveform never lies. Nasty. Intracranial vertebral depth 83.
Yes.
Wow.
Barely.
I think that's wrong.
You think?
Yeah, reversal flow. Oh yeah. So this is good. So I was looking at what is these 20 people thinking. So the 9 is good. So this is where everybody thought that this is a vein, but this is a reversed vertebral, and this is the other vertebral, because you see the speed and the systolic upstroke starts at the same time.
So this is a slice thickness.
Oh my
artifact,
God! The
essentially.
20 people, please sign up for Vascular Ultrasound Masterclass for next year.
See you in 21.
I think. This is right common carotid.
I think I have an idea.
What's your idea? Tell me. Yeah.
That's
Oh
right,
my
that's my
God,
idea.
that's so easy. I was thinking that we need to next year just do one like leg.
I'm so sad. I was enjoying
Carotid,
myself. This is the last
something.
one.
This is the last one?
Yeah.
Oh my God.
Oh.
Dude, I was 100% sure you're gonna win this.
You know, I'm not gonna make excuses.
Your eyes. I think I will blame it on your eyes. Thank you, thank you. That was too easy. And I would like to share Steven,
I'm so happy.
Victoria, and Sharina. Yes,
Yay.
Congratulations. Well, I'm so sorry. I feel like we are back in high school, but this was the best game we could come up with, and I would like to thank you for my organizers to made me play. But I really enjoyed it. I hope you guys enjoyed it as well. After this game, we would like to back to some serious business. Stephen is my lead tech, and again, a magician. So he will give us his magician talk.
Okay, I'm ready.
Go to slideshow, please.
Oh, hello. Excuse me. Oh, no. Here we go. All right, guys. Hi. Yes, I'm Steve, and I'm one of the lead techs here at Houston Methodist. Just doing my talk over a few tips and tricks. Yes, I am a magician, but only with ultrasound, right? So to cover why we're doing this presentation, we are all sonographers who have passed our registries for physics, but over time you kind of see that you start losing that, or your fundamentals as you don't keep using the tools, right? So yeah, physics plays a huge part in what we do. And why do we have to use it? It drives our image production, it increases our diagnostic ability, and there's artifacts that are created, so you have to somehow knock those out. And when you have all things together, it opens your mind to exceptions, right? Like if an artifact is there, could it be actually an artifact, or is it a dissection? Stuff like that. So why are we putting it aside? Why are we not using it as much as we used to? It's because of time. It takes time, right? Productivity is such a big thing in what we do today. Companies need to make money, and so do we, right? Got to keep our jobs. So let's go ahead and dive in on some tips and tricks with a curved linear probe. In most cases, we are often using a linear probe, but every now and then there'll come a case where you need higher amounts of penetration, right? In a very common situation, and that being a venous duplex, that's pretty much our number one exam almost anywhere that we perform these things. So importantly, we need to make sure that the patient doesn't have DVT. So good visualization is very important. So what does edematous tissue do? It increases the vessel depth, it increases beam attenuation. That in turn leads to poor image quality, and of course deeper vessels and all that good stuff need to adjust parameters, will lower your frame rates. So of course we just covered that. The ultrasound probe of choice is going to be probably your curved linear in these kind of circumstances. What are the drawbacks though? There's always a drawback when you pick a certain tool, right? You have to pick the certain tool that does the job for you, but in turn you'll lose some stuff that you won't necessarily need, I suppose. So yeah, you'll have less axial resolution, meaning your resolution on your y-axis, or from AP, so from the top of the skin deeper. You'll get less attenuation in return, which is created by reflection, scattering, and absorption. Case in point number one, right? An edematous calf. So here we're using a linear probe. We're starting distally, as we usually do, moving up the calf, and it's starting to get harder as we get proximal. You can still, what would you say? Would you be able to see that? You can still see it, but it's definitely harder. Here we're switching to a curved linear. We're having a much easier time. We can definitely see the walls of the vessel compress in this case. And of course, A quick adjustment to gain and another augmentation. Case point number 2, curve versus linear again. Okay, definitely seeing the PTV. The real question is, can we see the paro with the linear? We can at this point, but we can definitely appreciate it a lot more with the curve. So, other tips and pointers regarding frame rates. So we want to get faster frame rates so we can do our job quicker and also get a nicer compression or visualization of the compression. So first thing you want to do is, of course, reduce your depth. That will in turn reduce how long it takes for the beams to return back to the probe. And as you remember, with the probe, it's a sequence. So all the probes have to, or all the lines have to fire first. And then after the lines finish firing, you create one image. So if it takes longer to get to your structure of interest, then it takes longer to return back to the probe, thus increasing your frame rates. Number 2, reducing the line density within the probe. So now we're cutting like how long it takes to create a frame by quite a bit, right? It looks like maybe by 3 times. So you're increasing your frame rates almost by 3 times in this case. So it's frame, or line, frame. Okay, here's some settings on the machine on one of our more popular machines in the lab. We have line density on the first page of our settings here. And on the Philips, you'll see it right here on resolution and speed. So it's kind of a different take on like how they define it, but the settings are there. Another neat trick is squeezing the sector width. So, how's it working? Oh, can we turn on our mouse? Sorry, guys.
The pointer.
Yeah, pointer. I know, I understand. So, squeezing the sector width, you reduce the amount of lines. You still have the same density, right? So your resolution doesn't change. And when we say resolution, we're talking about lateral resolution. But, yeah, again, line, frame, line, frame. Of course, there's our thing there. Here's how we change it here on the GE. You just kind of turn the knob here, and you'll get a reduction in the sector width. Right over here for our Philips levers. Option 4, reducing the amount of foci. So focus, what it does is that it pretty much cones down each individual beam so that it has higher resolution at the squeeze, right? So in this case, where we have multiple focus, we have squeezes right here, here, and here. In this case, we'll have our squeeze probably somewhere at one single point in this example, but we're sending individual beams each time. So in this case versus this case, we are having 3 times more beams being sent before they make a frame versus this one. So again, what's our goal? To optimize high frame rates and temporal resolution while still maintaining a diagnostic quality or spatial resolution, so overall detail, including, of course, your lateral and axial. And for physics lovers, here is the diagram, which you can appreciate. Axial resolution is how well you can see on AP, whereas lateral resolution is how well you can see side to side. We can always change our frequencies, but that is something that we normally don't do too often, especially with a curved linear probe. We should maintain as high of a frequency as possible just because we want to maintain our resolution. And 5 megahertz should be plenty enough versus your typical 9 megahertz that you use with the linear probe. So standard line density, what I would suggest is using standard line density, or in times that you really need to change it up or objects need to be too close together to really be able to discern them away from each other, increase the line density. But you should always reduce your sector width because vessels are relatively small. You don't need all that wasted space on the outside, especially when you're in transverse. You should only have, in most cases, one focus because, again, the vessel's very small. You should really only need to look at that particular area of interest. Of course, you can find incidental findings, though, and, of course, leaving the frequency. So with curved linear, of course, one of the hardest or most difficult things to do is to grab a good Doppler signal. So I call it a red area or red zone or no man's land. You just can't seem to get a good angle. But on the outside, we can actually get a angle that is parallel to vessels that run straight across your image. And case in point, so to get it, we have to move down the body and then angle it on the outside. But of course, you always want to put your image of interest or your segment of interest in the center of the screen. In this case, all you have to do at that point, once you get there, is to heel and toe. So putting that theory into practice, we have our images here. And it looks like somebody forgot the aorta, so boom, I'm a magician. I'll add it, no problem. Segment of interest, let's add right there. So here we go. Scan lines, if you remember, they shoot out like so, fanning out. So I can't seem to get this 30 degrees. So what can we do? In theory, we should be entering the body at 30 degrees, or yeah, of the vessel of interest. So we're going to mark our point there, place our probe there, and now we have 30 degrees in, and then angle adjust with 60 degrees, right? Same thing on the other side. Okay. Here's another one. So even though, as long as your beam of the ultrasound probe is touching the X, right, you should be able to get that angle, regardless of if you heel and toe, because it doesn't really matter if you heel and toe, it's still going to give you the same exact line, right? So here you go. So if we want to put the vessel in the center of our screen, quickly just move to the, or use the edge of the screen to place your Doppler, or see if it's possible to get that sample or a good angle, and then heel and toe, right? That's my best attempt. Couldn't get center, but hey, accuracy is always better. Other tips and tricks for venous studies. So definitely you'll run into these kind of cases when you have patients with extensive PAD and maybe ESRD and or end-stage renal disease and calcium. So we're just not really able to see that vein. You can see it in that frame right there, but just barely. So what do we have to do? We have to attack it from other angles. So we have to move our probe and then angle back into the tissues. So let's go ahead and go with this one. So in theory, this is what we should possibly, hopefully, encounter, right? So we're going to have a new shadow, or yeah, new shadows from attenuation. And this is the theory and practice. Or I could have just gotten lucky. Interesting point, since we're going to go ahead and build off of it, is the femur, right? The femur can get in the way as well, but also it's actually a great tool to help. Now, why the image starts looking better with the femur, I'm not entirely sure, but my theory is that the femur absorbs a lot of ultrasound beams that attenuate, or will attenuate and cause a reduced amount of resolution. So here, with the linear probe, I'm having a very difficult time seeing the distal femoral vein. So, but if I come onto the femur and I repeat the same movement, here we go, I can see it, and it's very crisp, right? So we only have, if we look here, we only have this area of the transducer that's actually firing beams and accepting those beams, right? So it's probably a reduced amount of beams making it back, but they're higher quality beams, I should say, or like more accurate beams. Try it out, guys. So here's a little representation here. Maybe you want a towel, stick it under the knee right here. You probably want to put it right under the knee. So that what it does there is that it creates independency of the leg. So in turn, you'll have more room to kind of do your augmentations and squeeze underneath the thigh here in cases where you need it. So yeah, that is the drawback to, how you say it, this method here, is that you can't really do your compressions with your probe hand anymore. And this is me trying to attempt to do the compression, but I can't. So you have to do the compression with the other hand, your offhand. All right, so with transverse sweeps, what this does is it actually kind of moves, or how you say it, it helps you see the vessel in cases where there's a lot of edema. You can kind of see the PTV barely around in this area. But of course, we still have to find a good window for it too. And you can kind of see that I'm moving transverse, trying to see if there is a better window. Of course, ultrasound is an art of trial and error, right? So here I'm basically compounding those two elements. I'm sweeping and getting a lot of surface area of the leg, while at the same time I'm trying to find a window. And I find the best window, I start doing my compressions, at least for that small segment, right? Here we can also use the sweeping method to find smaller vessels like the GSV, which is up here. Very difficult to see, very small, but we did find it. So, reading Doppler shift. Here is a classic trick I found in Sidney K. Edelman's book, and it helps you predict flow directions using a linear transducer while you have your beam steered, and it's called the home method, right? So, home method, how does it work? You have a home line that's drawn on the top corner that, how you say it? Top corner that, or top edge or acute edge, right? And you draw it straight down, and that's your home base. So, judging from your color flow here on, or your color mapping, any flow that is moving away from home will be on the bottom side. Any flow moving towards the home will be on the top side of the flow, or of the color scale. Yeah, color scale. There you go. But where is it when you do a straight box method, right? It doesn't apply. So this is where things get kind of weird and confusing, because if you are only religiously, using the home method, you can't use it here and you get confused. So let's return back to basic principle and how color is actually developed on the ultrasound machine. You have positive shifts and you have negative shifts. Flow moving towards the beam will be your positives. Flow moving away from the beam will be your negatives. And here are your choices of how the box or color box can be steered. So follow this basic principle. Any flow or any color on top is always going to be positive. Any color on your bottom is always going to be a negative shift, period. So it doesn't matter if it's orange, black, blue, brown, purple, it's always going to be positive. So what does this mean? It means that, again, any flow that's positive is going to be moving up towards the beam. So the question now comes, is it this flow moving from left to right or right to left? So generally the flow is moving in this particular direction, right? Okay, how about this example? I'll give you a second. Flow is still moving up because we are still using the principle that any shift that's positive, the colors on top, it's going to be moving up towards the beam, period. In instances where you have a curved vessel, this is how it should display. You'll have a segment that is going to have forward motion, and then segments that will have an away motion based on this image. So the question again is flow moving left to right or right to left? So if this is telling me it's going up this direction. This is telling me it's going down, it's going this way. So its flow is moving from left to right. All right, a little curveball here. If we steer the beam, it's the same. The principle still applies, but now we have we have angles, right? So here's how the beams are going to be firing, and thus the way that the color will be displayed is going to respectively do the same thing. Again, the question is flow moving left to right or right to left? So based on this, it's telling us that flow is moving up, flow is moving down here, so it's moving from left to right again. All right, this one's an interesting concept. So flow is moving from left to right. So in this case, is color going to be blue or red? And because this is a right angle, it's telling me that this is exactly at 90 degrees, because you can't determine that there's no, or how you say it, there's no motion moving towards the beam or away from the beam, so therefore color will not be produced at all. Here we go. We're going to have a tortuous example here. I won't say anything. I'll let you guys kind of get a minute to figure out what it could be. Okay, so based on the straight box, it's telling me that my beams are moving up and down. This color chart is telling me that it's this, or purple is moving away from the probe, so therefore this is moving generally down this way, and flow in the green is moving up this way. So we're having these movements like this. So flow is moving from right to left. Pop quiz, why are we not seeing flow in these segments? And based on our last little bit, it's because there's no, or the angle of incidence is 90 degrees. So therefore it shouldn't produce any color theoretically. Straight box. And so we're always told to angle our color box with the vessel. You can create oftentimes better and accurate colorful images though with a straight box method. Case in point, we have an ICA. Boom, look at that. So our change from our angle to straight box, you're coloring in the vessel so much better. Now you could increase your gain with the angle, but it's not always better. I mean, you saw it right there. Angle and color flow is independent of each other. So here we are trying to find that distal segment. And of course, I always have to do a comparison. Both are good choices in this case. I'm not knocking on one or the other, but I like to try a lot of different things. As you guys should too, right? Okay, just doing our little angles, and you can see from the straight box method or color box straight, and you still have the ability to adjust your Doppler angle as you please. Okay, other situations where straight boxing can be effective. All right, just rolling through these. Vertebral, this is what I wanted to get to. So we're able to thread through the vertebral process using the straight box, whereas we kind of find ourselves with some issues with attenuation from using a angle. But with increased gain, we're able to bring the color flow in. But in turn, you're actually getting a lot more aliasing and a lot more splash on the, how you say it, superficial side of the image. And of course, when we go back to do our sweep, the gain is just insane, right? Of course, you have the ability to knock back your gain as you're live in your clip as well. So misconjurations, what does that mean? So we have a aorta and IVC with ECMO. Yes. So it is important to kind of figure out how to set up your color flow, first before you start inverting your settings, right? So this is telling me that the aorta is moving in a negative shift. It's moving away from the beam. But you could easily have inverted the color and the Doppler and gotten a red signal. And just to prove that they're both moving in opposite directions, the IVC and aorta, we have that. In the IVC, we have a positive shift. Again, we could have easily just inverted the color and the signal to, match it to how we would perceive it should be. But because the setup was correct with the color scale, they were able to actually determine that there was retrograde flow in this case. Complications with the AVF. So, nice big chunky thrombus in your cephalic vein. In your left brachial artery, we start off with a low resistance flow, and as we start moving distally, it's starting to slow down and change in waveform. So once you get distal in the antecubital fossa, we have pretty much a loss in flow entirely. But the AVF is still patent. So that's interesting. You have a brachial artery that's occluded, however your AVF is still open. In this case, we have a radial artery that is moving, or patent rather, and you have low resistance flow. And in your ulnar, you also have pretty much the same kind of waveform signal. But how's that possible? Your brachial artery is occluded, right? So here we're demonstrating that brachial artery here into the AVF anastomosis distally. But we're starting to see a complete loss of flow in the distal brachial. So we have radial flow, again, just to show, actually, both of these arteries and ulnar arteries and radial arteries are moving in opposite directions. But now we come to the case of like which one is correct, like which way should the flow be going. And the tech here made a 50-50 choice. They assumed that the ulnar artery was moving retrograde. But actually, it's moving in the correct direction. So if we look at the color here on the color scale, it's telling us that it's a positive shift. So this waveform should actually be on top of the baseline, or you can invert it to be on top. So now we have the clue that ulnar artery is moving antegrade, radial artery was it retrograde? Indeed it was, right? So red, it's telling us that flow is moving towards the probe, up this direction, and you have an angle down this way, so it's moving up towards the probe in a diagonal fashion. And of course, positive shift means that it is still moving, like it is moving from right to left in this case. So we have a occluded brachial artery, a reversal in the radial artery, antegrade flow in the ulnar. So what's happening is that the flow is moving in your palmar arch, bypassing that brachial artery segment, and you're getting flow to your AVF like so. Power of augmentation. So this is our little iconic, what was it? Our iconic case study with the stingray. So quick patient history, pleasant man, got hit with a stingray, it hurts. Pleasant man, stingray, sounds very familiar. Here I tried to create a gel bubble to look at the little pseudoaneurysm, but I didn't quite get like a very good sweep of it. But we're just going to be following the brachial artery. We can see that the pulsatility index, or the resistance, is starting to decrease as we move distally. So when I see that, I start thinking, okay, this is more than just a pseudoaneurysm, right? There has to be a fistula occurring, right? So now I'm starting to do my compressions. I see that the radial vein to the right, or the, I would say the medial side of the arm, is not really compressing. So my first thought is, oh man, I think I hit jackpot. I think there might be increased pressure in that vein, right? There might be a fistula there. But when I do my color flow and Doppler, it's very smooth. It's pulsatile, but it's not as big as I expected it to be. And the same applies for the opposite radial vein on the other side. So with the augmentation, I'm trying to see if the flow bounces back right away, or if you get like a response from closing off the vein and seeing if the decrease in pressure will create hyperemia. In both cases, it does not. So what I do find interesting with augmentations is that you have to actually pay attention to the results of the augmentation, guys. Because if you just augment just to do it for the protocol, you start losing like the reason why you do the augmentation, right? So just pay attention to your patterns. Okay. And sure enough, as we move distally to the wrist, we start seeing that fistula or aliasing. We start bumping up our scale, so we eliminate all those unnecessary noise. And of course, just for your perusal, Doppler signals. One of my favorite tricks here, B-flow. GE has really opened up like our ability to make great images using a different tech. All right, so we have a carotid artery scan. And of course, you can already tell tight stenosis. Boom. So we're looking at our ECA here. You have all this significant plaque. So flow is moving through the bulb here at this tight area, and then moving up across towards the top left side. Not seeing that 150 centimeters a second for stenosis though. So all the stenosis is in the bulb. And B-flow, oops, side-by-side comparison. We're even able to kind of, and this is a really cool feature here with B-Flow, is that you're able to kind of create an effect of an angiogram. You're layering signals on top of each other to smoothen out the signal and create an image. So any movements, though, just like subtraction angiogram, you're going to see it on your X-ray, right? So same concept. Okay, just a side-by-side comparison with color flow. Reaching deeper into the bulb here because there's a blockage here, you can't simply go through the plaque anymore. You have to kind of reach underneath it. And we're able to get high-grade stenosis, whereas before, trying to move from here, we weren't getting the same velocities. So I'm just talking about it. All right, some more tricking. And of course, the results of Doppler signals afterwards to show you that it was a high-grade stenosis. Here are looking at an ECA with some branches on B mode. Now if we try to compound it or use that imaging where it layers, after many, many tries, we'll eventually get the picture that we want. And with this one, we can actually see the individual branches here. All right, and that's about it.
Thank you, sir. That was truly magic, and thank you for all your hard work and teaching us, and not just us, but I heard that you're also teaching our Alpine Community College students. So thank you for taking care of the next generation of sonographers. Thank you. I do not see any questions. Let's see the next talk. Let's swap the computer and let's give the waveform. Waveforms never lie. Joe called me yesterday. He told me that he had some other things to do, and I got a heart attack. Now I'm just recovering slowly. He tried to be funny, but it really scared me to death. And I'm happy to present that he's here, and he's going to give us his best talk ever. Joe, tell us why the waveform never lie.
So I think it's important to look at the entire ultrasound exam, velocities and so forth. But many times waveforms provide us with so much more information than just the number, the peak systolic or end diastolic velocity. And waveforms give us a clue of what's happening. I think it's almost like the body or the ultrasound is trying to communicate to you with a language. And the language to me is the waveform other than the measurement that you're getting or just the appearance of the vessel in the way. And that's why I think waveforms, and this is something I didn't invent. I think I got this from you. You used to tell us that waveforms don't lie. And that's kind of how we got into this today. One thing I would like to encourage our viewers is to sign up to our YouTube channel. And if they like some of the presentation or think something is interesting, please share it with other colleagues. We would like to really expand our community of physicians and ultrasonographers and nurses and technologists who are getting involved with ultrasound. So a lot of what we're going to do today is you probably have seen already through the previous lectures that have occurred this morning. I'm going to go a little bit fast just because I understand that some of the basic stuff you've already covered. So we're going to talk about waveforms in different systems: extracranial, arterial, extremities, also venous upper and lower extremities. So we're going to start with the extracranial circulation. And as we all know, the carotid artery has a sort of a mixed resistance component. And that's in the common carotid artery. The external carotid artery, we know, is a higher resistant vessel. And usually the diastolic component is much lower than that of the ICA. And the ICA is a low resistance waveform where you start seeing some spectral broadening, a more prominent diastolic component. And so we should at least understand the difference between high resistance and low resistance waveforms. And my impression is that understanding what happens in the carotids or the extracranial circulation is the building block to understanding waveforms in the rest of the body. That's why I always like to start with carotid ultrasound and then move on to the different areas. Again, another example of low resistance waveforms in the internal carotid artery, and again, the high resistance waveforms in the external carotid artery. And these are the normal appearing waveforms. Here we have the spectrum as we move from the mid-common carotid. You see that the resistance waveform is changing a little bit as we're moving into the distal carotid. The external carotid artery has a high resistance waveform. The proximal internal carotid artery, you look at the waveforms, and then you have the mid-internal carotid artery where you see that the low resistance waveform starts to sort of express itself with a little bit more freedom in a way. Again, here's the temporal tap, and this is, you're trying to identify by tapping on the temporal artery, you're trying to identify the external carotid artery and anytime you're having some difficulty, and this is usually seen within its diastolic component. And that's different from the pulsus biferians, for example, that you may see in aortic stenosis and or regurgitation, where you have these sort of peaked waveforms that affect mostly the systolic component. We're going to get into that in a little bit later. So let's start looking at waveforms. There's a little shape like stenosis that looks like a little focal thing. Forget about the peak systolic velocities. What do we see here? Significant turbulent flow, color aliasing, we see spectral broadening, and then I start looking at, so already I can see this waveform and say, wow, this is a high, sort of, there's a stenosis there for sure. You know, there's a lot of disturbed flow. And then I look at the velocities, and I can see that, you know, both the end diastolic and the peak systolic velocities are elevated, and I know that this is a severe stenosis, okay? Here's another example. There's turbulent flow, there's spectral broadening, there's elevated peak systolic velocities and end diastolic velocities. Well, great, I know that there's a stenosis here. But for a second, let's forget about the numbers. By looking at the waveforms, you know that there's a stenosis there because of the appearance of the waveform. Let's look distal to the stenosis. Watch that. Decreased systolic rise, dampening of the waveform, right? You know that this stenosis is severe because the flow going past the stenosis is so decreased. It's almost like looking at a traffic accident. When you see an accident on the highway, what you see is the traffic backing up. And then what's going past the accident, just a small number of cars. Same thing. Here's all the traffic backing up and getting all confused within the stenosis. And then distal is this. So if you didn't have these numbers, you would still know that that stenosis is quite significant. Here's another example. This is the mid-common carotid artery. You see the mixed waveform. The external carotid, though, has some increased velocity and some turbulence. You're like, well, why is flow sort of increased, or it's more turbulent within that external carotid artery? Well, let's look at our internal carotid artery. You see this high resistance staccato waveform. No diastolic component to see, just a small amount of systolic component. And here you probably see a reversal of flow in early diastole on this mid-internal carotid artery. So this is either a severe stenosis or a string sign, or almost a near occluded common internal carotid artery, and now a lot of the flow is being directed to the external carotid artery that's taking up the slack from that vessel. Let's look at this image here. External carotid artery, what's happening? Flow is reversed. That's great. And what's happening in the internal carotid artery? Very low resistance sort of waveforms here. And this is really being picked up right almost at the segment of the bulb. Here's another example. Here's a common carotid artery. Waveforms are slightly sort of mixed resistance, but slightly on the high resistance. There's some turbulence, okay? Here we see a defect within our color spectrum. But what happens in this mid-carotid, almost past the stenosis, you see that systolic rise is delayed. There's rounding of the waveform, and there's some turbulence and spectral broadening. You know that between this proximal segment and the mid-segment, there is definitely an area of stenosis that's leading to this dampening of the waveform. So what does this tell you? It tells you that you have to go back and take a look and see if you can identify the stenosis, or you want to get alternative imaging if you cannot really characterize the area of stenosis. Here's another example. This is quite interesting. This is the proximal external carotid artery. You know, standard external carotid artery, some spectral broadening, but high resistance. Mid portion, wow, the resistance is increasing. The distal portion of the external carotid artery that we can see of the proper external carotid artery, staccato waveforms, no diastolic component to speak of, so there's a very high resistance. So we know that there might be some sort of further obstruction to flow there. Now let's move over to subclavian and vertebrals. Again, subclavian artery supplies the arm, so we know that that is a high resistance bed. The vertebral artery supplies the brain, that's a low resistance bed, and that's what we expect. A high resistance looking waveform, a low resistance waveform in the vertebral. Well, let's take a look here. Systolic velocities in this right vertebral is the peak systolic waveforms in the 200s, and almost on both sides. On the left side, it's a little bit higher. And the blood pressure difference between the two arms is quite significant. I mean, there's a difference. It's 24 millimeters of mercury lower on the left, and it's consistent with this systolic velocity. Okay.
But you said vertebral. No, this is a subclavian.
This is this is a subclavian.
Bilateral subclavian.
Yeah, so sorry.
And the vertebrals.
Yeah, the vertebrals are below.
Yeah.
So these are the subclavian arteries. So it's bilateral, greater than 50% subclavian artery stenosis on both sides. It's more severe on the left, and that's given by the difference in blood pressure too. But let's look at the vertebrals. Look at the vertebral waveforms. You lose that kind of early or this sort of rapid systolic rise here. What you see is there's a delay in the systolic upstroke and this rounding of the velocity. Still low resistance. So you know that the flow to the brain is going okay within the vertebral, but before the vertebral, there is some area of stenosis, which could be right at the inflow, right at the origin of that vertebral artery. Okay? Now let's take a look at this subclavian velocity. Look at this, delayed systolic rise and the rounding of the subclavian artery waveform. The velocities are low. Doesn't mean that there isn't a stenosis, because a stenosis always shows you high velocities. The velocities will be high at the stenosis. This tells me that before this segment, there is an area of stenosis that's leading to this dampening of the waveform. Okay? Let's take a look here. Left vertebral, normal waveform. You know, brisk systolic upstroke, a little bit of a flattening of the systolic segment, and then a nice long diastolic low resistance component. Look at the right vertebral. Rapid systolic rise, deceleration, hardly any diastolic component. So we know that this vertebral, there's either an outflow stenosis or the vertebral is hypoplastic on the right side. Again, right vertebral artery, normal waveform. Left vertebral artery, peak systolic rise, early or mid-systolic deceleration, and then there's an antegrade late systolic flow. This is a very early pre-steal waveform, okay? Now let's take a look at this. Subclavian artery, the velocities are not quite elevated. They're about 100, but there is some spectral broadening, okay? Probably the angulation here could have changed, and that would have given us a little bit of better image. But again, it doesn't matter what this is. We know that there is a significant subclavian stenosis because we look at the vertebral waveforms. Look at that. The mid-systolic deceleration, there's a diastolic component. This is what some people call the rabbit-looking waveform or something. It doesn't matter. This is a steel waveform. This is before stenting. After stenting of the subclavian artery, you lose some of that spectral broadening. You see the reversal in diastolic flow, and you see just a little upstroke here where you can pick up some of the antegrade diastolic flow. But you look at the vertebral. Vertebral waveform is back to normal. So we reconstituted flow into that vertebral. Again, here the waveforms give us the entire answer of where the stenosis could potentially be. The right arm systolic blood pressure is 179. The left arm systolic blood pressure is 104. There's 75 millimeters of mercury pressure between both arms. Well, perfect. Let's look at the subclavian artery on the right. Velocities are standard subclavian artery velocities. On the left side, you see that there's some spectral broadening, but there's a loss of the diastolic component, so very high resistance. That means that distal to where this image was obtained, there's an area of stenosis. Well, you say, well, where is it? Where could it be? Let's look at the vertebrals. The right vertebral waveform is normal, okay? Left vertebral waveform is also essentially normal. There's no evidence of steal. So we know that the stenosis within the subclavian artery is distal to the takeoff of the subclavian. So it could be distal to the takeoff of the vertebral, sorry. So that stenosis could be somewhere in the mid to distal subclavian or perhaps in the axillary artery segment. So by looking at the waveforms are essentially telling you the stenosis is just, don't look at the vertebral, it's going to be further downstream within the subclavian artery. And this is extremely valuable because it kind of gives you an idea of where else to image. Remember, this wasn't an upper extremity arteriogram, this was an extracranial ultrasound, not sorry, arteriogram, ultrasound. So the extracranial study can potentially prompt you to get a more dedicated extremity ultrasound to delineate the area of stenosis if the patient has symptoms. This here is a great case. Common carotid artery is occluded. You can see it here. It's occluded. There's no flow. There's chronic thrombus and all that. The external carotid artery, the proximal external carotid artery, you see there's some high resistance waveforms. Okay, there's either a reversal in late diastole or a reversal in early systole. It's hard for me to tell here. I don't have all the images here. Just an example. But look at the proximal internal carotid artery and on the distal internal carotid artery. You see in the distal internal carotid artery, flow is a mix between retrograde systolic flow and antegrade diastolic flow. And then the proximal ICA is completely reversed, high resistance. So the ICA is feeding my external carotid artery. So flow is reversed in the ICA going to the external. Here may be a good idea to get a TCD to look and see what's happening in the brain. Well, let's look at what's happening in the vertebral. So here we have the brachiocephalic artery, or brachiocephalic trunk on the right side. Okay, you see the subclavian artery. This is a patient who had a dissection. That's why you see kind of these almost multiple peaks up here. The right subclavian artery, the flow is significantly dampened. So there's a stenosis between the brachiocephalic trunk and the subclavian artery, and very likely involving the origin of that carotid. That's why the carotid is occluded. And look at the vertebral. Flow is reversed here. So the vertebral is essentially supplying down the arm. This is great. This is a great case. This is a patient who came in with some neurological changes, and the patient gets a carotid ultrasound. Let's look at, before looking at the CT, let's look at the ultrasound. The external carotid artery shows, high resistance waveforms typical of the external carotid artery. And then here what we see as labels as the internal carotid artery proximally, waveforms are a little bit high resistance. Okay, this is almost at the level of the bulb. And they're not the classic ICA waveforms. Again, here, even though we have a diastolic component, we still have the peak systolic rise, a quick systolic deceleration, not necessarily to baseline by close enough. And as we go distal, this waveform looks more like a high resistance external carotid waveform. So this prompted us to get a CT scan to really identify the internal carotid and see if it was really open or we were just getting an image of something else. And here what we see is the internal carotid artery is occluded. There's some calcification. There's the external carotid artery here, and what's coming off of it is the ascending pharyngeal that we are tracing up. So these waveforms are actually the waveforms that we're picking up of the ascending pharyngeal that is going parallel to the common carotid. So this is the external. This is the ascending pharyngeal. This is the common carotid going up, and this is occluded. And what the ultrasonographer is doing with a lot of effort actually is incredibly picking up the ascending pharyngeal, which is there, and that can throw anybody off because it was just in the same plane right in parallel. So what happened here is the waveform that we should be expecting, a low resistance waveform in the internal carotid artery, was not seen. And if it was a significant stenosis, we should have expected a staccato waveform or hardly any diastolic component. We didn't see either of that, and this was more consistent with an external carotid artery waveform, and that's why the CT scan was done, and that is your proof right there, the ascending pharyngeal. This here is this calcification, and there's the occluded internal carotid artery. Right there, internal carotid artery is occluded, ascending pharyngeal is that little blimp, and that's your external carotid artery. Here's another example. Again, this is a patient with a carotid subclavian artery bypass. This is the waveforms of the proximal anastomosis. This is the waveform of the distal anastomosis. You see high resistance waveform, spectral broadening, elevated velocities in the 280s. Okay, that's a carotid subclavian bypass on the right side. Let's look at the left vertebral. The left vertebral is normal. We expect low resistance waveforms. What happened to the right vertebral? Slight delay in systolic rise, early systolic deceleration, and a mid to late systolic antegrade flow. This is almost a pre-steal waveform, okay? So that tells us this carotid subclavian bypass certainly is not providing enough flow to the subclavian artery, and there's definitely a significant stenosis at the distal anastomosis to the subclavian segment, okay? This is what we talked about earlier as opposed to bifurions. You see two systolic peaks. This is different from the patients with intra-aortic balloon pump, which we're going to see. So you got to sort of have a little bit of piece of a history. So these two systolic peaks, in some young patients, it could be just a normal finding, okay? But when you see two systolic peaks per cardiac cycle, 50% of the patients with aortic regurgitation or aortic stenosis with regurgitation can potentially exhibit this. And this we actually saw in patients, in a patient who had presented with syncope and had some significant aortic stenosis that was being worked up. And this is what we see, that two peaks. That is different from the two peaks that you see with an intra-aortic balloon pump. The first peak is it's systole, then you have a return to baseline, and then the balloon pump inflates. That's your second peak. And then when the balloon pump deflates, you have that reversal in diastolic flow. This is a patient with cardiogenic shock with an Impella device, with a left ventricular assist device. What you see is that the waveforms are dampened throughout. They look almost like venous waveforms. The difference between that and venous waveforms is one, they're antegrade, and the velocities are really higher than the venous waveforms, and you have at least some semblance of pulsatility or pulsatile flow. This is great. This is a patient with intra-aortic balloon pump and heart failure. So you see two things. The two peaks of the intra-aortic balloon pump, well, the peaks of the heart beating, first systole, intra-aortic balloon pump peak, and then the reversal of flow at the end of diastole, okay? But then you also see the dampening of the waveforms throughout as a result of the patient's significant heart failure. What do we see with atrial fibrillation? The longer the diastolic component or diastolic filling, the following waveform will be a higher velocity. The shorter the diastolic filling time, the lower the peak velocity. That's because the heart doesn't have enough time to fill up and get you that push of blood that you need. Here we see 1, 2, 3 peaks here and there. When you see this kind of confusion, what I call this kind of, the waveforms are just kind of confused in a way. This is kind of mind mnemonic in a way. You start thinking, wow, is there a dissection there? What I could see here is there's a chronic dissection. You see a chronic flap up here. You see flow into lumens. So that's for the extracranial. And now, I think this sets up the tone for what high and low resistance velocities are. Let's look at venous waveforms. So what we expect with the venous waveform is some phasicity with respirations below the baseline. Here's a little bit of augmentation, maybe a little, kissing the baseline here, but this is essentially normal, spontaneous, and phasic flow. Again, normal, spontaneous, phasic flow. Augmentation here, you're squeezing the calf, for example, or the thigh, and you see the increased acceleration, and then just a quick return to baseline. What happens here, this is different. This left side is normal. You see spontaneous phasic flow, some augmentation. But this patient here, these are two different patients, by the way. Here, what you see is this kind of sawtooth appearance, okay? Where you have, reversal of flow, and there's above and below the baseline. And what you think about seeing these waveforms in the lower extremity, because this is different from the upper extremity. In the lower extremity, you start thinking of pulsatile flow, and you think about fluid overload or right-sided cardiac dysfunction, whether it's diastolic dysfunction, pulmonary hypertension, anything that affects the right side heart function. Here, again, this now is the same patient. Left leg waveforms, pulsatile waveforms. This is an elderly patient. Pulsatile waveforms could be fluid overload, could be right side diastolic dysfunction. That's great. Well, I should expect to see the same thing on the right side, but I don't. What this tells me is that there's a venous outflow obstruction within that that iliac vein on the right side. Compare right side versus the left side. I should expect to see both. So here there's either a DVT, a stenosis, or something at the iliac vein component. Again, same story. Right side, you see this flow. And so by chance, these are, we're seeing a lot of sick patients with heart conditions and so forth, but, the right side is sort of, there's some form of phasicity. Left side, completely flat waveform, no phasicity, you know that there's an iliac vein stenosis or occlusion. And that's something that, that should prompt you to look at this. Here, what we see is, one, we see disturbed flow, okay? What we see is this sort of pulsatility, and you look at the velocity. So it's very small AV fistula within that common femoral vein. We see a lot of these, the patients come in with some either growing pain or something after a particular intervention or a femoral line or catheterization, etc. And sometimes we see this. This is an example of valvular reflux, okay, where the flow is normal under, it's a normal venous flow, and then it reverses with Valsalva and so forth, okay? And again, here you augment, you squeeze the leg or the calf or the thigh, you get increased, you accelerate the flow, and then you get that valve that doesn't work, and you get the reversal of flow, and then it returns to baseline. What do we see here? This is a patient with a popliteal, with a venous ultrasound for leg swelling, and we're looking at the waveforms. As we're getting down the leg, the popliteal waveforms start to look a little bit arterialized, and there with some disturbance of flow. So you're thinking at this point, this is not a normal venous waveform, unlike the waveform that's seen up in the leg, right? And you see this sort of pulsatility to it and some disturbance of flow. You look at the artery, and what you see here at the arterial segment, you have this sort of very turbulent arterialized arteriovenous flow within the popliteal artery. You know that there's an AV fistula between the popliteal artery and a vein. Let's look at the upper extremity. Upper extremity, you see sort of this sawtooth appearance that in the lower extremity, that gives us the impression of fluid overload or right-sided cardiac dysfunction. In the upper extremities or neck, the venous flow is a little bit different, because this typical appearance of pulsatile flow is because there's forward flow into the atrium that causes a sharp increase in blood flow velocity that decreases as the atrium fills. And then as the blood flow then will reverse as the ventricle contracts and some of the blood in the atrium can flow retrograde. So if we don't see this sort of variability in the upper extremities, then you start to think that there's a problem. Here's the jugular vein. You don't see that kind of sawtooth appearance or that kind of fluctuation. So you know that between that segment of jugular vein and the heart, there is an area of stenosis or occlusion centrally. Again, look at the right side. You see some variability. Look at the left side. The variability is almost gone. So we start thinking here that maybe some thoracic outlet syndrome or thoracic outlet obstruction of that vein. Could be a stenosis, could be an occlusion, could be something. Because there is some phasicity here, you see the waveform, I doubt that that's an occlusion. It may be a significant stenosis or, again, thoracic outlet syndrome. This is a patient, venous ultrasound, cephalic vein. You see the disturbance of the color flow, and you see the disturbance here of the venar flow. So you know that there is, this flow is arterialized. The velocities are about 40 here. They're elevated for veins, for a venous segment, and you start thinking, well, maybe there's an arteriovenous fistula somewhere in there from a previous peripheral IV that got the artery or something, okay? Here on the other side, on the other hand, you see some fluctuations in velocities, almost like, you want to think, is there arteriovenous flow here? But what happens here is, look at the velocities. Velocities are very low. So I really doubt that this is an arteriovenous waveform. This is just more, just play with the knobs, adjust them a little bit, and you might be able to kind of see this as what it is, just a normal venous waveform. Arterial waveforms, now we're going to start looking at the periphery and the arms. We're going to just briefly review. You have the peak systolic rise, reverse diastolic flow, and forward diastolic flow. Those are the three components, or the triphasic classic waveform. Okay, let's look at the upper extremity. We've gone over this already. The subclavian, again, you have a narrow range of the spectrum of systole. You have reverse of diastolic flow, and then you have the forward diastolic flow. Look at this other subclavian. There's hardly no forward diastolic flow. There's a lot of turbulent flow. The velocities are high. You know that this is an area of stenosis, okay? Other clues, again, for stenosis, you see aliasing, increasing the peak systolic velocity, turbulent flow with filling of the spectral window. Again, more of those examples. The waveforms are telling you it's a normal waveform. This is a sort of a much higher resistance waveform with a lot of turbulence flow, increased velocities, and so forth. Let's look at this waveform, this clue here. The patient had a blood pressure of 108 on the right arm, 203 on the left arm. And let's look at the proximal mid and proximal subclavian artery, mid subclavian artery, and this is the proximal brachial, not axillary, but the brachial artery. So we're looking at the flow here, and you see that the significant broadening of within the spectrum and the reversal of diastolic flow without any significant antegrade flow here. It's just very flat. So that tells you there's definitely a significant subclavian artery stenosis here. And now let's look at some physiologic waveforms. This is the upper arms. You know, you see that triphasic waveforms are present, and these are the waveforms at the digits. This is a normal exam. And what I have here is the different provocative maneuvers, and we're looking for thoracic outlet. Well, this is a normal exam. Well, let's look at a non-normal exam. Forget about this screen. Let's look at this screen. The waveforms are normal. So you know there's not significant arterial occlusive disease in both upper extremities. But in the military position and with the head tilted, you see that the waveforms at the digit change. Okay? That's in both arms. So here's evidence of thoracic outlet obstruction of the artery. Well, could this be at the first rib clavicle junction? It could be. Could be at the pectoralis minor insertion, potentially. You know, there's this pectoralis minor syndrome. But what this tells you, it gives you a clue that where the obstruction could potentially be, it's certainly at the thoracic outlet on both sides. Here, there's a patient with inherent ulnar artery disease. Okay, great. Well, is this what's causing the patient's symptoms, or is the fact that with provocative maneuvers, there is decreased flow? So the patient could have ulnar artery disease, but maybe the symptoms are not due to this. Here, what you want to chase is not necessarily the ulnar artery. You want to chase the thoracic outlet compression of that subclavian artery on the right side. Again, this is a patient that, you know, getting prepared for AV fistula creation. You see here, by compressing the radial ulnar artery and here releasing the radial artery, you don't have enough flow within the palmar arch. That means that this hand, here when we release the ulnar artery, flow at the digits becomes triphasic, right? So what this tells you here is that the arch is certainly dependent on the ulnar artery, okay? And whether the arch is complete or not, it's hard to tell, but now you see here, well, that's another clue, the distal radial artery, there's no flow. So the distal radial artery is occluded, and flow to the hand is really dependent on the ulnar artery, okay? And this gives you many clues. One clue is, well, if that flow to the hand doesn't depend on the radial artery, you want to create an arteriovenous fistula, you can make a wide anastomosis to that radial artery. You're not going to affect the flow to the hand whatsoever. You just kind of improve the flow to that fistula. So this study gives you a lot of clues, okay? This is a patient with severe in-stent subclavian artery stenosis. You see that significant amount of turbulent flow and high velocities, etc. You can call it whatever it is. But distal to the stent, you see the dampening of the velocities of the waveforms, okay? So this tells you that this is a very significant stenosis. And then the digits are not being well perfused. So once you fix this problem, everything else should improve. Again, there are patients with intra-aortic balloon pumps, and we saw how that affects the lower extremity arterial waveforms. Well, it also affects the upper extremity waveforms. You see systole, intra-aortic balloon pump inflation, reversal of flow at the end of diastole with balloon pump deflation. Again, here's the to and fro flow. This is a pseudoaneurysm that we were able to detect. So when you see this kind of waveforms, you know, you got to look for that pseudoaneurysm. You can see it here. This is the pseudoaneurysm. This is clot. This is patent lumen. Now let's look at the lower extremity arterial. Again, we discussed shape of the waveform. Right common femoral artery waveform, triphasic, up, reverse flow, integrate flow. Left common femoral artery. Wow, this is monophasic. It's just a quick up and down with delayed systolic upstroke. What's happening? Well, this gives you a clue. Where's the stenosis? Is it in the aorta? No. Is it in the right iliac? No. It's definitely left iliac system. There is a stenosis that's decreasing the flow to the left common femoral artery. Same thing. Right side, common femoral artery, waveforms versus the left. Definitely there's an inflow stenosis here that's involving the iliac artery. Here, both sides are dampened. Well, what's happening here? Either There's bilateral severe iliac artery stenosis, aortic stenosis or disease, or the patient could potentially have cardiac failure, and this is what we're seeing, dampened waveforms. Again, waveforms tell us a great story. Here's the anterior tibial artery. You have sort of waveforms that are showing a little bit of high resistance. In the distal anterior tibial artery, there's super high resistance. You barely see any diastolic components, almost a staccato waveform. Then we look at the physiologic study, dorsalis pedis artery. What happened? The flow is reversed. This is real. So the distal anterior tibial artery is either completely occluded or there's a severe stenosis because the flow is reversed in the dorsalis pedis on that side. Here, what we're looking at here is the left superficial femoral artery proximally. And look at the proximal segment. You know, peak systolic rise, high resistance, no diastolic component, and then we start seeing a diastolic component in the mid segment. And then in the distal segment, you see the waveforms are significantly dampened. So between this proximal and mid segment, there's certainly a severe stenosis because you see the diastolic component returns here. And there's no diastolic component here. So we have to be here a little more aggressive in looking at the stenosis, or that you know that there's a stenosis. You may at this point decide, well, great, there's evidence of stenosis. Let's go ahead and get other forms of imaging. Again, this is a patient on ECMO. I have a few more slides. So there's a patient on ECMO. Okay, they have a sort of the almost venous appearing waveforms, but we see the common femoral artery. There's arterial waveforms that you see the peak systolic rise. There's occlusion of the SFA proximally, and then it reconstitutes distally. Okay. And here's a patient with peripheral arterial disease, tibial disease. We know the rest of the vessels are normal, and here the goal is to focus on the tibial arteries. And here you see the reversal of flow in the dorsalis pedis. And here what you see is almost mild to normal range for the ABIs on the left, but the waveform morphology tells you no, that's not true. They're calcified arteries because the waveform morphology does not match that ABI. Okay? And here's another example, turbulent waveforms within the proximal, just proximal to the stent. So before you get into the stent in the SFA, you have a lot of turbulence, a lot of evidence of spectral broadening here. And then as we get to the stent, we have some high resistance waveforms, and then you have these dampened waveforms distal to the stent. So that tells you there's a stent stenosis, and you can see that distally, the physiologic waveforms do show you that sort of dampening of the waveforms and decreased distal perfusion. Again, here's another example, staccato waveforms. So these waveforms occur proximal to an area of severe stenosis or occlusion. Distal or past the area of severe stenosis or occlusion, you have the tardos parvus waveforms, which are dampened waveforms. And as we go more distally, you see that the waveforms are dampened. So between this image and that image, there's a significant stenosis. Thank you very much. And again, please sign up to our YouTube channel and share our videos and our channel with your colleagues.
Thank you,
Zsolt.
Joe. I have a quick question for you. Just came from an anonymous source again. When do you usually request a provocative maneuver to check for thoracic outlet syndrome?
So normally we base our studies, the request of our studies on patient symptoms, okay? If a patient tells you I'm having heaviness of the arm or numbness of my hand, you see that there are some decrease or changes in coloration of the hand, or they start developing for arterial stuff, for arterial symptoms, claudication, they're writing and their hand gets tired, or somebody who's cooking, and let's say bakers, they're starting to cook and they're mixing the batter, their arm gets tired, or people who play sports, baseball, or they do a lot of swimming, they feel like their arm gets tired. You start thinking, well, is it arterial, is it venous? Venous usually are going to be associated with some swelling, some blue hue to the hand, and so forth. If you're thinking about neurological thoracic outlet, you're going to have some thinning of the thenar and the hypothenar compartment, some tingling, numbness, etc. But the arterial, you really get this claudication, this aching, throbbing pain, and then you start also doing the physical exam. You check for a palpable pulse, and then with arm elevation, you start looking for decreasing that pulse. But I think the study that gives you a lot of clues is this. Because, you know, if you're suspicious and you're getting changes in the PPGs and the digit waveforms, then that gives you a clue that there is a thoracic outlet. And again, the thoracic outlet goes first rib clavicle junction, and it's also considered the pectoralis minor insertion because, as we know, there's something called pectoralis minor syndrome.
Thank you, sir.
Pleasure.
This ends our block, and we are not going to have 15 minutes break. We're going to have a 5 minutes quick break, and we'll continue with Karen Broadbent and vascular ultrasound in oncology. Hello back. Hello everybody. Thank you for joining us our last session, and thank you for spending your Saturday with us. The next talk, I would like to introduce Karen Broadbent. We worked together for a few years, and Karen now switched hospitals. We miss you, Karen. But Karen is really taught me a lot about vascular ultrasound, and I think her experience really made her a really special sonographer over at MD Anderson. And we really wanted to learn from you, what do you see on your vascular ultrasound in oncology cases, because we don't see them too much, but I think really specifically we wanted to learn to be able to recognize if we run into one or another.
Well, I'm so glad to help, and thank you very much for inviting me. I'm really happy to be back here. Unfortunately, I have a job because cancer and cancer treatments are really hard on the vascular system. So there's a couple of things that we see that probably not a lot of people see. We see a lot of, well, you guys all see DVT, but we see DVT that are really crazy. We see a lot of tumor thrombus. We see carotid body tumors. We see a lot of abdominal and retroperitoneal tumors. So I've got some pre and post-op tumor resection cases to show you. And we also do a lot of preoperative port placement studies, which are very interesting. So patients with cancer and cancer survivors are at increased risk for vascular disease for several reasons. There's new therapies and innovative surgical techniques that are leading to decreasing mortality and better 5-year survival rates in our patients. New cancer therapies, including the targeted therapies and also immunotherapies, are associated with metabolic complications that affect the vascular system. Cancer itself serves as a risk factor for vascular disease by altering the way our blood clots. So our cancer patients are at higher risk for both arterial and venous thromboembolic events. And then there's common modifiable and genetic risk factors that predispose patients to both malignancies and to cardiovascular disease. And some of those are obesity, hyperlipidemia, and smoking. So here's a list of just some of the things that cancer therapy can do to the vascular system. And you can see it's a really long list. Thromboembolism, coronary vasospasm, pulmonary and systemic hypertension, and the list goes on and on. So unfortunately, we have a lot of work. So I can't really talk about how a vascular lab works in a cancer setting unless I tell you what our vascular surgeons do. There are 2 vascular surgeons at MD Anderson, and their primary role is to resect tumors that are close to or affecting blood vessels. So we see a lot of angiosarcoma, which is really rare, and leiomyosarcomas, which both originate in blood vessels. We see a lot of locally advanced tumors that encase or invade vessels, and some of those are the sarcomas, the renal cell carcinoma, pancreatic cancer, and some of the head and neck cases also. Our vascular surgeons also help out for vascular emergencies during other surgeries, and they're always there for bleeding or if there's arterial or venous thrombosis during a case, and also to assist with vascular exposure. They do a lot of ports. We do a lot of lines, as you can imagine, at MD Anderson. And then that's on top of the management of pre-existing vascular disease and newly diagnosed vascular disease when patients come to MD Anderson. So now you know what we do in our lab. Our practice follows what the vascular surgeons do. So we see the age-related vascular disease that everybody else does, but we also see cancer-related conditions related to their treatments. We see disease-related conditions that are related to vessel compression, vessel invasion, and then we see cancer that propagates into a vein, and that's called tumor thrombus. And we see a lot of DVT. So speaking of DVT, the risk of venous thromboembolism is 5 to 7 times higher in patients with cancer. And it's particularly highest in patients with non-Hodgkin's lymphoma, the GI malignancies, lung, brain, ovarian, and pancreatic cancer. If a patient has a DVT at diagnosis or within the first year of treatment, it's a much worse prognosis. The risk for thromboembolism is higher in patients that have really aggressive cancer, patients that have metastatic cancer, short survival times, and who have other chronic comorbidities. And then tumor thrombus, we often see with the hepatocellular cancers, the renal cell, lung, pancreatic, and the sarcomas. So in patients with cancer, when they have a DVT, we tend to see a larger clot burden. That means we see more thrombus in these patients. We see higher rates of upper extremity DVT, probably because all the lines that we have. And we see higher rates of iliocaval thrombus and higher rates of bilateral DVT. So this is a patient who's a 68-year-old female with metastatic lung cancer. And she had iliofemoral, popliteal, tibial DVT, and then she developed a PE on Lovenox. So a lot of clot burden in this patient. So sometimes a DVT isn't a DVT. Sometimes a DVT is something much worse. This is a tumor thrombus in a 43-year-old woman who had a fibular osteosarcoma. The original site again was in the fibula. And this DVT was diagnosed in 2017. We didn't see her back for a couple of years, and when we did, this is what we saw. And you'll see a very unusual echo pattern here. It's almost like there's some areas of calcification throughout this thrombus. And then you can see that there's a lot of color flow in this bottom picture. When you have a tumor thrombus, you should always be able to track it back to something outside of the vein. And that's what you're seeing here. This is a soft tissue metastatic implant. And then this is the common femoral and the great saphenous. So we see a lot of, quite a few of these. So this is a 73-year-old male, male patient with renal cell carcinoma. I'm going to choke here. Pardon me.
I'm sorry.
And he's got significant tumor thrombus in the left renal vein. And this is the IVC that's completely thrombosed. Excuse me, you can see that.
Just take a break and get some more water. I don't want you to.
I know,
Please,
I think I'm getting choked,
yes.
sorry.
We just will wait.
I'm better.
Yes, please.
I'm better.
Yes, thank you.
So again, you can see the tumor thrombus in the left renal vein. This is a really good picture. And the IVC is completely filled with the tumor. The aorta and the left renal artery are just below this. So you can also see that the leading edge of this tumor thrombus is almost up to the right atrium. So this patient was successfully resected, and our surgeon did a primary closure of the IVC, and it's pretty amazing that they could save this. So when trying to, there's really not good criteria to differentiate a tumor thrombus from a bland thrombus. But as I said, usually the tumor thrombus is going to be continuous with something outside of the vein, either a lymph node or a subcutaneous implant or the primary tumor. The lumens of these tumor thrombuses tend to be greatly dilated and greatly expanded. And there's very abnormal arterial vascularity in a tumor thrombus. These also tend not to improve with time, unlike a bland thrombus, which you expect to recanalize or at least partially recanalize. So at MD Anderson, we see a lot of carotid artery disease, a lot of really significant carotid artery disease. Radiation treatment causes acceleration of the atherosclerotic process in the arteries, especially superficial arteries. It damages the endothelium and also the vasa vasorum. It's a late complication after radiation therapy, and the stroke risk doubles in these patients. We do screening pre and post radiation, and then the follow-up is based on the disease that we find initially. These patients are managed very aggressively medically, and intervention on these patients is controversial and it's very complex because of the risk of infection and the poor healing in the very fibrotic tissue that occurs in the necks. Tumor involvement is very rare in the carotid arteries, but this is, or especially in the arteries, but this is an exception that you see on the screen. This common carotid artery is actually compressed by a tumor. It's a papillary thyroid cancer, excuse me, and it completely encased the common and had to be resected with the tumor. So this common was reconstructed with the saphenous vein. This patient was lost to follow-up, but we know that it was patent for at least 4 years after her surgery. So these are difficult. If you've ever scanned somebody who's had radiation in their neck, you'll know that these are very difficult scans because the tissue is very woody, it becomes very fibrotic, and it's difficult to maintain skin contact with the probe. You lose the posterior window when the tissue is really hard like this, and also the sternocleidomastoid is sometimes resected during these head and neck cases. So that posterior window is almost impossible to get. The patient might also be unable to turn their head or deflex their neck. They might also have a trach, so the common carotid is going to be very difficult to interrogate. So in post-radiation patients in the carotid arteries, we see a lot of common carotid stenosis, very significant stenoses. We see more diffuse disease, we see circumferential stenoses, long segments of stenoses, younger patients, and the plaque has a lower echogenicity, so we don't tend to see a lot of the heavily calcified plaque like you do in a non-radiation patient. So I've got a couple cases I can show you, just a couple of images. This is a mid-common carotid artery, and you can see the very narrow lumen here. And this is a 69-year-old male who has squamous cell carcinoma in his mouth. This is 10 years post-op, or post-radiation. So a very significant disease here with a peak systolic of 480. Another patient, 51 years old, he had radiation twice, once in '91 for lymphoma, and then in 2012 for his squamous cell carcinoma. And this is a transverse view, and you can see the lumen here, and then this is the lumen in the distal common. Significant color flow disturbance, and the velocities were 260. So this is the circumferential stenosis I was telling you guys about. This is the ICA and the ECA. So the lumen is here, and it's completely concentric, which is pretty unusual in a plaque. This is a 61-year-old male who had cancer in his larynx. This is a sagittal view of the same thing, and velocities were in the 300s, almost 400 centimeters per second. And these are real common stenoses for us to see. So here's another patient who's got a significant internal carotid artery stenosis, and she's also got a proximal common carotid artery stenosis, which changes everything. So this is long segment stenosis and diffuse disease in this patient. This is not a typographical error. This is a 35-year-old female patient with papillary thyroid cancer who was treated with surgery and radiation in 2012. And she has a greater than 70% stenosis in her internal carotid artery. The peak systolic velocity is 300, almost 340 centimeters per second. So not unusual. This is the youngest patient I've ever seen with this degree of stenosis. Use a lot of gel on these patients. These are just a few scanning tips for you guys. Don't be afraid to get your curved probe out for better skin contact. The resolution isn't as good, but at least you can get the images that you need. sometimes use the higher frequency probe. We have an L18 that sometimes we'll use, but the color isn't quite as good on the L18. If a patient has a trach, a lot of times they can take their appliance out. So ask the patient if it's possible to remove it. Some can and some are not able to. But be careful with the gel. Positioning is important. These patients can't lay flat. They might not be able to turn their head to the side. So you're going to have to put them on a pillow. Perigangliomas are very rare neuroendocrine tumors, and when they occur in the head and neck, one of the most common forms is a carotid body tumor. These are most often seen in women. They present between ages of 40 and 50. They may be familial. Sometimes they're bilateral, and they're very slow growing. They usually present as a non-tender neck mass. They might be pulsatile, and they significantly splay the carotid bifurcation. They're very vascular. Usually they're fed by branches of the ECA. And we worry about them because when they encase the carotids, they're very difficult to resect. So this is an image of a 64-year-old male patient with a carotid body tumor that partially encases the left ICA. And this tumor was, this is the internal and the external. This was resected without any kind of carotid reconstruction. You can see that these tumors are usually fairly homogeneous, and they're pretty well delineated. You can see the borders pretty well. So these are the long axis views of the internal and the external. And you can see the branches of the external. Some of the branches are feeding this tumor. So this is a 44-year-old male with a carotid body tumor that completely encases the internal and the external. He has not been treated yet. He's an international patient, so he'll be back at the end of the year for treatment. This is going to be very difficult to resect. So this is a 54-year-old female with a carotid body tumor that encased the ECA and half of the ICA. Well, the ECA had to be ligated because it's completely encased, but the ICA was preserved, thank goodness. And this was again resected without any issues. And when we see these carotid body tumors, we try to measure normal internal carotid artery distal to the tumor because it helps in the surgical planning if the patients know that we can, if the doctors know that we can see that. So the Champlin classification describes carotid body tumors by the degree of encasement. And type 3 is 360 degrees of encasement or complete encasement of both of the vessels. So we always do a bilateral scan with these because, as I said, they can be bilateral, and it's important to know about the flow on the contralateral side. The normally high resistant ECA might be low resistant on a carotid body tumor because of the branches of the vessel that feed the tumor itself. And again, we try to see normal ICA distal to the tumor. So when our surgeons resect tumors, it's usually a multidisciplinary case. There's usually 3 or 4 surgeons in on these. And before they resect something that's close to the blood vessels, we often are able to do a preoperative scan to help with the surgical planning. And some of the patients that we see most often are the patients with the sarcomas in their abdomen and pelvis and the extremities, and the germ cell tumors. Germ cell is a form of testicular cancer. So why do we do it? We do it, again, to help with preoperative planning. We look to confirm vessel patency. Oftentimes on a CT, it's difficult to tell if the veins are patent or not. And we can often help with the duplex exam. We often find undiagnosed DVT because the tumors often compress the veins. So below that, sometimes we'll find asymptomatic thrombus. We do saphenous vein mapping if we anticipate arterial reconstruction in the extremities. And this also serves as a baseline for our post-op scans. So I've got some images of patients that we've actually scanned. This is a 35-year-old woman with Ewing sarcoma in her left groin. and it's completely encased the profunda femoral artery. This is profunda and superficial femoral. So this was successfully reconstructed when they resected the tumor. They had to remove part of the common femoral artery and the common femoral vein. And both of these were reconstructed with PTFE graft. It's a synthetic graft. And when we saw her 4 months after the surgery, the vein graft and the arterial graft were both patent. And she had no leg swelling. So this is a 40-year-old male who has testicular cancer. It's metastatic. And this is a large tumor in his neck. And it abuts the common carotid artery, which is what you can see here. And this is a transverse view of the tumor, the common, and the subclavian is completely encased in this mass. We could also see that the origin of the vertebral artery was encased in the tumor, and the vertebral is here, and this is subclavian. So this tumor was resected. It did go into his mediastinum, so it was a really big surgery. The subclavian was reconstructed with a carotid to distal subclavian artery bypass graft. And when we saw him about 6 weeks after his surgery, the graft was beautiful. So this is a 22-year-old college student who has a left pelvic leiomyosarcomas. And the leiomyosarcomas tend to originate inside the vessels. This is from 2015, and we saw him after he had chemotherapy and radiation. So the preoperative duplex showed that the left external iliac vein was encased, completely compressed, or almost completely compressing the left external iliac vein. And on CT, we weren't able to determine if this vein was in fact patent. You can see that the external iliac artery abuts the tumor, and it's just anterior to the mass. So he was successfully resected, this tumor, and the external iliac vein was reconstructed with synthetic graft, they harvested the femoral vein from the same leg. And that sounds pretty radical, but the patients do pretty well after femoral vein harvest. They have pre-significant swelling for about 3 months, and after that, they do very well. This young man came back in the past summer, July of a year ago, and the graft was patent. He had also had a patch angioplasty of his external iliac artery, and that too was patent. So this is another young man with testicular cancer. He had a large retroperitoneal lymph node, and you can see it here on the CT. And we were able to see the same thing with our ultrasound scan. And this is the common iliac artery, and the IVC is compressed just below that. So as I said, we have a lot of lines at MD Anderson, and our vascular surgeons place a lot of ports. Most of the patients that we do preoperative duplex on are patients with lymphoma, breast cancer, head and neck cancers, patients who've had previous ports or previous lines, patients with history of neck radiation, and history of DVT. These studies are usually bilateral. They're limited exams. We look at the internal jugular, the distal innominate, the subclavian, and the axillary vein. And we convert to a full study if we find a DVT, and we often do. So what's useful about these exams? Well, is the vein patent? We often find undiagnosed DVT. And that's what you see here. This is an internal jugular vein that's completely occluded, and it's surrounded by these large metastatic lymph nodes. And the subclavian vein was also occluded on this patient. We often find chronic DVT, we find vein compression, and sometimes the abnormal Doppler signals that we get in the patent veins tell us that there might be something going on in the more central innominate veins or in the superior vena cava. We also find unusual anatomy. Sometimes the central jugular is very tortuous or angulated, and then sometimes just small caliber of the veins. So this is a 68-year-old male patient who has acute myeloblastic leukemia, and he needs a central vein for a central venous catheter for a stem cell transplant. And he has a history of a left arm DVT and PE. He had a right arm PICC placed in March, and they were unable to perform a catheter exchange. So when we did our preoperative port placement scan, we could see this subclavian vein is thrombosed all the way up to the confluence with the jugular vein. And this is also, again, not an unusual finding. The axillary vein was also thrombosed, and you can see the distal innominate here, and this is the external jugular, with the internal jugular coming in here. So this patient was able to have his right internal jugular catheter placed. We often find that the central internal jugular vein is completely occluded chronically, but the mid to distal vessel looks great, and that's what you see here. This is the internal jugular vein that's nicely compressible, but when you go central, which is what you see on the right-hand side of the screen, this is completely occluded, and you can see how narrow that vessel comes here. And the distal or the mid to distal jugular drains into big collaterals, and you can see that in a transverse view. So this is that same patient that had that the big teratoma in his neck, the young guy with testicular cancer, and this tumor almost completely compressed the internal jugular vein. So we see a lot of the compression of the veins. And this is a very significant flow disturbance that you would see in a compressed vein. So we see a lot of catheter-related DVT. And what you see on the screen is thrombus on a central venous catheter in the subclavian vein. And this is treated like a DVT, even if you don't see DVT in the rest of the lumen. And this is a 65-year-old woman with metastatic pancreatic cancer. And this was a preoperative port placement study. So this is a young woman who had a port placed in May, and she's got desmoid fibromatosis in her buttock and her leg. And she called her doctor's office in the morning, and she said, the vein on the side of my neck is sticking out, and I feel pressure on both sides of my neck. So she came in, and we find this isolated innominate vein thrombus around the catheter, and that's pretty unusual. But we see lots of very unusual clots in unusual locations. And again, we see this is another example of thrombus on a catheter. This is an axillary vein, and so you have to, when you're looking at veins with lines, you've got to look at those lines pretty carefully because they're often coated with thrombus. If it's significant, you need to report it. So that's just some of the unusual things that we do at MD Anderson. I hope this helps people if you come across some of these unusual findings or pathologies. And thank you very much for your time and attention. Thanks for having me.
Thank you, Karen. Thank you so much. And please post your questions on the Zoom chat room or the Q&A part. And with Karen, we are still watching and ready for more questions and happy to answer them. Next, I can see Dr. Peden is ready for us. Dr. Peden, you are the top gun for AVF. Please teach us how to do a proper AVF study and what are the pitfalls, what we're missing, most often missing, or one of those big boo-boos that we shouldn't do.
All right, good morning. Can you guys see my slides?
Make sure you are not muted because we can hear you.
Let's see. I am not muted.
Beautiful. We can hear you well. Thank you, sir.
You can hear me. Okay, great. All right. All right. Can you see my slides? Okay.
Yeah. Just go to presentation mode, please.
Do you need this
Awesome.
How about there? All right. Even an old dog, huh? All right, great. Let's see. I'm just trying to shrink down that Zoom thing. Hang on one sec. Let me just shrink that puppy down. All right. Is that better?
Come with
Still
you
hear me, Zsolt?
because Esther and the guys are.
Zsolt, you still hear me?
Yes. Yes.
Okay,
Looks
great.
good.
All right. So yeah, thanks for the invitation. I'm Eric Peden. I'm one of the vascular surgeons here at Houston Methodist. We're forlorn and missing Karen Broadman terribly, especially after that great presentation. But with such awesome cases, it's easy to see how she's having a great time at MD Anderson and helping out people. So good to see you, Karen, and great talk. I have lots of disclosures, always looking for more. So anybody with industry, feel free to reach out to us. So I'm not sure any of them really salient to this talk though. So in dialysis access, the question is kind of like, how hard could this possibly be, right? I mean, these are pretty superficial structures. These aren't cancer patients like what Karen's been telling us about. There's usually not tumors and all kinds of stuff in the way, thank goodness. Movement should be pretty controlled, right? We're not looking at the heart or deep in the belly usually or anything like that. You can see it, you can feel it, you can touch it, which is kind of cool. Plenty of gel in the warmer, it's entry level stuff, right? But in fact, no, I think many times it gives people terrors because if you're really going to go and do a good thorough study, it requires some thought, some knowledge about it, and some real effort on your part. And there are lots of challenges, right? So challenges are that these are pretty sickly people. Unfortunately, they're kind of unhappy people. And I would say, if your heart doesn't go out to dialysis patients, then you're almost heartless because just imagine that like half of your life is spent with somebody stabbing monster needles into your arm, leg, neck, wherever, 3 days a week, and just hours at a time getting that done. Really, really tough existence. And you've essentially exhausted your social network, right? Your friends and family can only take you to the hospital and dialysis units and ERs and such so many times and doctor visits, etc. And that's really challenging. So kind of take a pause when the patients seem cranky because they're having a rough day, and every day is a rough day for them. The anatomy is abnormal, and people ask me, why do these things go bad? Well, it's like, well, we're not made this way, right? If our blood vessels were supposed to be connected together in these weird ways, we'd be born that way, and we're not. And once we start reconnecting stuff, it becomes pretty funny to look at. And there are lots of positive findings, right? These are not your negative 5-minute DVT studies from the ER. These are patients that almost certainly have something abnormal that you're going to find. So why are we doing this study today, right? And I think that's really one of the questions you got to talk to yourself about in terms of thinking about what you're going to do for that. And I think in general, sort of some categories of we're doing preoperative imaging, which is really crucial. We're trying to figure out about maturation process, right? Because kind of like unruly teenagers, these fistulas and grafts tend not to mature so smoothly. And I'm experiencing that at home myself now with two teenage girls. And then figuring out problems, right? Because dialysis is all about problems, just problems, and then some more problems. If fistulas look like this would be a really short talk, right? We made a little incision at the wrist, big, beautiful vein plumps up, looks like it could be easily accessed with needles. Like how in the world could anything go wrong with this? But in fact, it still can. Because you have other things, right? You have crisscrossy stuff, you have grafts here, grafts there, fistulas all around, and that makes it a little more tricky. Thinking about anatomy, I think it's really important that you kind of think about, especially with the newer technologies that are out, is the perforator anatomy and how these vessels come together in the forearm. So the thing that we usually call the forearm cephalic vein, anatomically, if you look at Netter and many of the early kind of landmark anatomy books, it's actually the median antebrachial vein. As that courses up from the arm, from the wrist, from the radial side of the wrist, and then it comes to the elbow, it's usually going to meet two veins, right? It's going to meet the median cephalic vein, that's going to go up to the upper arm cephalic vein, and the median cubital vein, it's going to go up to the upper arm basilic vein. And then there's the perforator that really connects right into this sort of junction area of all these veins. It almost looks like it rises from the deep veins up to the superficial, which in fact it many times does. And then important as well to kind of appreciate the nerves that are in this area, especially when you're doing the surgeries in these spots, because damage to these nerves, in particular the lateral antebrachiocutaneous nerve that's right around the cephalic vein, and the medial antebrachiocutaneous nerve that's right around the basilic vein, are really important structures that commonly get stretched or injured or whatnot and lead to little sensory changes, etc. that can be really irritating to patients. And to be able to explain that to them, I think, is many times very satisfying to them and reassuring. So Mike Silva is the guy who really kind of led off the kicker for vein mapping or vessel mapping for dialysis access. And this is now over 20 years old, but the numbers still stand. And these are still things that we quote to people, right? So that for a fistula, we'd really like for veins to be 2.5 millimeters or greater. For grafts, we'd really like to have a 4 millimeter or greater vein. And for arteries, in particular, we're talking about probably radial arteries or distal arteries for 2 millimeters or greater. And obviously watching out for central venous stenosis, seriously calcified arteries, and then pressure gradients between the arms. And that's really important. And also patent palmar arch. So I think it is important as you're doing the mapping to note what's occluded in the arm already. For you to do a mapping and not comment on the fact that there's like 3 grafts and a big thrombosed fistula and partially occluded aneurysms all over the place, that really is a disservice to the people that are going to look at that report. And there are many people who are just going to look at that report alone and not actually examine the images or maybe even look at the patient till the day of, particularly now in the days of all these patients getting virtual visits prior to their scheduled surgeries. Many times the first time we're physically seeing them is actually in the pre-op area. You kind of hate to be surprised by lots of things. So if there's lots of occluded grafts, just kind of comment on that, right? That there's an occluded graft in the forearm, there's a partially thrombosed pseudoaneurysm of the cephalic vein, wherever, et cetera, et cetera. And those things are really helpful on the report. So bilateral blood pressure, yes, bilateral, really important, right? Because we want to know about arterial disease. Looking for significant arterial disease, especially calcified, right? So vessels that are calcified and are essentially non-pulsatile and non-compressible, that's important to note because that's probably not a vessel that the surgical team wants to take on in terms of clamping, sewing to, et cetera. And knowing about that in advance, in addition to just a peak systolic velocity, really helpful to them. Superficial vein size and quality, well, that's really the low hanging fruit, right? And that's the thing that we really want to know about, in particular for planning our fistulas. But without a good artery, that may not go so well. Deep vein status, quite important, particularly if somebody's had upper arm grafts. If they've had upper arm grafts that are sewn all the way up to the axilla and there's no other patent vein there and that vein's occluded, that would be important to note because that's going to be kind of a nasty surprise to think you're going to be able to put in a new upper arm graft and then have that not be feasible. Central vein status, especially inferred, sort of like Karen was showing, with looking at waveforms to reflect what's going on more centrally. That's really important to know about. And Allen's test, I got to say, I've kind of come full circle on this. Although as part of the initial description by Dr. Silva, we really hadn't done that in our labs for a long time. But now I've had a number of patients that have gone and gotten a great radius phallic fistula and then wound up with terrible steel because in fact they were radial dependent. And knowing that, really important. There's multiple different ways you can do that, whether that's with a pulse ox probe or a PPG on the finger. And we really just want to know that the ulnar artery is patent and feeds the hand, because usually if it's one of those 2 arteries that we're going to use, it's going to be the radial artery. And if we're going to take that out of circulation, we really need to know that the ulnar is okay. And in terms of new stuff, percutaneous fistulas are here. Now, they're not meeting quite the adoption that people had thought they would, but they're still here and they're still growing and that's still going. And the mapping now needs to include information about the perforator vein, what the proximal arterial calcification is going to look like, in particular the proximal radial artery and ulnar artery, and then what the deep vein sizes are, because that's the way these things are done. So there's 2 real systems that are out now. These are both approved and are available on the market and are probably being used in your areas. The Wavelink is the one that was invented here locally by Billy Cohn, who's next door at Texas Heart Institute and has made several devices, quite an ingenuitive cardiovascular surgeon. And this device is done, it's the one with magnets. If you kind of hear about the magnet one, it's driven by fluoroscopy and magnets. And it's basically one catheter in the artery and then one catheter in the vein. And the 2 things line up and are opposed by the using magnets. And then there's an electrode that uses essentially electrocautery and cut mode to cut a connection in between the nearby deep artery and deep vein, and then flows directed through the deep system and through the perforator up into the superficial veins. And that again is why that perforator is so important to know about. Ellipsis is an ultrasound-driven device, which is a single puncture, usually through the cephalic vein right at where the perforator is coming up, and then tracks down to where the perforator vein goes down and joins the radial veins, which really almost seem to terminate into this perforator vein. As the radial veins, as they come up the forearm, seem to go directly there. And almost always there's an area close by between the perforator vein and the radial artery that can be then traversed with a needle, a wires pass through there, and then this device is kind of cupped around there and sealed, and a channel is cut between the two and then ballooned for maturation. So here's just a clip of looking at the antecubital area and where this perforator is. I'm just going to play this, and as we do, just kind of watch how that does. So if we're looking at the median cephalic vein here, and then we're watching for where that perforator right there goes down and joins right by the radial artery. We'll just let that play back and forth a little bit. It's that connection in between and knowing where that vein goes. So as we're watching that come up and then split down there, that perforator goes and goes right down by there. There's sort of a confluence between the ulnar and radial veins as that comes together. And again, really important to know what that looks like because we need that perforator vein to be present. We need the superficial veins where it goes to be present, and for that to be nearby a vessel that's reasonable size and not heavily calcified, because both of those devices don't do too well with calcification. And then the surgeons that you're doing these for are very visual creatures, I can just almost promise you. And for them to see a drawing with the diameters on there, incredibly helpful to us when we really enjoy looking at this kind of drawing, because it really gives us a great sense of where things are at and lets you draw in extra branches or whatever else you might see, sclerotic valves, etc. That might be really helpful. This good, not quite as good. This is what we kind of shifted to because of the reporting software that we use and can be followed up and down. But again, that drawing, crazy helpful. And then we want something like this, right? Because we really want to know about what are the deep structures looking like in terms of the deep veins. We want to know like the blood pressures that I was talking about, and then seeing what those are looking like. And of course, the prelim reports and the descriptions that you put in are incredibly helpful, right? Because if there's lots of plaque, like is noted here, or severe calcification, we really want to have that information. And vessel mapping's had a huge impact. If we look at the time course when this was done and then the studies that were subsequently published afterwards, what we can see is that the percentage of fistulas went up considerably. The prevalence of fistula use, meaning how many patients are actually getting dialysis with fistulas compared to catheters or grafts, has dramatically increased, and fistula failure has generally gone down. And this is kind of an example of that, right? So here's a nice little fistula. You can't really tell what it is, but it's an unusual fistula. It's an ulnar basilic fistula, and that was really determined based on the mapping, right? In fact, these are the days early on where the techs were convinced I had no idea what they were talking about and actually put X's in lines, so I just almost couldn't miss it. It's like following the rainbow to the honeypot of gold. And in that case, it was easy to make the incision right over the spot and directly connect that, which then goes on to be a nice fistula. The forearm basilic vein is one that's commonly missed and left behind. Important to look for this, I would say, and is one of the ones that many times people don't look for. But seeing this on the back of the forearm really helpful because, in fact, many times that's a vein that's not been used or punctured or IV'd or anything else. A nice long incision, get the vein out, drag it across the front of the arm, then you can usually have a nice fistula that can mature quite well. Unfortunately, long incisions in the arms heal well. So then we say, why are we doing this study? And it's, again, not just for billing or patient care, but put the problems of what the patient's having on the report. I think it's incredibly helpful. And again, this is one of the things that Dan Parker used to say. This is why it's not vascular lab technicians, it's vascular lab technologists, right? So it's knowledge that's going into this and thinking about the patients and really being a part of the care team and investigating it, not just kind of blindly doing what you were told to do, right? You're not just back there to do a duplex, you're back there to help solve a problem. So what problems are they having, right? Is it maturation, infiltration? They got steel, aneurysms, who knows? So our prelims look something like this at the top on the reports. We'll say why we're doing the fistula, what the fistula is, what recent procedures have been done on this, and incredibly helpful. Because if you have a practice anywhere like mine, one, God love you, two, oh my goodness, but three is it's hard to keep all these patients straight and their different problems, etc. So for somebody to reiterate some of the troubles for you, incredibly helpful. So Victoria, thank you on this report for doing that. So moving along, maturation, right? Maturations and punctures. So 666, the rule of the double, right? So it should be 6 millimeters in size because that's what grafts are and that's what people have been used to sticking for a long time. It should be less than 6 millimeters from the skin. That's important because if it's really deep, that makes it a challenge, and we'll talk about that more. And then it should be flowing at 600 cc's per minute. And these are the numbers that still stick, and there are other published series, but this is really a good set of numbers to have in your head. Easy to remember, obviously. And then just really helpful because it is kind of a good standard. I think at the end of the day, you got to say to yourself, though, could you stick needles in this thing? And that means without your ultrasound, because there are incredibly few dialysis centers around the country that have ultrasound units in them. And almost always, these are people that are many times not nurses or dialysis technicians that have had a fairly remedial, limited training that are putting the needles into these veins. And that's a challenge for them because they're doing it a lot. The king and queen of maturation, the two really important things are what's the flow, the volume flow going through there, right? In cc's per minute, and what size is this thing? Unfortunately, not considered always are depth and tortuosity, which are things that you can really help everybody determine, because many times people put the hand on there and say, yep, got a good thrill, start sticking. But in fact, you with your trusty ultrasound know this thing is fairly deep, it's quite tortuous, and it's going to be challenging for anybody to get a needle into this thing and do good dialysis. So here's a radiocephalic fistula that we're looking at. And if we watch this fistula, it's got aneurysmal segments and it's just kind of dancing side to side. And you can see how we're having problems following that with the probe as we sweep the probe straight up the arm. And that can be a real trick. And then marking things on the screen or marking things on the skin can be really helpful in terms of letting people know where this fistula is at and how to access it best. So again, crazy helpful. And then as we look at this is what we'd like to see as it's fairly superficial, but again, this sort of side-to-side movement thing makes it fairly challenging. And many times marking this on the skin to say, where should this be stuck, can be something that convert this from a really hard stick to something that's much easier to stick. And having the patient take a picture of that with their smartphone or device can be really helpful. So too deep, yeah, that's a problem, right? Because if it's deeper than it is big, then it's too deep, or maybe not big enough. But there are solutions to this, right? One of the things that we like to do now is a lipectomy procedure. So we call it a superficialization, that we're moving the vein. That's just because we don't want to be rude and say we're cutting out a lot of fat. But in fact, what we're doing is we're actually cutting out fat overlying the fistula. It's nice that way because it leaves the fistula intact in its same vascular bed, doesn't disrupt the fistula at all. We don't have to cut it apart and put it back together again. So it can be less traumatic to the fistula, which is nice. Not always the case, but this is commonly what we'll do for patients that have a cephalic fistula that needs to be superficialized. And that works out pretty well. We'll erase some skin flaps. We'll dissect free the fistula so we can see it, and then take out big lumps of fat over the top of it. Usually we'll close that up with a drain. It works in really big arms as well, which can be really helpful, and then suddenly makes these really stickable fistulas. In this case, we put X marks the spots on where to try and stick these things based on where this is got its straighter segments. Because this is what's more and more commonly done, is full-on transpositions with big long axial incisions. Problem with that is it's going against the tension of the skin. The skin widen, break down, not heal well, etc., which can be kind of a real challenge. So aneurysms are a real thing, especially now with the prevalence of fistulas. Many of these fistulas do tend to break down and have aneurysmal changes, and some of these can be really scary, especially these ones with a scab. These ones with a scab, especially like that one on the right side, this is one you probably really hate to see needles in at dialysis for one thing, and you hate for this person to leave the vascular lab because heaven forbid that scab comes off. That's a real issue. But don't just document that there's aneurysms, help us figure out why there's aneurysms, right? And it's usually a few things that are going on, right? Needle sick, well, that's for sure, right? No vein likes to be needled that much. But usually there's a high flow component to this that's making that thing dilate. And then almost always some sort of outflow obstructive lesion that's increasing the pressure in there and making it dilate. So looking at that is really important. And bad things can happen. I mean, pretty regularly, one of these things bursts, pops loose. And if this happens at night or when this person's alone, they can exsanguinate from this, right? You can see this person's had a stitch placed and then sent away from wherever they're at. That's a dangerous thing. And it looks like that one at the bottom is sort of healing, but that one at the top is pretty dangerous. And this is what happens when they come to the ER. It can be just like something really from a horror flick with serious bleeding all over the place. See ones like this is not one to send out of the vascular lab. This is one to say, wow, this person probably needs to be admitted before something really tragic happens. Because when it goes, it really goes. And you look at this, you're like, it's a little scab. Is it really that bad? But if you look closely, I mean, that scab is just like ready to pop, which is just spooky. And that little thin cap with little scabby stuff on top is the only thing separating the air, the walls, and the floor from about 2 liters per minute of blood flow, which obviously is not going to take a long time. And one of the more causative lesions for causing this, because most of these are brachiocephalic fistulas that have the troubles, one of the most causative lesions is the cephalic arch, or the cephalic axillary confluence, where a cephalic vein has to go down and pierce through the clavicular pectoral fascia to join the axillary vein just medial to the pec minor. And that's one of the more common areas, for whatever reason, that people get recurrent stenoses. And there's different postulated mechanisms for this. One is the external compression from the ligament that's around there. One is that there's a valve there and then it's making a turn. And it's probably a combination of all of those things. Plus the rest of the vein is dilating. That area really is fixed and can't dilate too well. Plus the valve annulus on the inside makes that sort of a fixed lesion. And that becomes just a real common problem. And we'll see it here, right? We'll see really tight lesions as we transition from the cephalic vein down the axillary vein. You can see the axillary artery beside it. And that's a real challenge. Here's a different thing. So the guy sent in with swollen arm. You're like, okay, well, it doesn't look so good. And yeah, it's a big arm, but in fact, it's quite a bit bigger than the other side. So what in the world's happening and why, right? Is it terrible text? Just kind of happens. That's part of being on dialysis, kind of get used to it. Well, dig into it a little bit, right? And if you look at it, you're like, oh my goodness, this is a big old pseudoaneurysm. Well, your color box will tell you that, right? And your color box fortunately tells you it's just hematoma around it, not a big pseudoaneurysm. See color flow just within the fistula, not outside. And if you look at it, this is a really deep fistula, right? So this thing's nearly an inch deep. Well, that's a pretty deep fistula. And if we talk about the deeper than it is big, then that doesn't hit that ratio. And then basically for the dialysis techs and nurses, it's kind of like one of these things. They're just kind of launching dialysis needles in this arm, hoping to hit this thing. Sometimes they do, sometimes they don't. Sometimes it's good and sometimes it's not so good. But you can help figure this out, right? And keep that guy smiling. So by commenting on the fact that the fistula is quite deep, that it's deeper than it is big, then that might prompt some revisions because, you know, it's tough. It's tough for them to hit those things. So steel is one of the more vexing troubles. It's the most common reason that practitioners in dialysis get sued is because of steel. And it's under recognition and under treatment and then permanent disability that can happen. So looking at steel is really important, kind of acknowledging that and then kind of dig down to the problems and come up with solutions, really important. And a lot of steel and its steel treatment options are based on the volume flow, right? So how much flow is going through this thing? That's really crucial when you're doing your steel study. You want to confirm with digital amplitude changes with compression that it is in fact steel, because people can have hand symptoms for lots of other reasons that may not be steel. So your PPG on the finger, compression of the fistula and the access away from the anastomosis. You're not compressing the actual arterial inflow. And then in our lab, we use a doubling. You want to see a doubling of the waveform amplitude to confirm that it's steel by vascular lab study criteria. Looking for arterial disease, really important. So bilateral blood pressure and a good arterial duplex, looking for lesions, because those things are quite common. You say, whoa, hang on a second, bilateral arm blood pressures? Like over the fistula or grafts? Surely that's not what he just said. But yes, that's what I said, right? Let me just say it again. So bilateral arm blood pressures and a good arterial duplex. So can you do this? Short answer is yes. Should you do this? The long answer is yes. So we've studied it, and although it gives you a lot of trepidation to say you're going to do this, we went back and looked at over 200 patients that had steel studies with bilateral arm blood pressure measurements and no acute occlusions. Now, does this mean that they should just routinely go and have their blood pressure monitored there, or stick art lines, have their blood drawn, etc.? No. Should you leave the blood pressure cuff up for half an hour just to see what happens? No. But for you to take a blood pressure over the axis is okay. Fistulas, grafts, both, because the cuff is up for a very short period of time. And it can give you insight to proximal arterial disease. So yes, it is okay to take the blood pressure as a diagnostic study over the axis. You don't want this, right? This is one of the most tragic things that can happen to dialysis patients is they wind up with severe ischemia that leaves them with a contracted claw-like hand that is completely unfunctional. Maybe even worse is something like this, right? So this poor guy, you can tell, is still using the access on the side where he's lost his hand. Tragic outcome in dialysis. You can see there's obviously kind of a complicated guy. And in fact, to show his complications is to look at his other side and see that, in fact, he's got missing digits on the other hand. And almost certainly, if you looked at this guy's feet, you would not be able to count 10 toes. And you even wonder about being able to count both legs. Because people that have this severe of arterial of steel that leads to limb loss almost certainly have significant arterial intrinsic disease. So as it all comes down to it, I would say volume flow, volume flow, volume flow. If you're doing a dialysis access study, almost no matter why you're doing that study, you want to give a volume flow, because that is the thing that the whole point of having access in your arm is, right? That there's adequate flow inside a vessel that they can put needles into and provide adequate flow to give them good dialysis, because this is their lifeline to staying alive and getting good dialysis, right? And a lot of that is dependent on the volume flow. And at the end of the day, if the volume flow is good, it almost doesn't even matter what else is going on, because if it's able to deliver enough blood to get into and out of that dialysis machine and clean the person's system, it's probably doing its job. One thing I'd say that's frequently not included in dialysis access studies and really should be is a good 2D transverse sweep from the anastomosis up to the next joint. So if that's in the forearm, that means from the radial cephalic anastomosis up to the antecubital area to see where that thing drains into. If it's an upper arm fistula, then from that anastomosis up to the cephalic arch, up to the confluence of the basilic with the brachial vein and axillary vein and deep veins. If it's a graft, sweeping from the arterial anastomosis up to the venous anastomosis, even if it means going down, up, back of the arm again, really incredibly helpful, because that shows you which areas are tortuous, shows you which areas are deep, shows you where the aneurysmal segments are, and shows you the stuff in between. Really important. So I think as well, one of the things is when you see a stenosis, not just to say greater than 50%, less than 50%, because not all stenoses are the same, right? So for most of these, we're fairly stingy. We say it's not just a 2-to-1, particularly at the venous anastomosis, right? So the AV anastomosis in the fistula and the graft of vein anastomosis in the graft. We're looking for a ratio of 3. But, you know, if it's a ratio of 2 in the mid body of this thing, or 2.1, that may be viewed upon differently than if it's a ratio of 7 or 8 or something more severe. So reporting on that ratio can be really helpful and lead people to say whether or not they should treat lesions that right now don't seem to be so symptomatic. And be systematic as you're doing these studies, right? It standardizes things, simplifies it, and I think makes the study easier for you to do and more meaningful to the person who's trying to interpret it. And if all else fails, ask the patient what's wrong, right? Because many times the patient knows the real deal. Now, sometimes they have no idea because they just go to dialysis, close their eyes, grit their teeth, and hope for the best, and then are happy to make it out of there alive. But, you know, many times the patients are in tune with what's going on, can tell you, hey, you know, the machine's alarming, or they can't stick this part, or there's actually a lump on the back, or it's these 3 fingers. But talking to the patients is really important, right? Because you're part of the team that's trying to figure out what's going on with these people and what we do to make them better and help their life out. And that's it. Thank you very much.
If you don't mind, can you stay on a little bit, because I have a few questions. If you open up your QA session or the chat room, first question, is it okay to take a BP over a hero graft as well?
Yes.
Yes.
As a diagnostic study, right? So I'm not saying go get your blood pressure routinely monitored over your hero graft, but yes, you can put the cuff up and down and measure the systolic pressure in that arm that's got the hero graft in it.
Very good. I saw a moment ago lots of questions, but this is the only question I see. Anybody else, any questions for Dr. Peden before I let him go? Okay. Sir, thank you so much again. I think AVF is still one of our least favorite study at the moment. So thank you for teaching how to do it better. Thank you, thank you. And finally, I would like to introduce Christopher Chartoneau, the vascular chief over at HCA. Christopher was my roommate when he was a research fellow. This is why we are still connected, and we have a certain love for carotid dissection. So Christopher, please teach us about carotid dissections.
Thank you so much, Zsolt. Can everyone hear me?
Yes, you're good to go.
I'm going to share my screen.
We can see it.
All right. So I'm Christopher Charlton-Ow. I'm a vascular surgeon, and it's been really great to see some old friends, Zsolt, Dr. Lumsden, Dr. Peden. Dr. Garami was generous enough to share his office with me almost 15 years ago when I first came to Houston. So anyway, it's been great. I have no disclosures relevant to this talk, but I do have some other disclosures. All right, so we'll get right into things. The updated dissection classification was just published this year. I was on the panel that helped create it, and it's a little bit different. And I'm talking about aortic dissection, even though you may not be imaging directly the aorta, it does make a difference because now, even though there's a dissection, there may be a dissection in the ascending aorta. Really, what the new classification is based on is where the entry tear is. So we could have a type B dissection still with a tear through the arch. And that's something that's changed. And this is because people are closing these with thoracic endografts, even though there's a tear in the ascending aorta, which in the old classification used to be considered a type A dissection and would go straight to ascending aortic replacement. But these kind of things, so it almost doesn't matter where the tear is. What matters more is where the entry tear. All right, and these entry tears can be quite, I mean, these aortic dissections can be quite complicated. They don't just kind of tear along a linear fashion. We saw some imaging of dissections in some of the other talks, but these dissections often spiral down and they can dissect into the brachiocephalic arteries. And this is where kind of our talk comes in. Here's a type A dissection case. This is one of my patients. You can see there's a tear in the aorta here. You can see this is the ascending aorta. Here's the descending thoracic aorta, and you can see a very small compressed true lumen and a very large false lumen there. And of course, this person was taken by an ambulance. You can see the tear in the dissected aortic arch, and unfortunately, in the ambulance on the way to the emergency room, he developed left hemiparesis. And when we look at the CT scan on his admission, we can see that all three of his brachiocephalic arteries have a dissection. This is not his case, but this is what the dissection looks like in person in the operating room. You can see this is the ascending aorta, so the head is to the top left of the screen. The heart is in the bottom right of the screen. So that's the tubular portion of the ascending aorta, which has been opened surgically while he's on pump. And you can see that dissection flap right there and how thin the remaining wall of the ascending aorta is when half of the aortic wall, the intima and media are torn away into that flap. This is what a dissected artery looks like transversely. These happen to be vertebral arteries, but it kind of goes, I mean, we've opened plenty of dissected arteries, and you can see acutely in the false lumen, there can be flow or there can be thrombus, as in this case. And it's this thrombus here which can be thromboembolic in nature. Interestingly enough, in these chronic dissections, it's very rare to see any thromboembolization, and this has implications for the future. But look at all this thrombotic, potentially thrombotic material, which could embolize if there's a second exit to this dissection. I'm going to play a little video. This is intravascular ultrasound. The catheter is in the descending thoracic aorta. You're going to see me placing it upwards. That little branch right there was the carotid artery. This is the Now you're going to see that's the innominate vein, and you're going to see three brachiocephalic arteries exit off of the aorta, and right distal to the subclavian aorta, you're going to see this dissection flap. You can see it has potentially some thrombus in it, but you can see it's partially thrombosed. That's the echogenic material in the false lumen. The catheter's in the true lumen. It's very compressed. And you can see there's going to form almost 3 layers, and then it's going to form almost this circumferential tear around the aorta. This person presented with mesenteric ischemia, and we ended up putting in an endograft. But this is what the aorta looks like with intravascular ultrasound. And it really isn't going to be that much different when you look at the aorta externally as well. And this is the abdominal portion of the aorta, and you're going to see That's the superior mesenteric artery. There's the renal artery. That's the left renal vein passing over. So these are very characteristic images. We see this quite commonly in our intravascular ultrasounds, which I do pretty much for every dissection case if we have to treat it. From the dissection, what you sometimes may see in the carotid arteries is echogenic material within the lumen. And at first, this may look like an acute occlusion, but really what it is just potentially thrombosed false lumen. So you can see in the image here on the left, it's labeled ICA. You can see a little bit of echogenic material in the lumen. ECA looks normal. What we see is a thrombosed false lumen, and you can see flow in the true lumen. We looked at these ultrasound findings several years ago, and what we found out was there were several characteristic findings in the dissection. We've had a couple of talks now on normal ultrasounds for carotid duplex ultrasound, so I won't go over it, but essentially you should see low resistance waveforms. In the internal carotid artery, you'll see a mixed pattern in the common. But one of the things what we've learned to do sometimes is to use the curved probe to potentially look at some proximal brachiocephalic arteries, and we can see the dissection flap there extending from the aorta into the innominate artery. Again, I think Dr. Noam showed some images of a dissection. This is very characteristic of us to see this hyperechoic flap in the artery. And this is very useful to point out, and I'll tell you why, because the treatment is very different when you see stenoses or occlusions from dissection versus atherosclerotic plaque. And so it's very important for us to sort of figure out, just like what Dr. Peden was saying, we're not just here to say, okay, there's a stenosis, but actually what is that stenosis from? Because the treatment is very, very different. One of the most common findings, and again, Dr. Noam pointed this out when he talked about a aortic stenosis or aortic regurgitation. Sometimes you can see this notching in the systolic waveform. I think this is probably the most common thing that we find in acute dissections. Sometimes this lessens in chronic dissections, and I'm not exactly sure why, but this is kind of anecdotal. I'm not sure why I see it, but I see it. One of the other things we see is this kind of abnormal notching and intermittent reversal of flow. This is typically seen with a thrombosed false lumen. We also see this a very jagged systolic upstroke as well. And you can also see a very delayed systolic upstroke in the initial part of the waveform. These are characteristic findings. You don't always see all of them, but you very often see at least some of them. So finding one of these abnormal things should prompt you to kind of take a step back and say, wait a minute, maybe I need to look proximally, maybe I need to look distally. Do I see the flap on grayscale? And sometimes you see some of these abnormal waveforms distal to the problem, so you may not see the problem in the internal carotid artery. It's very common. It's much more common to have common carotid artery dissection without the flap extending into the internal carotid artery. Sometimes you can see all of these things kind of mixed together. So you can see this kind of notching, but you also see a little bit of delays to solve upstroke. So you see a lot of things all happening together. So in summary, some of the ultrasound findings which we'll see is an echogenic dissection flap, a differential true and false lumen flow patterns, a second pulsed waveform or notching after the initial systolic upstroke. And, sometimes the velocities may or may not really tell you much about what's going on. So it's really important to look at the waveforms itself. And it's really important to look on the grayscale to see if you see that. Now, all of these things I think are really important, because if you do see a stenosis and you do see, okay, there's velocities of 500 centimeters per second, it's real easy for us to sort of say, okay, let's do an endarterectomy or carotid stent. But really, your diagnosis of what's causing that increased velocity is very, very, very different. Is very important for us as clinicians, because what we found is that although dissection often acute dissection can often be a cause of stroke, really what we haven't seen is that these dissections in a chronic nature, even though the velocities are elevated, we see very few strokes in chronic dissections, even untreated. And we looked at this and we published this a few years ago. We looked at patients who had brachiocephalic artery dissections. We called it CCAD, common carotid artery dissection. We looked at these patients compared with our non-dissected aortic arch dissection patients. And basically, I'll just focus your attention on the stroke on admission. You can see that the carotid artery was almost more than double the stroke rate compared to the non-dissected patients. But what was interesting about the studies, when we looked at these patients long term, there really wasn't a big difference. So essentially, acute dissection can be a cause of stroke, but we really, even untreated, and these are patients who never had that carotid dissection treated, we really just did not see a lot of new strokes in that patient population. We had actually one stroke, but it was in the opposite side of the artery that was dissected. The caveat to this is that 88% of the patients with carotid artery dissection were sent out on aspirin. And there was a trial that was published a couple of years ago called the CADIS trial. It was mostly a UK study, and it was mostly done in patients without aortic arch dissection, but had just spontaneous, isolated, common carotid artery dissection. And it showed that aspirin alone was useful for 6 months with or without anticoagulation on top of it. So antiplatelet agents really formed the basis of treatment of carotid dissection. And interesting, I didn't have time to put it on our slide, but this week I just got consulted for a patient with elevated velocities after open heart surgery. We kind of came to see the patient. Yep, the ultrasound done as an inpatient looked like elevated velocities to something in the 490s centimeters per second. But when we got the CT angiogram of the neck, what we saw was isolated and focal carotid bulb dissection. And we just decided not to treat that person with surgery, but with antiplatelet medicines instead. And we kind of published this, I guess, wow, it goes back 2013. Doesn't seem like that far away, but really what we found in our data was that very few patients present with stroke after carotid artery dissection if they're treated. I think I've successfully got us back on time. So thank you very much for your attention, and I really appreciate the invite, and I also really appreciate the being able to see all my friends like Dr. Peden and Dr. Garami. Looks like he's driving home now. Anyway, thank you very much, everyone.
Thank you, Christopher. Thank you for everybody's logging in and joining us today. Stay safe and see you guys next year.